Hello and welcome everyone to the 2022 Targeted Therapies Patient Forum. I'm Akash Desai and I'm delighted to co-chair this event with Dr. Isabel Prishigo from Memorial Sloan Kettering Cancer Center. At GRACE, our aim is to improve overall medical care for cancer patients by democratizing a critical and cutting-edge information on optimal cancer management and providing it directly to patients. Proving that the principle that the barriers between information for physicians and education for patients could be overcome, GRACE covers a broad range of topics spanning different cancers. At this Targeted Therapies Patient Forum, presented by GRACE, we bring you the top oncologists in their field presenting the most current and emerging information in targeted therapies and answering patient questions in real time. Myself and my co-chair, Dr. Prishigul, are very excited for today's event, which features some of the best thoracic oncologists in the nation. Some housekeeping points. Please post your questions through the Q&A button. We will take questions during the panel discussion and the Q&A session after the three presentations for the first session. However, we will continue to take questions on the portal as and when you post them. So feel free to post questions as you think of them, and we will do our best to answer all of them. Without further ado, I will start by introducing my co-chair, Dr. Prishigul, and next, the first speaker of the event. Dr. Prishigul is an assistant attending on the Thoracic Medical Oncology Service at Memorial Sloan Kettering Cancer Center. Her main research focus is on predictive prognostic biomarkers for response to immunotherapy and targeted therapies. She has a passion for patient advocacy, education, and identifying and addressing healthcare disparities. She serves as an active representative on the ethics committee at the Memorial Sloan Kettering Cancer Center and is a co-chair of the Lung Cancer Research Foundation Education and Engagement Committee, as well as the program moderator for the LCRF's monthly Together Separately Done webinars. Dr. Prishigo.
Thank you so much. I have the honor of introducing Dr. Desai to you, who is a third-year hematology oncology fellow at the Mayo Clinic in Rochester, New York. His professional interests include evidence-based in oncology, clinical trials, drug development, cancer care quality, and healthcare delivery, with a special focus on thoracic oncology. He is also one of the founding members of the Grassroots Consortium focused on COVID-19 in cancer patients, now known as the COVID-19 and Cancer Consortium. He has won numerous awards already for his work on thoracic malignancies, including an ASCO YIA, a World Lung Early Career Award, and an Education Award from ESMO. He was also the Patient Education Ambassador for GRACE from 2021 to 2022.
Thank you, Dr. Prishigo, for the kind introduction. And so now I will kick off the meeting by introducing our first speaker, Dr. Fred Hirsch, who will be talking about genetic testing in lung cancer. I think Dr. Hirsch needs no introduction to people who already work in the field. He's the executive director at the Center for Thoracic Oncology at Tisch Cancer Institute in Mount Sinai. He's also the associate director for biomarker discovery at the Tisch Cancer Institute. He's a well-renowned researcher who has moved the field forward through his outstanding contributions. Dr. Hirsch, thank you for joining us today.
Thank you very much to everyone, and thanks for the invitation to be a part of this event. I'm very excited to talk with patients and patients' families, particularly these two groups have, of course, close to my heart, and I will try my best to make some complex issues understandable for everyone. I have some disclosures. As probably everyone knows, we have seen an amazing progress in treatment outcome for non-small cell lung cancer, particularly here advanced disease over the last 2 decades. When I came to United States from Copenhagen in Denmark, year 2000, that was the situation here with an overall survival of 11 months. And today, this is probably outdated already, but we can see here we have gone through an amazing progress. We started to talk about histology, then we came to maintenance therapy, then we came to molecular targeted therapies, and then more recently immunotherapy. Everything has contributed to this very encouraging progress in outcome. Here again, we started just focusing on histologic subtypes, what we can see in the microscope. Then we now moved to molecular subtypes and genomic subtypes. We also know that molecular characterization of the tumor is important for most of the patients with advanced lung cancer. I will come back to this. We know that patients who receive targeted therapy do much, much better than chemotherapy patients. But for having a targeted therapy, you need to have a molecular target. So that is a reason why it is important to have the molecular characterization. Today, more than 50% of patients with advanced non-squamous lung cancer, non-small cell lung cancer, have what we call the driver mutation, which is targetable either with an already FDA-approved agent or developed agents in clinical trial. And this pie chart here is growing almost as we speak. Month to month, we see new potential targets in lung cancer and new drug opportunities. This is standard of care for the molecular targeted patient population today. And we can see here we are talking about EGFR mutation, ALK, ROS, BRAF, NTRK, RET, MET, but we are dealing with many more in clinical trials. But what is also important to note with this slide is that today we have approved drugs not only in the first line, but we have several generations of molecular targeted therapies, which give us then the potential to sequence therapy, and hopefully that can make lung cancer going into a chronic disease and a curable disease. How do we do molecular characterization of the patient's tumor? Well, most of us will use today next generation sequencing. That is a fast, cost-effective, and less tissue required platform, and we can see many genes, mutations, and many more. I will come back to that during my talk. Previously, before that, we talked about FISH, immunohistochemistry, PCR, other platforms where we did single studies for single abnormalities. But again, next generation sequencing, we capture a lot of abnormalities on the same time using relative small amount of tissue. Well, next generation sequencing is a broad term. Within the term, we have small panels, we have larger panels, and it differs from institution to institution, or I will say vendor to vendor, whether we need to use smaller panel or larger panel. But comprehensive genomic profiling covers a large number of genes and mutations. Do we know that next generation sequencing lead to changes? Well, we learned that many years ago. This is data already back to 2014, and from study there showed that 28% of patients received different therapy than initial recommended before next-gen sequencing was performed. So in other words, next-generation sequencing, or NGS as we used to call it, can really change the way we are treating lung cancer patients today. When I come to United States, to University of Colorado, I was tasked to look into EGFR, epidermal growth factor, in preneoplasia, in bronchial dysplasia. And me and my group, we demonstrated this picture here. You see here the lining of the bronchi. We called it epithelium of the bronchi. And we can see here that EGFR expression, which is the brown surrounding of the cells, we can see that this increased with increased changes in the bronchial lining, which learned us that EGFR is an important factor in the cancer development. A lot of clinical trials follow this with EGFR TKIs, tyrosine kinase inhibitor. Me and my group in Colorado, we had an opportunity after several years to look into long-term survivors from this EGFR TKI, in this case, gefitinib or Iressa. And astonishing data came out. We got access to, it was called the Expanded Access Program for Iressa, and we digged up around 200 patients who had a median treatment duration of 11 years, and 86% of them lived 10 years out. We could not dream finding 200 patients with this result. Of course, they are selected, they are all long-term survivors, but the fact that you could have patients with advanced lung cancer based with a targeted therapy with this treatment result, that was, in my opinion, revolutionary. We have learned about different generation of EGFR targeted therapies. Flora was a study comparing osimertinib, which is a third generation EGFR TKI, and compared it with first or second generation. And we can see clearly that the survival curve here is much better with osimertinib than with the first and second generation EGFR TKI, which of course led to osimertinib as the first choice for 15-20% of the patients who have EGFR mutation in the tumor. No, at that time we said either the patient are EGFR positive or EGFR negative. We had two groups. Today we have learned that EGFR mutations are not one entity either. Within the group of EGFR mutation, we can have several types of mutation. Some of them are sensitive to the current therapy. Some of them are more insensitive. But here we can see different mutations, and I will talk about several of them. We have also learned that when the patient progress on either first or second generation EGFR treatment or third generation EGFR treatment, in this case, third generation, as I mentioned, osimertinib, we see several other mutations potentially coming up and several pathway, we call them pathway, which means that during the treatment, new activated biological pathways has appeared. Is that good or bad? Well, we don't know, but the good thing with it is that we have developed treatment which target specifically many of those so-called resistant mechanisms. Most recently, we have learned about a drug called Amivantinab, and lazertinib is a fourth generation EGFR TKI, and Amivantinab is a drug which targets both EGFR and MET. MET is one of the resistant mechanisms for EGFR treatment. So, of course, if we can if we can treat the tumor which not only cover EGFR, but also take care of the resistant mechanism, that is good. And amivantamab alone or in combination with another EGFR TKI has shown very promising effect in patients who have failed on osimertinib. So there is certainly hope. Aldora is a study which studied osimertinib in early stage disease. We have so far talked about advanced disease. Now we need to move what we have learned for advanced disease. We need to move it up to early stage disease. Early stage disease is still the situation where we have the best chances for cure, not the only chances for cure. I haven't said that. We have, as I said, good results also with advanced disease, but we need to focus on early detection of lung cancer to get early stage disease and be good treating early stage disease. That is a common strategy these days. And there are patients with EGFR mutation having early stage disease. And we can see here, if you give those patients an EGFR TKI, these patients do better than standard of care. So that was a landmark study and have led to focus on targeted therapies also for early stage disease. Another EGFR mutation is exon 20 mutation, as we call it, and HER2 mutations. And we do have drugs these days who can target those specific mutations as well. And preliminary data are very promising also for those more rare mutations. They are a little bit more rare than classical EGFR mutations, but again, we are currently developing drugs which can target them as well, and hopefully successfully. This is HER2 mutation. We can see here an overall response rate of 60% with this drug conjugate here. And that is a new avenue. This is called ADC, antibody drug conjugates. And that is a new development of drugs. I'm sure you will hear more about it in this seminar. But our data so far with this particular drug conjugates are very promising. This is targeting HER2. The drug conjugates have a dual effect. First of all, the antibody target the targeting receptor on the surface of the cell, but the drug has also what we call the warhead, which goes into the cell and attack the cell nucleus and the DNA of the cell. So it has a dual activity, and we have several of them. The determinant is antibody. Are we dealing with an antibody for HER2, for HER3, for another receptor? That is where the development goes these days. How do we select patients to these new drugs? We don't really know yet. It might be that we need to go to the protein expression, which is determined by immunohistochemistry. This is a technology we have known for years, but it has kind of disappeared because we have been focusing on mutations and next generation sequencing. But I believe that more classical immunohistochemistry, which is cheap, which is easy, and which can be done in all pathology labs in the country, I think that is coming back and highly relevant when we are talking about the new agents, antibody drug conjugates. Let me touch upon a couple of other things you will hear more about. KRAS mutation is the most frequent mutation in lung cancer. It has not been possible to target this mutation with drug for decades. It has been worked on in many labs, never succeeded. By the sudden, we have got a drug which can target a subgroup of KRAS mutations called G12C, which is, by the way, the most frequent subgroup of KRAS mutations in lung cancer. And today we have very good data with those treatments. We see here we have two drugs, sotorasib and adagrasib. Both are FDA approved for patients with this particular mutations. And we can see here that we have a disease control rate, means either response or stable disease, which is also good. We can see that in 90% of the patients with this particular abnormality, and a response rate around 40 to 50%. This is patients who have failed previous treatment. So this is second or third line therapy with those encouraging data. And you will hear more about it later today. I just take this as an example how important it is to have molecular profiling of the tumor. I don't go into details here. Another abnormality which has been familiar for us over several years is ALK positive tumors. We have now several drugs which target this abnormality. Most lately, we have introduced lorlatinib as a first-line alternative in this particular subgroup. I just want to show you one outcome study. This is from Colorado, University of Colorado, where I was working before. And this is a group of patients with advanced disease. Remember, 10, 15 years ago, the prospect for this group of patients was, we are counting 7 to 9 months. What do we see here? Median survival, meaning 50% of the patients are still alive at 6.8 years. That is amazing data, in my opinion, and very encouraging. As I said, we have many new drugs, and we have also learned about sensitive mutation and resistant mutations to the different drugs. And interesting is that some mutations can be sensitive for one drug and resistant mechanism for another drug. So we might be able in the future to sequence of a therapy based on mutation status. We don't do that routinely today, but that is a prospect I foresee over the next very few years. And the NCI have actually clinical protocols which is based on this mutation analysis. A few other examples. RET. We have 2 drugs today. We have several drugs today, most recently selpercatinib, praseltinib, with response of more than 60% in patients who previously have failed traditional therapy with very long progression-free survival. We have MET inhibitor with 60% response, and we can go on. I'm sure you will hear more about this, but all these things come into one sentence: importance of molecular profiling of the tumor. And today we have talked about tissue profiling, which is most common, but today we are using more and more blood-based assays. We call it liquid biopsy. My colleague at China, Dr. Rolfo, has spearheaded this development and made guidelines for use of it from ISLC. I just want to give you one example. I know you will hear more about it later on. We did a study where we looked into liquid biopsy for patients who got EGFR treated therapy. And we could see by using blood-based assay and monitored therapy that patients who cleared their EGFR mutation at the end of cycle 2, we looked into their overall survival, and they did much better than patients who did not clear their assay for EGFR mutation. So this is an example where we probably will go in the future. I'm sure you will hear much more about it later on. I would like to mention that some years ago I was in a blessed situation being in the steering committee for the National Cancer Institute, and we here together with FDA, together with academic organizations, we launched what we called the Master Protocol for Lung Cancer, the lung map concept, which is having clinical studies based on the molecular profiling. And today we have screened more than 4,000 patients and assigned patients, more than 2,700 patients to clinical trials. This is a concept which is very fruitful and bring the science hopefully very quickly forward. Now, how are we doing with molecular testing for patients with lung cancer? I actually thought we were doing pretty good, but I got much wiser at the ASCO meeting last year when we saw real-world biomarker testing studies. And believe it or not, for patients with lung cancer, and there were thousands of them in this study, less than 50% of the patients had had 5 biomarkers and more studied. That was an eye-opener. This is a community-based study. And unfortunately, there were also a huge difference in ethnicity, with African Americans doing very poorly in terms of having their tumor tested. So the bottom line here is we have a lot of work to do. We need to have most of the patients with lung cancer tested, and we need to do much more education in the communities. There are identifiable barriers. It is patient barriers, it is disease barriers, the size of and the location of the tumor. There are organizational barriers, clinician barriers, structural barriers, and policy barriers. We need to tackle each of them to be sure that our patients get opportunity to have testing and hopefully with next generation sequencing. And with that, I will end my talk. Happy to take questions. This is a greeting from the newly developed Center for Thoracic Oncology at SINA, which I was called for leading. And you can see we are working together, medical oncology, pulmonology, thoracic surgery, medicine, radiation oncology, and basic science. And that is where the future goes. We need to work together in a multidisciplinary pattern. So again, thanks for your listening and attention. Hope to see you in New York in different ways. Thank you very much.
Thank you, Dr. Hirsch. That was a tour de force review of the targeted therapy options that we have in this space, and I thank you. Continue to put your questions in the chat, and we are going to be having a question answer session with Dr. Hirsch and Dr. Flores and also Dr. Kim following all of their talks. So without further ado, I have been given the honor to introduce someone that I really admire and respect in this space. And I'm so happy that she is here joining us. She needs no introduction, but her name is Dr. Narjust Flores, formerly Dr. Duma. She is a thoracic oncologist at the Dana-Farber Brigham Cancer Center. She is the Associate Director of the Cancer Care Equity Program at Dana-Farber and an Assistant Professor of Medicine at the Harvard Medical School. So without further ado, I turn the program over to Dr. Flores, who will go ahead and give our next talk. Take it away.
Hi, everyone. First, let me check that you can hear me and see me. Is that correct?
Yes, we can hear you.
Okay. So as we talk about it, I'm switching name to Dr. Flores. I'm hoping to make this quite new concept as simple as we can to understand what is oligoprogression. So I'm going to be sharing my screen, and please let me know if you can see the full presentation. Are we able to see the whole thing?
We are seeing the presenters mode, I believe, if you could switch.
Okay, yeah, we will. What about now?
Perfect.
Okay, great. So we're going to talk about oligoprogression. So what is oligoprogression? Well, oligoprogression is a new concept. And, in medicine, we like to make things complicated. So oligo means few or little. And progressive disease is a disease that's growing after initial treatment. So oligoprogressive is a few sites of the disease are growing after initial treatment, okay? And this is a relative new concept because before we saw disease progression as a concept that was affecting, it was black or white. It was disease progression or no disease progression. But now we have this middle point called oligoprogressive disease, which is disease growing in a few sites of metastasis in a patient that otherwise has a stage 4 or widespread disease. And it's very important that we are conscious about the language that we use, and is the patients do not progress, their cancer progress, because our patients are more than the disease, and the disease doesn't define them. So this is oligoprogression or the cancer. The patient, there is no patient oligoprogress, it's the disease. Then we need to make sure we use patient-inclusive language. So I use this diagram because it really helps understand several concepts. And they all start with the word oligo, which means few. So we have patients that have de novo. It means at the moment of diagnosis, they have oligometastatic disease. It means the disease travel from the lung to another site, compared to other patients that may present with cancer in many, many organs, right? And we have oligopersistent. What is oligopersistent? It's a patient that has some disease and some limited sites, and when it's treated, only 1 or 2 sites remain. And what we're talking about today is oligoprogression, in which the patient has limited disease, receives treatment, and after a certain time, 1 or 2 sites of the disease grow where the rest of the body or the rest of the disease is under control. So why do some patients have disease progression in many organs, and why some others only have disease progression in some limited numbers? So one example is a patient that has widespread disease. They get treated with TKIs or the targeted therapy, and then they have a good response for around 6 to 9 months. And then a site in the liver or a site in the bone starts growing. So that is oligoprogression. The rest of the body is under control, but 1 or 2 sites are growing. So it is a complex concept that we're trying to understand why does exist. And there's several factors that affect oligoprogression. One, we know that when we are targeting a specific mutation with these new drugs, the cancer evolves and develops resistant mechanisms. And so that's one of the reasons we see oligoprogression, because a part of the cancer has developed a resistant mechanism to the targeted therapy. Another is changes in the tumor microenvironment. You see these most in patients that are treated with immunotherapy or immune checkpoint inhibitors or the pembrolizumab, nivolumab, or those drugs. Also, there's several hemodynamic patterns because we see oligoprogression more common in some organs that have high blood supply, like the liver. A lot of patients tend to have disease progression in highly vascularized organs. And that means there's more blood going, there's a pattern there. Also, What areas have been previously treated with radiation and ablation or surgery? Those areas are less likely to have disease progression compared to areas that have not. And also the unique disease characteristics. Lung cancer is no longer one disease, it's many different types of mutations. And we know that certain mutation-specific cancers like to go to certain organs more than others. One example is the ALK-positive non-small cell lung cancer that has a preference for the brain. So in this area of very well-tolerated treatment, and like we just heard about patients with ALK-positive lung cancer living up to 6-8 years, we know that we're going to encounter some resistance. Cancer continues to evolve over time and continues to overcome these inhibitions that we're doing with the targeted therapies. So it is inevitable that patients will develop resistance to the target medication. We don't know exactly when. We're learning little by little who are at higher risk for this. But it's important to understand that oligoprogression, that means a few sides of the disease growing when the rest of the disease is under control. It is an opportunity to regain control of the tumors that are growing with local treatment. Okay? So oligoprogression has given us the opportunity to treat those sites that are growing when the patient still remains in the targeted therapy. And why is that important? Well, the quality of life of many of our patients is better when they're in targeted therapy. You know, taking a pill instead of getting chemotherapy. Also, it provides control for a mutation that we know that you have. Is the best tailored treatment. So treating these sites of disease that are growing here and there allows to keep our patients in the target therapy for longer time before switching to chemotherapy and to the less effective immunotherapy. But there are two important things we need to know about oligoprogression. The first thing I look at is the presence of symptoms. Is this oligoprogression giving symptoms to my patient? Often we see it when there is disease progression in the bone, right? The tumor is growing on the bone. It tends to produce more pain, especially if it's in the back when patients go to bed. Is the disease growing very close to the airway that is causing cough or is causing cough with blood? So the main thing for me is how is this affecting my patient? And where is the site of the disease progression? We need to understand that we also need to follow the criteria for disease progression. It needs to be more than 30% of the regional size in order for us to say that the cancer is growing to a significant point. The disease sometimes, particularly with immunotherapy, can wax and wane. So we have, when we call it progression, disease progression, it needs to be over the 30% of the regional size or the size to call it. And the second thing is what resources are available at my institution that will allow me to treat these little spots of disease progression. I'm very fortunate to be in an ivory tower in which I have many resources to treat this, but not all these resources are available all across the United States or outside of the United States. And finally, in number two, we need to make sure, particularly with patients that have an EGFR mutation, that the disease has not transformed to a small cell. And we're going to talk about that. So when we talk about disease growing in certain spots, but being controlled in the rest of the body, two things: symptoms, what can I do for this? What do I have available? And I need to make sure I'm not dealing with a different disease that has transformed. And I'm putting this image here to stop and understand that our patient's health is as delicate as this snowflake. We need to make sure that or communicate and listen to our patients. A lot of signs of oligoprogression I have identified before the CT scans. My patient tells me that they just have this new abdominal pain. Sometimes that's a capsular dilation from the liver, that they have this back pain that return, that looks and sounds similar that when they had diagnosis of lung cancer. So there is a very fine line to make sure that we don't miss the oligoprogression or it becomes full-on flank progression. So listening to our patients, having a good communication, we allow us to make early diagnosis to control the rest of the disease. And I cannot stress enough that the treatment of oligoprogression or lidoprogression needs to happen with a multidisciplinary care team. I wish I could do everything in my patients, that we make a scheduling quite easier. But we often have to work with surgeons, radiation oncologists, pulmonologists. We need to talk to interventional radiologists to treat this disease. And also, in cases in which you're not sure if the disease has transformed, to talk to your pathologist to evaluate a repeat biopsy. So this slide looks simple, but has a lot of information. So the first one is oligometastasis. That's a patient that is diagnosed with cancer that has spread outside of the lung, but is limited to certain disease sites. So these patients are getting radiation. Then here's where we are with oligoprogression and oligorecurrence. Oligoprogression is when the cancer grows in very limited sites, right? Here in the shoulder, here in the leg. And we usually treat it with local therapy. And that's what those little thunders kind of look. They mostly are radiation, but allows to control those two sites of diseases that are growing where the rest of the disease is under control. This is very different than widely metastatic progressive disease. If you can see one picture to another, oligoprogression is when it's one or two sites growing. Full-blown disease progression is when it's multiple sites. But we still use radiation to treat some of the symptomatic lesions. So this is a good example of a patient that had oligodisease progression in the rib. And these tend to be very painful every time you take a deep breath, when you're trying to sleep on their side. So the patient remained in the targeted therapy, but we were able to treat with radiation that spot that was giving us trouble. And these patients remained in targeted therapy for a year after we treated these lesions. So it's a bridge. It's a bridge between, we know that the cancer is developing a resistant mechanism. Let's try to treat these sites that are growing to get the most benefit we can for the targeted therapy. This concept of oligoprogression continues to be studied. There is more information about oligometastasis, which is the patients are getting diagnosed with stage 4, but they only have the disease in certain sites outside of the chest. So this is a study that's being done in Canada in which patients that have oligoprogression, 1 to 5 lesions. So we have a limit, and they're less than 5 centimeters, and it's less than 3 organs. So bone, liver, adrenal glands. The adrenal glands are the glands on top of the kidney. Then, if they have a driver mutation or not, they're getting randomized. It means somebody gets a standard of care, we switch in the therapy, and somebody else gets directed therapy to those sites that are growing. This is still ongoing. As you can see, it was recently published, mostly the ongoing progress of the study in March of this year. So what do you use to treat these disease sites that are growing? There are several local therapies. What is the difference between a local therapy and a systemic therapy? Well, the local therapy treats the disease where it is, that spot. It doesn't treat the disease everywhere else in the body. And that's what we use for oligoprogression. The number one use is radiation. Particularly, we know the pinpoint radiation, or called SBRT, stereotactic radiation. I call it pinpoint because it allows to treat a lesion without all the extra radiation side effects and the area surrounding that tumor. It tends to be very effective. It ranges from 1 fraction to 10 fractions. That means fractions is the number of treatments. Another option that is less commonly used is surgery. So remove the disease that's growing, that's giving us the trouble. Why is less common? Well, it requires more other patients. Lung surgeries require a long recovery time. And we also have ablation. So ablation uses laser, and a common way to say laser, of very cold energy to kind of burn the tumor that is giving us trouble. And they usually use these needles that you can see in this picture to go to the lesion and put very cold therapy, it's called cryotherapy, or use very warm therapy, that's a type of laser, or radio ablation. So these are mostly local therapies. They do not treat the cancer and other sites besides the site that is directed. And once we talk about it, the cancer that gets exposed to mutations will develop resistant mechanisms. And that's what we see in oligoprogression. I'm going to talk quickly mostly about EGFR, mutant non-small cell lung cancer, because it's the one that we have seen more from the disease that transformed. So what happens? We have the gene mutated, right? You block that gene mutation with the TKI or the drug. Well, the mechanism, the cancer finds a mechanism to survive outside of the original pathway. And sometimes that makes the cancer go from adenocarcinoma, which is the most common type of lung cancer, to small cell, which is a different type of lung cancer. This is a rare phenomenon, but as we continue to see our patients living longer and longer in targeted therapy, we're seeing more. This is some of the data that comes from NGH. And depends on who you read, the frequency of transformation of adenocarcinoma to a squamous cell or small cell can range from 4 to 15%. And why is this important? Because the disease treatment is very different. So usually these patients don't have oligoprogression. They have like a frank progression. The disease is just growing faster than was growing before. But the only way to really show if this is a different type of cancer is to a tissue biopsy. It means we have to go to the site that is growing significantly and take a biopsy to understand. I'm a big proponent that when patients have a lot of disease progression, to do a repeat biopsy, because this allows to understand how is the cancer finding a way around? How is the cancer develop the resistant mechanisms? So the number 2 thing we talk about oligoprogression is if the disease is not behaving like it used to behave, that may be a clue that we are dealing with a transformation. This is a rare phenomenon, but it cannot be missed. So in the case scenario in which the patient has only a few disease progression, here's where we are. Oligoprogression. So we treat it with local therapy, radiation, surgery, ablation, or any other therapy, and the patient remains in the pill or the target therapy they were on. And we are learning more and more about oligoprogression. This comes from a news article, actually, and that talks about how we can use radiation in patients that have disease progression certain size to try to get control of the disease for a little bit longer, and our patients remain in targeted therapy for a little bit longer. Important to mention is that treating those disease progression doesn't mean that the cancer is cured. It just means that we're buying time in the current therapy. There are certain cases in which patients get radiation to the remaining sites, but that's very different. That's oligometastatic disease. These are patients that are already in targeted therapy. The cancer grows on the targeted therapy. And as I'm coming to the end of my presentation, I want to use the example that I use for my patients that I think has been very successful. And as somebody who lived in the Midwest for 6 years and used to have a yard, these guys, the dandelions, are like a headache in the spring. So oligoprogression is like pulling a dandelion, right? You get your little thing and you pull that dandelion. You know it's going to come back, but it gives you a little peace of mind to know that you pull it and at least you're not seeing it. And as you know, dandelions pollinate quite easily. So there is some data that suggests that treating that clone or treating that disease that's growing may provide more control and longer benefits. So oligoprogression disease is like pulling a dandelion. You pull the dandelion with radiation, surgery, ablation. The cancer is not cured. Your jar It's not completely free of dandelions, but you get some time in your current therapy. The dandelion may come back later. We don't know exactly when, but we will be prepared to find other options. And as I finish the presentation, we need to continue to have better and improve the communications with our patients. As I said before, many times the disease oligoprogression talks to my patients before it talks to me, meaning they have new symptoms, they have new concerns, and all those little things need to be listened to and addressed. So we are able to control the disease early on when it's growing instead of waiting to get a wide progression and then these local therapies are not an option. I hope this has been helpful. I'm going to stop sharing my screen and I will be here for questions later.
Well, thank you so much, Dr. Flores, for that excellent presentation. As someone who still lives in the Midwest, I think I'm going to definitely use the dandelion analogy to my patients. So thank you for that. Well, we'll now head into our third talk for the session. And so next up is Dr. Chul Kim, who will be talking about managing treatment toxicities, a practical approach. Dr. Kim is an assistant professor at Georgetown University focusing on thoracic malignancies. And so the floor is yours, Dr. Kim. Thank you for your time today. And I will request you if you can keep your video on so the audience can also see you as you are presenting. Thank you.
Thank you very much, Dr. Desai, for the kind introduction. I will first share my screen here. Sorry, I think it says failed to share. Sorry, I got a message saying something went wrong with your screen sharing permissions. Please reload and try again. Sorry about this.
I think someone from the studio can they help Dr. Kim navigate this?
Let me open my slide again.
Hi, Dr. Kim. It's Claire calling from work. I'm not calling. I'm from Workcast. Just a quick one. Can you hear me okay?
Yes.
Lovely. Can I just ask, are you using a Mac or a standard device, like an Android?
I'm using a Mac.
Okay, I might need to take you through your security settings. So apologies, audience, for this, whilst I just run through some security settings on that side.
Yeah. Is it okay if we can go into a few questions with Dr. Hirsch and Dr. Duma while we're working on Dr. Kim's setup?
Yes. So Dr. Kim, if I send you a guide that I'll pop into the presenter-only chat, and then you can take yourself through that whilst we're doing the questions. Okay?
Thank you.
All right. Thank you. So thank you, Dr. Hirsch, for your wonderful talk. And I think while we're still waiting for Dr. Kim to set up, there are a couple questions coming from the audience. But I would like to start with a question on, you talked a lot about next generation sequencing and how that has changed the landscape of treatment for lung cancer. What is your current practice in terms of ordering next generation sequencing? Do you order it on patients with all stages, or is it just stage 4? So if there is a patient who recently gets diagnosed with lung cancer, how should they think about whether they would need an NGS testing or not, and what do they discuss with their doctors?
Yeah, so that is a very good question. Can you hear me?
Yes.
Yes, yes.
Yeah, that's a very good question. I happen to be in a highly academic institution, so what is practiced in my institution might not be necessarily the rule of practice in a community setting. In my institution, we are aiming for doing next-gen sequencing practically on all patients with lung cancer who comes in. particularly enforced now with also a DORA study in early stage disease. And we have the opportunity to do next gen sequencing with in-house with company who came out of Sinai. Now, what I have also participated in guidelines for CAP ISLC AMP. And the guidelines do not recommend molecular profiling for all patients. They recommend molecular profiling for patients with adenocarcinoma and for certain patients with squamous, if they are young, if they are never smoker, if they you have suspicion of a molecular driver, ethnicity, Asian background, those things can come into play even for patients with squamous lung cancer. So the answer to your question is a little bit complex. I will say that patients with adenocarcinoma should be molecular tested today, independent of stage. The patients with squamous lung cancer should they should be tested if they have certain characteristics, as mentioned: never smoker, early age or young age, and Asian ethnicity. So that will be my take on it. A question which has come up frequently is, if a patient has a poor performance status 2 or 3, do you have mutation status on this patient? Even if poor performance status is not included in the clinical trials, we all know anecdotally that if a patient come in poor performance status, and the poor performance status is because of the disease and not the comorbidity situation, these patients, if he has the right molecular abnormality, we can have these patients jumping out of the bed within few weeks. If this patient happened to have an EGFR mutation, and that is the reason for poor performance status. So, in my opinion, poor performance status is not a limitation for molecular profiling. I hope I have given my perspective to it.
Yes, absolutely. No, thank you so much. So I'm hearing, from an audience perspective that, always good to discuss with your doctors, regardless of what your stage, whether they think you should be tested for next generation sequencing and mutations. And like you said, I think that's very true that, performance status should not be a limiting factor for this kind of testing.
Yeah.
I guess just another follow-up on that, and that actually question comes from the audience was, I know you talked a little bit about, the use of Amivantinab. So there's a question from the audience talking about, is Amivantinab effective for exon 21?
Exon 21.
Yes, that's the question.
We don't have data on that yet. We are talking exon 20.
Absolutely. Yep.
Yeah.
And in terms of going back a little bit to the NGS, what is your preference for DNA-based versus both DNA and RNA-based approaches? Could you speak a little bit to that?
Yeah, we do actually both in my institution. RNA sequencing is better for fusions. And in lung cancer, we have quite a bit of fusions, as we talked about. We have NTRK, ROS, ALK, and other fusions. So RNA sequencing seems to be a little bit better there, but DNA sequencing is fully acceptable and done most of the places. So that is the answer.
Thank you so much, Dr. Hirsch. Dr. Kim, are we?
I might add that, technologies today develop so quickly that what we are talking about today might not be relevant 6 months from now. We have new technologies which take care of both RNA and DNA sequencing.
Thank you. Dr. Kim, should we continue the questions as we are still trying to?
I think I fixed the problem. I apologize. And I think we can try. I hope this works. So, okay. Is the wordcasting? I changed the setting. I still have the same problem.
Hi there. Sorry, it's Claire again. So there's two options here. We might need to get somebody else just to share the slides on your behalf, or it might need that your browser just needs to have a quick update. So that might mean that you have to log out and log back in again. So you may want to decide which option you want to take offline. Sorry, the joys of technology, eh?
Oh, okay. So Maria, can you share the slides for me?
Yes, I can.
Thank you so much. All right, so I apologize for the technical issues. So today I'm going to talk about the treatment toxicities of targeted therapy, and as Dr. Hirsch and Dr. Flores wonderfully discussed the advances that have been made in the past several decades in terms of understanding the biology and then advancing the therapeutic landscape of lung cancer. It is also becoming very important to understand and recognize some of the side effects associated with the targeted therapies for lung cancer for safe and effective therapy. Next slide, please. Next slide, please. So there are about 21 unique agents that are approved by the FDA for treatment of non-small cell lung cancer. And here in my talk, I'm going to focus on EGFR, ALK, and ROS1 genomic alterations given the time. But some of the principles and suggestions can be applied to the side effects that arise in the setting of other targeted therapy drugs. Next slide, please. So EGFR is a molecule that is widely expressed throughout our body, and so it is not surprising to see that various organ systems are affected by EGFR inhibitors. So here I'm going to focus on skin, GI side effects, and some of the rare side effects, but important to recognize the pulmonary and heart side effects. Next slide, please. So when EGFR is inhibited in the skin, there are several changes that happen. First of all, there's an alteration in the chemokine expression in the skin, leading to recruitment of some of the innate and adaptive immune cells, such as macrophages, dendritic cells, and T cells. And this is followed by alteration in the differentiation of the epidermis, which is the upper part of the skin, and also change in the expression of antimicrobial defense genes in the keratinocytes. And combination of these factors lead to the development of skin toxicity in the setting of EGFR inhibitors. Next slide, please. So this is a general timeline of skin side effects that develop with the EGFR tyrosine kinase inhibitor therapy. First, we see rash and itching develops, followed by dry skin, skin fissures, stomatitis. Stomatitis means oral cavity inflammation, and then sores, followed by nail changes thereafter. Next slide, please. As Dr. Hirsch mentioned, there are 3 generations of EGFR tyrosine kinase inhibitors, first, second, and third generation. And based on the FLORA trial and others, we utilize third generation treatment more often than the earlier generation inhibitors. So with third generation EGFR inhibitor, such as osimertinib, the instance of rash is less compared with first and second generation drugs, and it ranges from 40 to 50%, and it is rare to see a high grade 3 or higher rash with the third generation EGFR inhibitor therapy. The itching and the dry skin are seen across all the EGFR tyrosine kinase inhibitors. In terms of peronica, so peronica is a term to describe inflammation or infection around the finger or toenail, happens across the generations of drugs. However, perhaps more commonly with the second generation. In terms of third generation inhibitor therapy, the range of peronica instance is from 20 to 30%, but again, it is rare to see high grade peronica with the use of third generation inhibitors. Next slide, please. So I'm showing you some of the pictures that really exemplify the acne-form rash, the acne-like rash that happens with EGFR inhibitor therapy. The picture on the left is a patient who is taking first generation EGFR TKI therapy, and you see that there's sort of pimples on the face and then pus-filling lesions as well that are tiny. And on the right is a patient who is taking osimertinib, which is a third generation EGFR tyrosine kinase inhibitor, showing a little less degree of rash, as you can see. Next slide, please. And how do you manage acneiform rash? And this rash can have several impacts because of the appearance and then the itching associated with sometimes pain. And when the rash is mild or grade 1, defined by less than 10% body surface area involved, we think about using topical corticosteroids. And for the face and neck, we think about using low potency steroids such as hydrocortisone or moderate potency steroids such as triamcinolone. And for the body, for the trunk, we can go up a little higher on the potency of steroids such as clobetasol cream, which is considered a high potency steroid cream. And this can be supplemented by topical antibiotics such as clindamycin 1% gel. And when the rash is mild and grade 1, we usually continue the therapy. Next slide, please. When the rash becomes moderate or grade 2, defined by 10 to 30% body surface area involved, we still use topical corticosteroids. Then we think about using oral tetracycline antibiotics such as doxycycline and minocycline. And the way I use in my clinic is that I assess patients frequently every 2 weeks or so to determine how long the patient may need to stay on the oral antibiotics. And unless the rash is intolerable, there is no need to interrupt the therapy. Next slide, please. When the rash is severe or grade 3, defined by more than 30% body surface area involved, we use topical steroids, oral antibiotics, but then consideration can also be given to a short course oral corticosteroid so that the steroids can go everywhere. And we can, for example, prednisone 0.5 to 1 milligram per kg for a few days. And then in this setting, we think about holding the therapy. And if there's lesions that have pus or other discharge, cultures can be sent for further workup. Next slide, please. As I mentioned, the EGFR tyrosine kinase inhibitor therapy can cause xerosis, which is a dry skin and sometimes scaly, as you can see in the picture. And this can be accompanied by itching. Next slide, please. When the itching is localized, you can utilize topical steroids. But if the itching is more generalized, we can think about using oral antihistamines such as hydroxyzine or gabapentin or pregabalin. These are GABA agonists. For the prevention and treatment of dry skin, we recommend using moisturizing creams regularly or lotions without any irritants such as fragrances or alcohol. For the scaly dry skin, as seen in the prior picture, exfoliants such as ammonium lactate urea can be utilized. Next slide, please. So peronica can be a very challenging side effect of EGFR tyrosine kinase inhibitor therapy. And the pictures at the top really showing really bad cases of peronica. You see a red and angry looking peronica around the toe and fingernails. At the bottom, you see mild cases of peronica, and nail changes can happen, as I mentioned, and these include nail discoloration and then a brittle nail. Next slide, please. So it is important to minimize the trauma around the finger or toenail. So we recommend wearing comfortable shoes and wearing gloves when doing house chores or doing the dishes, things using hands essentially, and avoid biting nails and cutting nails too short. And when there is a concern about ingrown toenail that may cause trouble down the road, getting preventive correction procedure may be reasonable. And also it's important to apply emollients such as moisturizing creams around the nails so that the area is continuously moisturized to prevent the development of peronica. Next slide, please. The management of peronica is quite similar to the rash as that I discussed already. When it's mild, defined by no pain, no discharge, no nail plate separation, we can use topical steroids or antibiotics or antiseptics. If it's associated with the pain or discharge, then we use these topical creams, products, but also oral antibiotics such as the tetracycline antibiotics can be considered. If it's a severe, causing severe pain and discharge and infection, we need to think about interrupting the EGFR TKI therapy and utilizing the topical products and oral antibiotics. And at this point, I consider the refer patients to a specialist for further evaluation. Next slide, please. Stomatitis can happen with EGFR inhibitors, and here in the picture showing really red and inflamed ulcers that are on various areas on the oral cavity, and this can really interfere with the patient's quality of life because it can impair the eating, and then it can cause burning. Next slide, please. So it is a good idea to check in with the dentist once in a while to make sure there's no mechanical reasons to develop stomatitis, and using ultra soft or softer toothbrush can be recommended. And when there's really bad burning by this stomatitis, using minimally flavored toothpaste such as children's version of toothpaste can be helpful. And then mouth washing without sort of irritants there, such as alcohol, can be utilized to moisturize the oral cavity and also soothe the pain. When there are multiple lesions in the oral cavity and causing pain and burning, we often think about using steroid mouthwash. It can be either dexamethasone mouthwash or magic mouthwash, which can work like magic, though there's no magic there. If there's only a few areas that we need to treat in the oral cavity, then we can use high-potency corticosteroids for those specific spots to treat the symptoms. And then if there is any clinical suspicion for infection, and we can send viral and fungal swabs for further investigation. Next slide, please. So diarrhea can be challenging, and thankfully with the third generation EGFR TKI osimertinib, it's not really a bad problem at all. When diarrhea happens, we utilize loperamide as the mainstay of therapy, and this is the way I usually tell my patients how to take loperamide. So first, if there's an episode of diarrhea, you take 2 capsules, which is 4 milligram, followed by 2 milligram, which is 1 capsule after each loose stool, up to 60 milligram per day. And you can think about using Lomotil and other anti-diarrhea medicine if loperamide doesn't work well. And diet modifications such as less greasy, spicy fried food and dairy products, if lactose intolerance is suspected, can be done. And hydration is important, and we always tell our patients to drink adequate amount of fluid water. If the diarrhea is severe in the setting of, let's say, osimertinib, then I would really think about other etiologies such as infection, because severe diarrhea is really rare with the sort of more specific EGFR TKI drugs such as osimertinib. And in the setting, we do IV hydration, and it's reasonable to hold EGFR TKI therapy as the workup is ongoing. Next slide, please. This is one of the dreadful side effects, and the picture here is showing actually a picture CT scan image of my patients who developed pneumonitis after a successful year of treatment with osimertinib and ended up in the ICU actually because of pneumonitis. So this is rare. This happens about 3.7% with osimertinib, but it can be serious. So the symptoms to report to the medical team include cough, shortness of breath. And I understand, I acknowledge that these symptoms can be hard to differentiate between, let's say, tumor progression and other EOs such as pneumonia. However, there's a really low threshold to report these symptoms to the treating doctor and medical team so that the proper investigation can be done to understand the process. When the pneumonitis is suspected, it is very, very important to hold the therapy. It's okay to hold while the investigation is ongoing, because if you continue to take EGFR TKI therapy, and again, per the doctor's recommendation, then you put more fuel to the fire, and so that should be considered. And when the patient has hypoxia and any other symptoms, then we utilize supplementary oxygen, utilize high-dose corticosteroids, sometimes empiric use of antibiotics as well is done. Next slide, please. And then cardiac toxicity, this is heart toxicity from the third generation EGFR TKI osimertinib. And according to a recent report, the instance of decrease in the pumping function of the heart, called the ejection fraction, was reported to be about 3.9%. And so this is rare, but this is important to recognize. And I have several patients in the past many years who developed cardiac toxicity leading to discontinuation of osimertinib. And so we recommend a regular cardiac monitoring for patients with the underlying cardiac risk factors. And also, it is important to report any symptoms suggestive of cardiac failure, such as a breathing problem or developing edema in the legs and other parts of the body. Next slide, please. Now, moving on to ALK tyrosine kinase inhibitor treatment, and shown here is various organs that are affected by ALK tyrosine kinase inhibitors. Generally, these are very well tolerated, but there are these are some of the organ systems that can be monitored, that will need to be monitored when someone is on ALK TKI therapy. Next slide, please. And there are 5 drugs, as Dr. Hirsch mentioned, for ALK fusion-positive non-small cell lung cancer. And like in EGFR TKIs, we have 3 generations of drugs. And one of the reasons why patients develop various side effects is because these drugs target different molecules beyond ALK, as seen in the table. And then the molecular targets of these drugs are non-overlapping between agents, meaning that each drug has unique side effect profile compared with others. Next slide, please. And so looking at, one of the most commonly used drugs is alectinib. Common side effects are anemia, usually mild. We can usually monitor or deal with dose interruption and modification. And then edema can happen in all ALK TKIs, actually. Myalgia is one of the most common side effects of alectinib. And so CK, which is a muscle enzyme, creatine kinase muscle enzyme level, is something we monitor for our patients regularly. And the liver toxicity and nausea are the common side effects. And brigatinib, the common side effects are diarrhea and the muscle enzyme elevation, so it's creatine kinase elevation and nausea. And hypertension is a unique side effect of brigatinib, and we need to monitor blood pressure regularly on brigatinib. And then I will spend one slide for the early onset pulmonary events associated with brigatinib. This is a very unique side effect of brigatinib. In terms of lorlatinib, which is 3rd generation drug, common side effects are hypercholesterolemia, so how cholesterol is high, or triglyceride levels. Edema is quite common, 55%, an increase in weight, peripheral neuropathy, and importantly, mood and cognitive disorders can be seen in about 16 to 21% of patients. However, sounds a lot, but the rate of discontinuation is quite low with these drugs, and the far right column showing the discontinuation rate, which is 7 to 13% among these agents. Next slide, please. The early onset pulmonary events associated with brigatinib is something the field has been recognizing as we use the drug, and this isn't common, 3 to 6%, and patients feel shortness of breath, chest tightness, and sometimes you also have hypoxia, meaning low oxygen level. And Dr. Kamij and colleagues described rapid tolerization to early onset pulmonary events with the brigatinib is possible during continued dosing with frequent assessment in stable patients. For patients with severe symptoms, a really bad breathing problem and low oxygen, then dose interruption should be considered with the supportive care with supplemental oxygen. And the CT scan below is showing in the middle the ground glass opacity that happened with brigatinib, which subsequently resolved with the supportive therapy. Next slide, please. Lorlatinib has, as Dr. Hirsch mentioned, has the best hazard ratio for the extracranial and intracranial among all the ALK TKI therapy drugs. However, it is associated with a unique side effect such as hypercholesterolemia, high cholesterol level. So cholesterol is something we monitor very closely for these patients, and also triglyceride level. When the levels are high, we start with the statin. Usually we either rosuvastatin, pitavastatin, or pravastatin. These interact less with the lorlatinib compared with other statins. And when a statin is not enough, we utilize fibrates, fish oils, nicotinic acid for the hypertriglyceridemia, high level of triglyceride lipid. It is not necessary to interrupt the dose unless cholesterol levels or triglyceride levels are really, really high. Next slide, please. In terms of CNS side effects, again, it is important to counsel the patients, about the possibility of mood disorders, cognitive effects with lorlatinib, which sometimes can be significant, but the good thing is that it generally improves and resolved following those modifications, and those modification guideline is shown in the table on the slide. Next slide, please. In terms of edema, I mentioned that this happens with all the ALK TKI therapy with the varying degrees of incidence and severity. The highest incidence with lorlatinib. We recommend using compression stockings and elevate the legs, and the low salt diet, increase exercise to use the muscle to squeeze the water out the legs. And sometimes we need to utilize diuretics such as furosemide or Lasix. Next slide, please. I think the ROS1 tyrosine kinase inhibitors have really similar organs being affected by the treatment, like in ALK rearrangement, non-small cell lung cancer. And I'll highlight the entrectinib, which is a second ROS1 drug that was approved, and there's another crizotinib, which is another ROS1 inhibitor that was approved by FDA earlier. Next slide, please. So if you look at the common side effects of entrectinib, the most common side effect was dysgeusia, which is altered taste. So the taste changes on the drug, but usually mild, grade 1 or 2, followed by some of the CNS side effects. And this is associated with the TRK pathway inhibition property of entrectinib. And these are dizziness, weight increase, and paresthesia, which means neuropathy. Next slide, please. And how to manage dysgeusia, so altered taste, is a tough one because there is not a lot of high quality studies, and a lot of studies are limited by small sample sizes. But it is important to understand why the patient experiences dysgeusia. Is it dry mouth? Is it they don't smell things? Or is it taste change, like sour taste or metallic taste? And based on that, there's some helpful suggestions in the algorithm shown here. But again, as I mentioned, the recommendations are somewhat limited by the limitations of the studies studying the issue of dysgeusia. Next slide, please. I'd like to conclude the session by highlighting some of the TRK inhibition-related neurologic adverse events. And the TRK pathway controls several things. First, appetite, balance, and pain sensitivity. And so when you inhibit TRK pathway, you can develop various side effects. And the TRK inhibition can be are associated with the entrectinib, as I mentioned, also larotrectinib, which is NTRK inhibitor that was approved by FDA for NTRK fusion positive cancers, tissue agnostic fashion. And the TRK inhibition can lead to several side effects, as I mentioned briefly: weight gain, dizziness, and ataxia means balance problem. And when you stop TRK inhibitor because of various reasons, progression or side effects, patient can also experience withdrawal pain because of the TRK pathway being involved in pain sensitivity. And then paresthesia, which is neuropathy, can happen as I discussed. Next slide, please. And there are various ways to deal with this side effect. And this is one of the, I think, best review papers by Dr. Drilon and colleagues published about 2 years ago, suggesting several medications and other supportive treatments that we can utilize to treat or manage these adverse events associated with the TRK inhibition. And so I will not go over the details, but these are some of the medications we can utilize for these side effects. Next slide, please. And so to really conclude, targeted therapy is an effective and generally well tolerated, but then there's a diverse side effect profile across different agents and across patients. And early recognition and communication of the side effects are the key to successful treatment. And so I'd like to highlight that. It's my last statement. Thank you for your attention, and I apologize for the technical issues. I will be happy to take any questions.
Dr. Kim, thank you so much for that extensive review. And I found the pictures to be extremely helpful, especially as a clinician myself, to see what your thoughts are about toxicity. Because sometimes, I'm sure as you see, we see a patient and we see an issue that they're complaining of, and we're not sure if it's related to osimertinib or not. So having pictures to reference and see was very helpful. And I'm sure that was also helpful to the audience. Speaking of our active patient audience, we have an excellent question for you specifically, Dr. Kim, and then we also have some in line for you, Dr. Hirsch and Dr. Flores. So I have a great question for you, Dr. Kim, in regards to toxicity. One of our patients has heard that development of side effects is sometimes associated with better survival, actually. So therefore, if someone is experiencing no side effects, but is also not having a great response to treatment, should we be perhaps increasing the dose of their therapy? What are your thoughts there?
Yeah, it's a very good question, and one of the questions that I get asked a lot sometimes. And my experience has been that, and there are some studies showing that if you develop rash on EGFR inhibitor therapy, there may be some better survival or outcomes. Those studies may be sort of limited by some of the survival bias because if you develop a certain side effect, you may have to live certain period of time to develop that. And so it is important to, when we assess those studies, it is important to assess whether they did any statistical analysis or design to correct that bias, the survival bias. And in terms of immunotherapy, I think there's probably a little stronger data to suggest that if you develop the vitiligo or rash on some immune checkpoint inhibitor therapy, there may be stronger survival. In the setting of targeted therapy, I'm not quite clear actually whether there's any sort of conclusive statements because I have seen many patients who have not had any side effects or just minimal side effects who did very, very well over time. I had some patients who had developed really bad side effects at the same time didn't respond well, as you mentioned. And so making the correlation, I think, is somewhat tough. There may be some suggestion or association, but it's not a strong one, I would say.
Well, thank you for that, Dr. Kim. I just have there's a couple questions for Dr. Dr. Flores. So I think you talked about, your approach to oligoprogression with EGFR mutated subset. Is your approach different for other mutations? And is there any difference in your surveillance strategy with regards to how you kind of survey patients on treatments? Because some of these mutations may have a predilection for brain metastases and such.
So I think more than mutation specific, I'm very patient specific because that's what it really comes to. What are the symptoms of the progression? What is important to the patient's healthcare beliefs and values, what I take into account. There's some diseases that we have better control. Like when I say diseases as subgroups of lung cancer. So I think it also comes to the fact that some mutations are more frequent than others. So we have more data about EGFR because the frequency of the mutation is higher compared to ALK. But I have used the oligoprogressive approach for patients with mutations and patients without mutations. Because the hope is that we don't give up on treatments too soon and that we're able to control the disease and the current therapy. For surveillance, we know that some diseases are trophic. Trophic means they like to go to an organ more than others. So for patients with ALK, ROS1 disease, I tend to have more active brain surveillance. And it's something I need to mention is a lot of my patients are younger women because that's sort of my area of research. So I take into account the consequences and the repercussions of, an undiagnosed brain lesion when I have a very young patient who has to take care of their 2 kids, who has a full-time job because otherwise they will lose insurance. So that's what I say, patient characteristics, not only of the disease, but what defines their life, their socioeconomics, and their social determinants of health will also determine surveillance, right? So for diseases that are more trophic or prevalent, I have a very active surveillance. We also have clinical trials evaluating early or monitoring with liquid biopsies. So these are blood draws that try to evaluate if the mutation is suppressed with the drug. And I know Dr. Hertz talked about this. So we have several protocols in which these patients are going in the targeted therapy and they're getting regular biopsies by blood that allows to determine if that disease or that clone, that mutation is being suppressed. And as we continue to monitor these patients, sometimes we see that the clone starts coming out or resistant mechanisms start coming out in the blood. So that's a very long answer for a short question. So patient is specific, disease is specific, following the patient's belief. And I tend to treat all the diseases based on how they present. Patients with mutations are most likely to get a treatment of oligoprogression because they're most likely to have this pattern compared to patients without the mutations.
Thank you for that, Dr. Flores. I love your approach that it's all about the patient. And I see you continually emphasizing that. And that is so meaningful to those out in the audience and also to us to learn from you as an example. On the tails of that, there's yet another question for you in regards to your oligoprogressive talk. So for a patient with EGFR non-small cell lung cancer, initially diagnosed at an early stage, but then unfortunately developed one oligometastatic lesion to the brain after chemotherapy, is this patient considered stage 4 and on palliative care? And also, does this mean that local treatment with brain surgery and stereotactic radiation is now considered curative intent since it's only one site?
So one thing important to mention is we're talking about oligometastatic here instead of oligoprogression, right? So oligometastatic are patients that have the disease coming back after a curative intent, in this case is surgery. So oligometastatic when they present with disease that has traveled outside of the lung to another organ, but it's only 1, 2, or 3 organs, right? So this is an oligometastatic setting. Yes, it's still stage 4 because when the cancer travels outside of the chest, outside of the chest, lungs itself, because it travels to the pleura, which what covers the lung, it's also stage 4. So if the cancer travels outside of the chest, it's a stage 4. We do treat these lesions in the brain because one of the challenges we have is a lot of the drugs have limited data or no data about getting to the brain. So this is a very complex question that, because of the different subtypes of lung cancer. So for patients with EGFR disease, if they're symptomatic, we tend to treat these lesions. But osimertinib, which is the new drug, goes to the brain better than the other drugs. So sometimes depends on the approach. But if this patient only has disease in the brain, sometimes we treat the disease in the brain and monitor the patient off therapy. We know the disease is going to come back because already traveled to the brain, but it provides sometimes patients with time off therapy. We know that targeted therapy is easier to tolerate, but it has many side effects. It's not Tylenol, right? So sometimes it provides some patients with intervals without therapy. So oligometastatic is different on the oligoprogressive. It's still stage 4. We do treat a lot of these brain lesions, but it's also dependent on the drugs that are available because patients with ALK-positive lung cancer, now we're letting the drug treat the disease in the brain before going to treat the disease of the brain if the disease is if it's not widely spread in the brain. I hope that answered the question.
Yes, that was a very comprehensive answer. And I think definitely defining oligometastatic disease versus oligoprogression is extremely important because these terms are often inappropriately used interchangeably. So, clarifying that for the patient and for those that are listening is really important. So thank you for doing that also. We actually have a question here for Dr. Hirsch, switching gears a little bit to our first speaker. So this message is for you, Dr. Hirsch, asking about a patient's family member that had been diagnosed with non-small cell lung cancer in 2013, was treated with erlotinib or Tarceva with localized radiation. This patient had been managing well since then, but then unfortunately switched to osimertinib in December of 2021 and has noticed increased progression in this disease state on osimertinib. So in regards to targeted therapy, it appears that there are many modalities for EGFR mutations to develop. And since it appears that osimertinib is not working, would it be appropriate for this patient to then return back to erlotinib or Tarceva at this time after platinum chemo?
Well, that is a treatment question which needs to be discussed. The short answer to this is we don't have much of data, but the patient responded to the first generation or second generation, right?
It seems so, yes.
And progressed on osimertinib. I would first of all I would be sure we have a molecular profiling of this patient on this stage, so we exactly know the mutation landscape. It could be that the patient has transformed to a small cell lung cancer. It could be the patient has developed an MET mutation or a MET abnormality. It could be another abnormality. So important is to characterize the molecular profiling in the current situation. Now, if the patient still have an EGFR mutation and there are other options, we would in our institution have clinical trials for this situation. For the concrete question, should we go back to Iressa or erlotinib? That is a discussion the patient need to have with the individual doctor. There is not much of data.
Yes, thank you so much, Dr. Hirsch. Yeah, I mean, obviously we don't have all the data, so I think it's, as you said, difficult to answer exactly what to do in this situation. But thank you for your insights. I want to go to a question, I think, for Dr. Kim, which is talking about some, pulmonary events with alectinib. So the question specifically states that if there is development of clustered semi-solid peribronchial nodularity labeled as obstructive bronchiolitis with no issues, a concern being on alectinib for now 3 years.
So if the nodularities or the lung lesions are small and there's no symptoms associated with those, I probably would watch. The rate of pneumonitis on alectinib is really low. It's much lower than we would see with osimertinib, for example. And so, and personally, I have not seen anybody developing pneumonitis on alectinib, but we never say never. But doesn't sound like pneumonitis developing in this setting because we inhale a lot of things every day with every breath, and so just because we are seeing something on the skin doesn't mean that it's something serious. So if there are small, tiny, no symptoms, I would recommend monitoring again in consultation with the treating doctor.
Thank you, Dr. Kim. There is another, we've got some more questions coming. So there is another kind of more specific scenario question, and I encourage any of you to kind of answer as to the best of our ability with the given, data. So I'm going to read through the question. So this is a patient who is ALK positive, I believe stage 4, taking Alkanza or Alectinib for a year. Since January 2022, she has been taking a reduced dose of 900 milligram. On the last CT scan in June, there was a new lesion in the left lung and fluid in the right lung. All other lesions were stable or reduced. A patient went back to full dose of 1200 milligrams, and they made a biopsy of a new formation, passed the NGS for analysis. So the question is, until there is confirmation of the analysis, to stay on alectinib, or should they add chemotherapy with pemetrexed in this situation?
Is this for me or Dr. Flores? This is a tough question.
I think if any of you can take a shot at answering, it would be great to hear from all perspectives on this esteemed panel.
So the
Dr.
lesion.
Can you repeat some of the details? Sorry.
Yes, sure. So I think initially it seems like patient was started on alectinib, then there was some dose reduction, and then there was some new lesion in the left lung and fluid in the right lung. So I'm assuming there was some progression, and so the patient went back to the full dose. And it seems like there was a new biopsy done, and that was used for NGS. So I'm guessing the biopsy may have been from the progressive lesion. So the question is, until there is confirmation of the analysis, to stay on alectinib, or to add chemotherapy with pemetrexed. So I think the question is really asking that there is progression, there is perhaps a new biopsy, which is the NGS is awaited. So what to do while we're waiting for the NGS results, to stay on alectinib or kind of add chemotherapy with pemetrexed?
I think depends on the patient, how symptomatic the patient is with the disease progression. The number one thing about oligoprogression is how symptomatic the patient is. Because if the symptoms are not that significant, then we can wait for the NGS analysis, because sometimes, and ALK is less likely, you can find a mechanism of resistance that you can target with other drugs, with other oral drug, as we're learning how to do this, right? Because this wasn't a problem a few years ago when we didn't have that many options. So if the patient is not that symptomatic, I usually wait. If the patient is symptomatic, depends on the symptoms, right? So adding pemetrexed as adverse events, it can be added to alectinib or target therapy, because many clinical trials right now are evaluating chemo plus target therapy, and we know it's overall safe. What is not safe is to add the immunotherapy with the TKI as safe. So I think addressing the symptom is very important in this case. If the patients are having recurrent pleural effusions, then yes, we need to start treatment and addressing the pleural effusion. Also, it's important to understand if the symptoms are very bad with the pleural effusions, adding pemetrexed will not quickly resolve the pleural effusion. So will be two types of approach: address the symptom itself. Do we need a pleural catheter? How we're going to address these pleural effusions that are reaccumulated and making the patient symptomatic, and then adding the chemotherapy when you wait for the NGS. If the patient is not symptomatic, I usually wait, understanding that the wait is around 2 to 3 weeks. And I would love to hear what my colleagues do.
I would actually agree totally with Dr. Flores's comments.
Same here.
Yeah.
Yeah, no, thank you. I think that was fantastic, given the scenario that we were given. So thank you again, Dr. Flores. There's another question. So this time for Dr. Kim. What treatment recommendations are there for the small percentage that do develop pneumonitis? If EGFR positive and can no longer take erlotinib, are there any treatments available?
Right. Usually, so first line, I use third generation EGFR TKI like osimertinib, and if someone develops pneumonitis on, let's say, osimertinib, then I think about switching the therapy to a different EGFR TKI therapy, such as erlotinib plus ramucirumab, those kind of combinations. And I have had some patients who have tolerated other sort of EGFR TKI after they develop a pneumonitis on a certain EGFR TKI. So that's what I usually think about. There are some case reports out there to say that you could do osimertinib re-challenge after osimertinib-induced pneumonitis, but I haven't done that personally. It remains sort of case reports. And so I think about switch the drug in that setting and while carefully monitoring the symptoms.
I think that was a very, very thorough answer. I think we run into these issues where, unfortunately, patients develop pneumonitis and they feel almost frozen as if there's nothing left. So thank you for shedding a little light in that space. We have yet another question that's come in to the chat, more focused towards Dr. Hirsch, but I'm sure we would love to hear from others. And this is for someone that harbors a ROS1 fusion. So if you have a patient with stage 4 disease harboring a ROS1 fusion, any early data on the efficacy of repotrectinib?
Yeah, I don't know the data on top of my head, but some of my colleagues might know the data.
Can you, and a little bit, because we know there is some, yeah, I don't have the data. Let me say the same. I don't want to go in hypotheses and provide wrongful information.
Yeah, so I don't know the exact numbers. The first line number was pretty high, if I remember correctly, approaching probably high 80s or even 90%. So that's what I remember from the presentation. But I don't know the exact numbers off the top of my head.
We can Google it, but
that's right.
This might be a good question for us to circle back on and send out the answers through Maria, because I know we will be collecting questions at the end and making sure that they're addressed. So let's hang on to this question so that we can get this answer sent out at the end. But I thank you for that question. It's very interesting, and I hope to be able to get an answer for you shortly. We do have another question that came in, and this would be great for the entire group as well. What about a patient with an L1196M mutation while on lorlatinib? So this is a patient with stage 4 disease harboring an ALK fusion that developed a resistance alteration known as L1196M while on lorlatinib. What does this mutation mean for ALK to show up on a liquid biopsy?
One question is the mutation present in the liquid biopsy at the time of disease progression, or is only present in the liquid biopsy? Because we are learning how to monitor patients with liquid biopsy, but we still rely on CT scans to change therapy, because we certainly don't know what these mutations mean, and also depends on the allele frequency. How frequent are in the liquid biopsy? I monitor many of my young women with liquid biopsy, and I don't act. At least I have evidence of disease progression, because there is no data out there that suggests that I should do something for something that I found in blood. Why? Because it can be a very tiny little resistant mechanism that doesn't have a clinical significance. And I don't want to take my patient on a very well-tolerated therapy for something that I have very minimal to known data about it without disease progression. So I guess the question is do we have disease progression or not?
Yeah, I totally agree with Dr. Flores. There are clinical trials ongoing these days. Also in my institution, we have a clinical trial where we act on the liquid biopsy data, but that is in a clinical trial setting. That is different from clinical practice.
I also agree. Yeah. So the clinical status is more important than, I mean, it's wonderful to monitor dynamics of mutations, things like that, but the clinical status, as Dr. Flores and Hirsch mentioned, I think more important.
Yes, absolutely. Thank you, all of you, for that comment. I would also just mention, I think, as you know, the question wasn't very clear on whether there is true progression or not. But if there is, then obviously there's some data that's coming out that there may be compound mutations when patients are on lorlatinib. And so again, just a plug for all patients and caregivers on the call that, please consider enrolling on clinical trials if they are available. Talk to your treating physician to see there are new compounds coming up with the ALK, like 4th generation ALK inhibitors. So if that's a particular situation of progression, then I would definitely encourage you to discuss clinical trials for new compounds with your physician. We have another question, I think, again, for Dr. Kim. Do you find that side effects of TKIs gradually decrease as time goes on?
Yeah, I'm curious to know what my colleagues have experienced, but sometimes, yeah, some side effects I feel that they get better. For example, I have had some patients whose rash has gotten better over time. Is it because of the body kind of is more used to the drug, or is it because better management over time, the patient and then the team learned? It's a little hard to tell, but yes. But there's also some unpredictability in terms of the side effects. I would say rash, if that doesn't happen in the first year, it's kind of unusual to happen, let's say, after 1 year of therapy. However, pneumonitis or the cardiac toxicity, those rare serious side effects can happen anytime during the treatment course. So it's important to remain vigilant while you're on therapy. So I think the answer is some side effects, yes, but then we still need to be monitoring all the potential side effects over time.
And I'm just going to add, maybe because I was raised by a grandma, I do like to do a lot of grandma prevention with the side effects. And one of the things I really found helpful is, particularly for the skin, appropriate hydration with the appropriate lotions really helps with the rash. For the nails, and I treat a lot of younger women. So we talk about nail care right before therapy is started. And that has been very successful. So like no acrylic nails, because they're gonna follow easily with osimertinib. So a lot of those tricks that you learn during practice, I think has really helped me, not only prevent it, but dealing with them later. Like how to dye your hair, how to do this. Some of my patients have a food diary that I start for the diarrhea, because while the mechanism is different, there are certain foods that may precipitate the diarrhea more than others. So being very attentive to and find a food diary has really helped me manage the side effects. I have a patient that couldn't eat peppers anymore. Like these are sweet peppers. That would give her diarrhea. Before osimertinib, no diarrhea. And through the food diary and following up, she the peppers were the problem. And the diarrhea significantly got better by doing dietary changes, because we know the flora changes in the gut as well. So little things here and there, I think it really help. And I have to say, I cannot say because there is no data, but a lot of my patients had tricks that I have learned over time that have helped them manage the side effects.
I think you're absolutely right, Dr. Flores. Setting the stage and setting expectations for your patients, especially before they start therapy, helps, alleviate some anxiety and also helps them anticipate these things that may happen. So I love that you gave a plug for that, and your grandma-isms. So thank you for sharing that. We have, looks like one final question here in the interest of time. I know we're going to take a break for lunch. But it looks like there's a follow-up for that patient that had stage 4 ALK fusion with progression on lorlatinib. And the patient did confirm that, yes, unfortunately, there is disease progression. And this L1196M showed up on the liquid biopsy. So I think that the answer still is the same, that this may be a compound alteration, and looking for clinical trials in this setting is very, very reasonable. Obviously, I turn it over to the panelists to give their final thoughts on this question.
I agree with that. Also, I know they said they're sure there's progression, but how much progression? But I think a clinical trial is wise in this case. If that is not possible, there's other treatment options outside of clinical trials as well.
Yeah. Sorry. Go ahead, Dr. Hirsch.
No. I agree with this statement. It depends. Depends on the situation also. But these patients seem to have progressive disease on lorlatinib, so look for a clinical trial.
Yeah, I agree. The only thing I would add is that I have to go back to the heat map that Dr. Hirsch showed to us in terms of sensitivity, resistance, and if I don't just remember off the top of my head, L1196M is sensitive to lorlatinib or not, but if it's still sensitive on at least on the panel, understanding potential other mechanisms of resistance can be helpful. Perhaps tissue biopsy, things like that. But again, I don't remember this is resistant to lorlatinib or not. I will just put it out there that sometimes because resistant mechanisms can happen in multiple. Sometimes people can have multiple mechanisms of resistance. So we have to just think a little bit about this particular mutation and decide what to do, I think.
Well, thank you so much, everyone, I think, for your comments and your perspectives. And this is not just me saying it. We actually also got a comment that they're very grateful for your time and your perspective. So thank you again. I think we're kind of maybe a couple minutes late, but we're almost on time. So we will now move into a break for lunch. So thank you all for engaging with us, and especially thanks to the faculty, Dr. Hirsch, Dr. Flores, and Dr. Kim, for joining us and spending your Saturday with us today.
Hi, everyone. My name is Ibi Dagogo Jack. I'm a thoracic oncologist at Mass General, and it's my pleasure to present today on BRAF alterations, or rather BRAF mutations in lung cancer. And so we'll pull up the slides now. And so next slide. Sorry, just troubleshooting a little bit. Next, can we see the slide presentation? Okay, next slide. Perfect. These are my disclosures. Next slide. And so today in this short talk, I was hoping to discuss three main areas. First, we will describe the spectrum of BRAF alterations in non-small cell lung cancer. And yes, I kind of intentionally used the word alterations and not mutations. And next, we'll review how these diverse BRAF alterations can activate this key signaling cascade called the MAPK pathway. And finally, we're going to discuss the current strategies for targeting BRAF alterations, or rather BRAF mutations in this case, in lung cancer. Next slide. And so when we think about activating oncogenic alterations in lung cancer, we think about mutations like EGFR mutations, rearrangements like ALK and ROS1, and then sometimes we can get copy number gain like amplifications in MET. BRAF can be altered or activated in a variety of ways in lung cancer, but by far and away, the most common way that BRAF is activated is through a mutation. In general, BRAF alterations are present in about 4 to 5% of non-small cell lung cancer across studies. And the most common way that BRAF is activated is mutations. And the predominant mutation is actually a particular substitution at the 600 position called BRAF V600E. There are other non-V600 BRAF mutations, and that account for about 1 to 2% of non-small cell lung cancers. And in addition to mutations, there are rare BRAF fusions or rearrangements. These can be present in the cancer at kind of original diagnosis, or they can emerge as an acquired resistance event, for example, in the context of receiving targeted therapy for EGFR. So captured here are images from this publication by the Foundation Medicine Group, really summarizing kind of the diversity of BRAF rearrangements or fusions that can be seen, as well as all the single point mutations that have been described in the BRAF gene or BRAF protein, kind of illustrating the point that the high peak right there, V600, is where the majority of these mutations are, but there are a clustering of other key mutations in the kinase domain. Next slide. And as mentioned, traditionally, we've really focused on V600 BRAF mutations. And that's because these were initially described in melanoma, where they're seen in about 40 to 50% of cutaneous melanomas. And we've borrowed a lot of our therapies from melanoma. In melanoma, it is rare to see non-V600 mutations. But in non-small cell lung cancer, we tend to think that, almost half or even more than half of mutations are non-V600 BRAF mutations. there have been kind of elegant studies over the last few years that have really taught us that it's more than just BRAF V600E and non-V600E, but rather when you look in the lab, there are functional differences between different BRAF mutations that have led us to actually subcategorize them, not just into V600 and non-V600, but rather class 1, 2, and 3. So class 1 is comprised kind of exclusively of that traditional V600 mutation, includes V600E and V600K. And then class 2 and class 3 really encompass the majority of the remaining mutations. And we'll talk about why we distinguish between class 2 and class 3 in upcoming slides. But as captured here, when you look across, and this is based on an internal study we did here at Mass General in collaboration with Dana-Farber, where we looked and kind of assigned BRAF mutations to distinct classes. And what we found is that there are still mutations that we don't know if they're class 1, 2, or 3, meaning we don't know the functional consequences of them. But for the most part, about 40 to 50% of mutations are class 1, and the remainder of the mutations, if we know their function, are kind of subcategorized into class 2 and class 3. And as you see here, if you look at different positions, whereas V600 predominates as a V600E, when you look at different positions like G469, there are different mutations that can arise. And that's important because they have different functional implications. So if we go to the next slide, it is important that another key concept that distinguishes BRAF mutations from when we think about MET, EGFR, and other things, when we think of MET and EGFR, these are kind of receptor tyrosine kinases or signal via this mechanism. They're on the surface of the membrane, they have an external signal, and they transmit it inside of the cell. BRAF or the RAF proteins are part of this complex and very important signaling cascade called the MAPK signaling cascade that has a bunch of important components, starting with that receptor tyrosine kinase on the surface. Then we have RAS proteins, the most important of which are the one you're probably most familiar with is KRAS. Then we have the RAF proteins. There's ARAF, BRAF, and CRAF. We're focusing on BRAF for this talk, but as you'll learn as we go on to a few more slides, CRAF matters too when we think about BRAF mutations. And downstream, we have MEK and ERK. Those are the key proteins that BRAF is signaling through to send proliferative signals to the cell. So the next slide. And so these proteins matter, and this signaling cascade matters when we think about this class 1, 2, and 3 BRAF mutations. As mentioned, class 1 is our classic V600 BRAF mutations. These, unlike in normal cells and in other BRAF mutations, where you need two BRAF proteins to join together and form a complex, we call that a dimer, to send signals to MEK and ERK, the V600 mutation in and of itself is fine. And so the protein can signal as a single, what we call a monomer. It doesn't need upstream input from the receptor tyrosine kinase or RAS, and it can activate MEK and ERK. Class 2 BRAF mutations are a little bit different. They too don't need RAS signaling or RTK signaling, but they actually rely on the dimer that we talked about. They need two BRAF proteins to trigger downstream signaling of MEK and ERK. Class 3 is a bit of an anomaly in that they are not truly activating mutations, in that they still need that receptor tyrosine kinase input and RAS input, but they basically amplify the signal from those inputs to signal for MEK and ERK. I know this is a lot of biology, but I'm going into it because I think it illustrates kind of the underlying principles why some medicines work for certain classes, but not others. So the next slide. And so what strategies have we used to target BRAF mutations in lung cancer? So I will admit we've borrowed most of our strategies from melanoma. We've essentially repurposed melanoma's therapeutic strategies. And for the most part, the focus has really been on V600 BRAF mutations or class 1 BRAF mutations. And the first strategy that was explored in melanoma and in the context of non-small cell lung cancer was blocking this atypical or abnormal V600 protein that signals as a monomer or a single protein instead of that dimer complex. So these are selective medicines that are made to block that single BRAF protein. The first one I wanted to discuss is called Dabrafanib. This is actually approved for BRAF V600E mutant non-small cell lung cancer. And in phase 2 studies, it demonstrated an objective response rate of around 30%, disease control in about 60% of tumors, and a median progression-free survival of about 5 to 6 months. And what that means is that from the time you started the treatment to the time the cancer progressed, on average was about 5 to 6 months. And so if we look at the next slide, there's another kind of BRAF monomer inhibitor that has been kind of selectively developed to block the V600 protein, and that's called vemurafenib. This is also approved for melanoma. This trial design, I think, is interesting because it's a little bit different here. Whereas the prior trial design I talked about looked specifically at V600E, this looked at all kind of V600E and non-V600 BRAF mutants and kind of explored efficacy in this context. Similar to what we saw with Dabrafanib, the objective response rate was around 45% in V600, and the median progression-free survival was around 5 to 6 months. Interestingly, however, if you look at the green bars, these are patients with non-V600E BRAF mutations. The objective response here was 0%, with just blocking the BRAF protein with these selective inhibitors. Next slide. But what we learned from melanoma and kind of what we've learned from non-small cell lung cancer is that 30 to 40% is great, but it isn't quite kind of top line, what we expect from our really efficacious targeted therapies like ALK-targeted therapies and EGFR targeted therapies, where we see 60 to 70% response rates, and which led people to kind of explore why cancers were becoming resistant to BRAF inhibition alone. And it turned out that the cancers were reactivating kind of MEK and ERK downstream, kind of inviting the question, what if we did what we call vertical blockade? We block BRAF and we block MEK, which is the protein directly downstream of BRAF. And so these are the combinations that are actually currently approved in non-small cell lung cancer with BRAF V600E mutations. This is that same study we looked at first that was just looking at Dabrafanib, the BRAF inhibitor, in V600E non-small cell lung cancer with V600E mutations. Here, they've added a MEK inhibitor called trametinib, and we see a doubling of the response rate from around 30% to 60%. The disease control rate, so how many tumors are at least stable, goes up from about 60% to about 80%, and the median progression-free survival increases from about 6 to 9 months. Here, it's a little confusing because they looked simultaneously in patients who had never received treatment and some who had received chemotherapy. And so that's where kind of their different numbers reported there. But nonetheless, this demonstrates that when we do a combination therapy, we get better outcomes. And so this really distinguishes BRAF from our other targeted therapies where we give a single pill blocking kind of a single protein. Here, we're blocking 2 key proteins in this MAPK signaling cascade. Next slide. And so what do we lose, or we know what we gain from efficacy, but what might we lose in terms of toxicity from combining a MEK and a BRAF inhibitor compared to if we did a BRAF inhibitor alone? So these drugs, I will admit, are a bit tougher to tolerate than our kind of osimertinib or Tagrisso or lectinib and medications like that. There are certain class effects, one of which is pyrexia or fevers, and these can be pretty challenging for patients. They're not associated with infections, and they do respond to Tylenol and stopping the drug and reducing the BRAF inhibitor specifically. Other key side effects are gastrointestinal, such as nausea, diarrhea, and vomiting. The rate of these, or the frequency of these, does increase a little bit when you add the MEK inhibitor to the BRAF backbone. We also see edema or swelling in the legs. And interestingly, if you do kind of BRAF blockade alone, the KRAS is actually important for skin cancers. And so you get this kind of interesting circuit where people's skin cancers actually grew on when you block BRAF alone. And so when you block MEK, there's actually a reduction in kind of KRAS-driven skin cancers from about 12% to 4%. So that might minimize that particular type of toxicity. In general, as mentioned, these drugs can be a bit harder to tolerate. And so 1 in 10 patients, or a little bit above that, 12% discontinued therapy in this study, and 60% required a dose interruption, and 1 in 3 patients required a dose reduction. In my clinical practice, I tend to dose reduce the BRAF inhibitor before the MEK inhibitor. So next slide. So in the context of other targeted therapies, the reason that we're really improving prognosis is that people have simultaneously studied what causes resistance and developed new therapies for next-line therapies. And in some contexts, we've even actually leapfrogged the older therapies by using the next-line more potent therapies, such as an ALK and EGFR. So what do we know about resistance to kind of BRAF combination therapies? I think the key point is that although we've known about BRAF for a while, what we know about resistance is, to be honest, a little bit rudimentary compared to kind of the depth of what we know about resistance for other targets. We do know that the cancer really doubles down on that MAPK signaling cascade. It finds ways to make the cancer dependent on RAS or dependent on or turn on that downstream signal MEK. And so what people have seen is that there's a variety of KRAS, NRAS, and other RAS mutations that make the cancer dependent on not just kind of that single BRAF protein for signaling, but a dimer complex that involves BRAF and CRAF. And you see in that context, it's not helpful to just block BRAF. They've also seen mutations that activate MEK downstream to make it such that trametinib cannot bind. And so that has informed kind of the design of ongoing studies and newer therapies, including pan-RAF inhibitors that can block both BRAF and CRAF and can also block dimers, not just monomers. And also combining these pan-RAF inhibitors with newer MEK inhibitors or ERK inhibitors, that key signal downstream of MEK. And I do want to point out that I focused on Dabrafanib and trametinib because those are approved in non-small cell lung cancer, but there are other kind of BRAF MEK combinations, including Vemurafenib and Cobimetinib that's approved in melanoma, and another one that's making its way through phase 2 testing in non-small cell lung cancer called Encorafenib and Binimetinib that we are eagerly awaiting results for because that one is already approved in melanoma and colon cancer. So next slide. And so I had mentioned at the beginning that the whole story is not V600 mutations, right? There are other classes of mutations, and it would be great if we could just repurpose our existing therapies for all BRAF mutations, but it seems like that will not be the case. As we already saw from that study that I presented of Vemurafenib, the response rate to a BRAF monomer inhibitor was 0% for these class 2 and class 3 mutations that signal as dimers. What happens is that if you just block one part of the dimer, the other one becomes hyperactivated and you actually get way more signaling through MEK and ERK. But the story isn't as kind of dismal when you do talk about MEK plus BRAF combinations or MEK inhibition by itself. Turns out that in the lab, there are certain BRAF mutations, particularly these class 2 ones that are already activated, that can benefit from blocking BRAF and MEK. Next slide. And that has actually borne out in the clinic in case reports. And so the first case report was published by Negrao and McCoach and colleagues, where it describes kind of the benefit from Dabrafanib and trametinib, that approved BRAF MEK combination that's only approved for V600 BRAF mutations. They basically gave it to a patient who had a class 2 L597R BRAF mutation. And as you see here, there's a response in the lung lasting over a year. Another case I wanted to highlight is a patient of mine who had a G469A, which is perhaps the most common class 2 BRAF mutation, and also benefited from Dabrafanib and trametinib, so that BRAF MEK blockade, as we can see here with shrinkage of a liver lesion, and this response lasted about 6 months. I should note that at the beginning, we're focusing a lot on mutations, but at the beginning, I did mention that BRAF can be activated by fusions. These fusions are probably kind of most important in the context of blocking other targets, such as EGFR. I just want to note that the combo of BRAF and MEK inhibitor is actually efficacious or has good activity in that context as well. So adding that to the backbone of EGFR targeted therapy in case reports, but as you can imagine, toxicity can be quite substantial. Next slide. And so to summarize kind of what we've talked about, I think it's key to mention that when we talk about BRAF mutant non-small cell lung cancer, we're still scratching the surface in terms of the functional consequences and also finding efficacious therapies. We have good therapies for BRAF V600 mutant non-small cell lung cancer. And so one key point I want to remind all of us is that BRAF altered non-small cell lung cancer encompasses diverse alterations, and there are 3 main strategies that are used to activate downstream signaling. And that matters when you're trying to think about the therapy to use. For Dabrafanib and trametinib, the therapy that we have currently approved is only for class 1 or V600 BRAF mutations. And what we know about resistance to this combination suggests that the cancer really wants to find a way to reactivate MAPK signaling, often at the hands of a new RAS mutation. And in this context, it's not, the strategy that might make the most sense is kind of something that blocks both CRAF and BRAF. Another thing to note is that where are we going in the future, right? The future is really focused on non-V600 BRAF mutations. And there have been novel kind of preclinical studies that have demonstrated encouraging efficacy. These are therapies that block pan-RAF, as I mentioned, BRAF and CRAF, but are also kind of getting away from the historical principle of only blocking monomers or the single BRAF mutation protein and going towards dimers. These are dimer breakers or dimer inhibitors. And then there's a class of therapies that I didn't have a chance to talk about called SHP2 inhibitors that are particularly efficacious in the preclinical setting for those class 3 mutations that are dependent on RAS, because SHP2 is it crosstalks or talks closely or communicates closely with RAS. And so this is a space to keep an eye out on. I think that we will have multiple kind of new promising clinical trials in this space in the future. And with that, thank you for your time. And I'm going to turn it over to our second speaker and take questions at the end.
Good afternoon. Can you hear me?
Yes, we can.
Yes, we can. Okay, thank you. So I'm gonna share my screen. I'll try to share rather. All right, I might have to ask you to share. Sorry. I have it ready here, but I don't know why it's not pulling up. Thank you. Okay. Welcome again. Thank you so much for this opportunity to talk to you all. I am Nagashri Sitaramu, thoracic oncologist at Northwell Health in New York. Next slide, please. These are my disclosures. Next slide, please. Okay, so I am going to be talking to you about NTRK, NTRK, or neurotropic tropomyosin receptor kinase gene fusions and TRK proteins. I just want to walk you through normalcy and cancer. So the TRK genes, so the NTRK genes are important for neuronal development, for nervous system development. They are expressed in normal nerve tissue, and they have roles in development of nervous system and nervous system function. So on the right-hand side, I have a figure that tells you about the three genes that we'll be focusing on, the NTRK1, NTRK2, and NTRK3. They are on different chromosomes, and they don't have, they're not close to each other. They're on different chromosomes. And they result in manufacture of proteins called TRKA, TRKB, and TRKC. And as I said, they are important normal tissues. However, sometimes these genes can either flip over, jump over to another gene, and cause what we call as chimeric fusion proteins, whereas a part of the NTRK gene links with another gene and creates a fusion protein, a fusion gene that can lead to hyperactivation of the system. And I'll show that in the next slide. So the TRKA, thank you. As I mentioned here, you see in the middle, you have the TRKB for an example. So when you talk about the receptors, these are molecules on the surface of the cell. For activation to happen, for the signals to be transmitted from outside to inside the cell, resulting in cell growth and proliferation and going to other places, you need the two receptors to come together. So it's called dimerization. So the dimerization happens when there is a signal from outside. The signal is called a ligand. So that when that happens, there's triggering of downstream pathways, as you can see here, the RAS pathway, the PI3 kinase pathway, and the PLC gamma. The PLC gamma is important for neuronal differentiation. The other two pathways are important for cell differentiation and proliferation, meaning it's important for cell growth, the cell to divide and go to other places. So when the flip happens, you don't need the ligand anymore. The activation happens without any ligand necessary. Next slide, please. Sorry about that. Okay, so I just want to talk to you about the NTRK fusions and other NTRK gene variants. the fusions are important, but there are also other mutations and other variations that can happen with NTRK. So generally, the fusions are formed, as I said, either by flipping of the NTRK gene, NTRK 1, 2, or 3, when the NTRK sequence is the 3', one of the ends of the gene it just jumps into another gene or 5' sequences of other genes. The result is what is called an oncoprotein that causes the TRK kinase ligand independent activation, meaning you don't need the ligand anymore. The pathway is open, it's activated, just the dimerization is constantly there, and that leads to cell transformation, proliferation, and other invasiveness, going to other places and all that stuff. However, it should be noted that all fusion partners they do not have typical dimerization domains, and not all structural rearrangements result in productive fusions. So not all rearrangements result in pathogenesis or in cancer development, and not all, and definitely not mutations or gene amplifications. They have not validated to be targets for treatment. So it's important to know that when you're reading a report. Next slide, please. Next slide, please. Oh, so this is the timeline of discovery. I mean, back in 1982 was when the first fusion was detected. This was the TPM3 NTRK1 in colon cancer specimen. It took so many decades for it to be recognized as an oncoprotein and for it to be targeted for medication. Next slide, please. So when we talk about NTRK fusions, it should be noted that there are some tumors, both in adults and pediatric population, that have this fusion occurring more frequently than some others. So, for example, the secretory carcinoma of the salivary gland and the secretory breast carcinoma all have 75% or above. And there are some other tumors like lung cancer, for example, which we're talking about today, where the frequency is less than 5%. In fact, in most population-based studies, is less than 1%. Next slide, please. So again, as you note here, there are some that are the fusion is actually defines the tumor. It's necessary for diagnosis as well. For example, the secretory breast carcinoma or similar secretory analog salivary gland carcinoma, infantile fibrosarcoma, where the frequency is over 90%. Whereas in lung cancer, the frequency is much less. And in fact, these fusions can occur in leukemias and other liquid malignancies as well. Next slide, please. So what I want to say here is that it is really, for some tumors, it is like searching for a needle in a haystack. There are many ways you can perhaps search for a needle in a haystack. You can put your head in it and search for it, rummage through the entire hay, or you can try to use a magnifying glass and try to look through every part, or you can have it color-coded and see if you can identify it faster. You can perhaps use a magnet, perhaps, or do an X-ray, or perhaps use multiple methods. And that's what seems to have, perhaps be the best strategy here when we are looking for NTRK in lung cancer. Next slide, please. So how do we implement the NTRK fusion testing in clinic? So we'll talk briefly about the tools to find these fusions, and when and how to test patients, and strategies for optimal testing and obtaining results in a timely manner. Next slide, please. So there are many algorithms that have been developed. This is the ESMO recommendation, where you, first of all, identify the histological type, where the tumor came from. And if it is something that is highly associated with the NTRK fusion, then you go on to do a confirmatory technique. If it is not something that is frequently associated, then I think sequencing is extremely important. So the next generation sequencing is important. We'll talk about the DNA platform and the RNA platform, but essentially we will need that to identify. But if that's not available, there are some other cheaper, easier techniques that can sometimes be used and can be perhaps used as a screening tool. And we'll talk about that again. Next slide, please. Okay, so this is perhaps another way another algorithm to consider, again, based on histology and then based on genomic testing. Again, if it is lung cancer here, if you can look at the bottom left, this is not very common. So next generation sequencing has become, fortunately, a very common thing. It's a normal thing for us to do. And again, there are differences between DNA testing and RNA testing here. And we'll talk about that. Next slide, please. So this is the immunohistochemistry. As you can see, there are different, if you do the immunohistochemistry, you can actually see the protein. This is the TREC-A-B, it's a pan-TREC protein that is stained. You can see where exactly the protein is located. Is it within the nucleus? Is it within the membrane? Is it within the cancer cell? Or is it within the normal lining? So it is an important way to kind of look into this, but it doesn't give us much details, much more than the staining itself. Next slide, please. So what are the possible ways to test? We spoke about the immunohistochemistry, which you saw on the previous slide. It is just staining the cells for the TREC1, the TREC-A, B, and C. And then you get rapid results. You just perhaps need just one slide. But, when we are looking for when we have very little tumor material to work with, you can do slides for pretty much every gene. So it becomes important when you're looking for multiple genes in the same specimen. FISH is another test. I didn't go too much into it, but basically it looks at, again, the part of the NTRK is stained, and then a part of another molecule, the common partner is stained, and then we see whether the two are together or they're apart. And there are different ways of doing it within FISH itself. And again, it requires a couple of slides, maybe one or two slides, gives rapid results, but it doesn't really give us information about what the exact fusion partner is, and sometimes it doesn't tell us if it is really an important fusion that has led to cancer as well. The next generation sequencing is what we use today, and this is rapid throughput. Entire gene is searched through for multiple genes, and then the fusion partners are identified. There's a longer wait time, and of course, there's a cost associated. When you look at the reports, you might see that it's a DNA-based assay or an RNA-based assay. Both of them are pretty good, but it should be, I just want to point out here that the RNA-based assay, meaning is the DNA, is the print, right? I mean, is the nuclear print, and then you have the RNA. The RNA is right next to what the protein is. So it gives us more information about whether what the DNA actually did, what was actually transcribed, and what led to cancer. So the RNA-based sequencing is a direct information, and it's also more sensitive, and it's helpful to detect some rarer fusion targets because there are so many targets. There are multiple targets that are identified. Next slide, please. So talking about treatment, so now that we have spoken about what this is, there are two currently available treatments for both adult and pediatric patients. One of them is the larotrectinib, and the second one is the entrectinib. So the larotrectinib is for adult and pediatric patients with solid tumors with an NTRK gene fusion without a known acquired resistance mutation, who are either metastatic or not candidates for surgical resection. In fact, in NCCN, it is recommended as a first-line treatment. Similarly, entrectinib is very similar, and it is also for the same population. It's also effective against another pathway that you discussed earlier, the ROS1 positive metastatic patients. These two drugs were approved without the necessity for the type of tumor. So pretty much the tumor can come from anywhere. It could be from lung, it could be from salivary gland, it could be from thyroid. As long as the fusion is present, these drugs are approved. So it's called a tumor agnostic approval. So this we are seeing more and more of this, and this is really an important move, an important development in approval of drugs today. Next slide, please. So the larotrectinib was evaluated in multiple studies, and this is the result of a pooled analysis from 3 phase 1 and phase 2 clinical trials. So there were 153. It's a very rare tumor, and you can it's hard to accrue. So 153 patients. The objective response was 79%, very impressive. Many of these patients had received other treatments as well. There were complete responses, meaning there was no tumor detected on subsequent scans. Partial response was 63%. Another 12% of the patients had stable disease without any progression. Only 6% of the patients had progressive disease identified. So very, very effective drug. Next slide, please. And this shows what is called, this is called a waterfall plot. Anything below the x-axis suggests that there was a decrease in the measured tumor. Anything below the 30% mark is considered as a partial response. Anything that hits 100% is a complete response. So the curves, the graph is very indicative of what the responses look like. Everything is below the x-axis. Next slide, please. These are curves that represent, if you take the 108 patients in the beginning, and there are patients that are lost either, because they didn't survive or they were lost for other reasons. And then at the end, at 42 months, 50% of the patients are still had a continued response. The same thing with the progression-free survival in the bottom. Next slide, please. So these are the studies that are ongoing. This is not even a current slide. Whenever there is a situation like this, it's always important, I think extremely important to look at the clinical trials that are actively accruing. There are trials that are accruing for patients who, for first line, meaning not treated with any treatment, or patients who have been on prior treatments with larotrectinib or entrectinib and have either not responded to it or have progressed after receiving it. Next slide, please. So this is the entrectinib, similar study, the phase 1-2 pooled analysis. The response here was 57%. There were patients with CNS disease, meaning a tumor that had gone to the brain or the lining around the brain. And even in those patients, the response was 50%. It was very similar in patients with or without CNS disease. There were complete responses, partial responses, stable disease, and again, progressive disease was only seen in 7% of the patients. Median duration of response is the amount of time that the patients were on treatment without having, maintained the response. They had a response and they maintained a response for the duration of time. It was 10.4 months. As you can see, the range was very variable, 7.1 on the lower bound, and it was not achieved. It was not evaluated at the upper bound. So a lot of patients continue to have response after a long time. Progression-free survival is without progression. So it is a little different than the duration of response, and that was 11.2 months. Next slide, please. This is again the waterfall plot on the top, and the second one is what is called the swimmer's plot, and the last graph is what is the duration of response. So all of these are very impressive. The swimmer's plot is tracking individual patients and seeing how long they're on treatment and if they're continuing on treatment beyond, and or if they stop treatment for whatever reason. So these are all different graphical representations of the efficacy of the treatment. Next slide, please. So this is again, the progression-free survival and the overall survival, as you can see, the graphs, it may not seem, extremely attractive, but you can see that with this difficult to treat population, there was no progression at 18 months for several patients, and then the overall survival lasted beyond 2 years for 50% or something of patients. Next slide, please. So unfortunately, every story like this has to have a second leg to it. There are mutations, there are resistance pathways that develop to most of these type of targeted treatments. So the resistance can be on target, meaning now we are trying to block. So the larotrectinib and the entrectinib block the pathways by just fitting into the socket. The socket itself may undergo a change, meaning there's a mutation that happens, and I've listed all the several mutations that have been noted, and that creates a poor binding. The drugs don't bind anymore, and they're no longer effective. So we had to kind of come up with a different strategy. Or it could be off target. So again, you block at the top, the bottom molecules in the pathway may get activated. So sometimes, either changing the drug, there are some newer generation drugs that are being developed, or sometimes you can combine the entrectinib, larotrectinib with another drug, blocking the downstream pathways. So there are several things that are going on, and again, clinical trials here are extremely important. Next slide, please. So again, in a nutshell, NTRK gene fusions are oncogenic drivers, but not all NTRK gene alterations are drivers. It's important to know. It's variable frequency in different cancers. Pediatric cancers have higher frequency than adult cancers, and some of the cancers have much more higher frequency than others. Lung cancer belongs to one of those that has the lowest frequencies. All solid tumors, especially those without another oncogenic driver, should be screened. It's extremely important to do that. The next generation sequencing is the most efficient, RNA-based, perhaps more sensitive than the DNA-based. Currently, we have 2 approved agents. There are multiple ongoing studies. There are resistance pathways, but there's a take 2 on this. There are newer drugs on the horizon with very promising data. With that, I will end, and thank you so much for this opportunity. I'll take any questions.
Dr. Dagogojek, can you see the questions on your screen under attendee questions?
I can, but it says no questions.
Let's see here. I can read them out. I can see them on my screen. So it says that given that side effects can be tough with the dabrafanib, trametinib combination, and immunotherapy can also work for patients with BRAF mutations, is it clear which should be preferred as first approach? Is targeted therapy clearly the best first-line therapy?
I think it's a very good question. And I think that we have to break it. It's a good and a very nuanced question is how I should say it. And so in terms of immune therapy for other drivers or other molecular alterations, we shy away from using immunotherapy. And these tend to be alterations that are enriched among people who have not had much exposure to tobacco. So when we look in the context of BRAF, about a quarter of patients have not had exposure to tobacco, whereas about 3/4 have. I think that I would hesitate a little bit in the context of people who have not had tobacco exposure to prioritize immune therapy in that context. But for others, when people have looked retrospectively, of course, we don't have any head-to-head comparisons where they've said, half of the people will get a combination of a BRAF MEK inhibitor and the other half will have immune therapy. And so we're left with kind of retrospective analyses where people gather data from a bunch of patients and try to summarize what the outcomes were to immune therapy and then compare them to kind of what we've seen in clinical trials of targeted therapy. It does look, for the most part, that compared to all comers, meaning kind of regardless of what mutation you have, with and all comers who receive immune therapy compared to those who have BRAF, that the outcomes to immune therapy are comparable in a lot of studies led by the French group. And so I think that you're exactly hitting on the point, right? There are many providers who will start with a immune therapy, chemo-immune therapy combination before moving on to a BRAF inhibitor. And that's why, the current trials that are running, the phase 2 trial of the Oncobini that I talked about, encorafenib, binimetinib, as well as the Dabrafanib, trametinib trial, explored the efficacy both as a first-line therapeutic and also after chemotherapy. I think the key thing that they have all noted is that the efficacy doesn't change dramatically, and so we're seeing similar response rates and similar kind of median PFS. And so I don't think it is wrong to prioritize immune therapy and chemotherapy. I do want to point out, though, that we've seen in other drivers that when immune therapy lasts in your system for such a long time, that when you start a pill therapy, sometimes it enhances the toxicities associated with pill therapies. It does not seem like that is fully the case with BRAF MEK targeting and immune therapy, because in melanoma, they've done these studies. And so there was an ongoing study in this space of kind of a BRAF MEK plus immune therapy upfront that was being run by Pfizer that we're still awaiting information from.
Great. And Dr. Sitharamu, your opinion?
I agree. I think, with regards to NTRK, I think use of immunotherapy, we don't have that much data, but these, unlike the EGFR and the ALK, I think immunotherapy might actually be effective in these type of tumors. And I think combination strategies, participating in trials perhaps is the best. We'll probably have more information about this now that we're using immunotherapy in the neoadjuvant and the adjuvant space. But I do think that these, unlike the other genomic alterations, I think there's better data or better efficacy for immunotherapy agents.
Looks like there's another question here. I guess you answered it to some degree. It's about our NTRK. So in your practice, do you clearly, if you see an NTRK alteration or NTRK rearrangement, do you prioritize targeted therapy in that context, or do you defer it?
Yes, no, definitely. I think that is also what is recommended on the NCCN guidelines. And, with something that is close to 100% efficacy, I would not, think twice. However, I do want to point out that, there may be occasions where the NTRK fusion was not detected, and patients were treated with either chemotherapy or chemoimmunotherapy, and they were subsequently, found to have this fusion. It's not wrong to treat with, if you didn't know about it, obviously you're not going to, treat that fusion. And again, in the studies that I showed, the phase 1 through 2 studies, patients who were previously treated with chemotherapy and other drugs responded equally well to the pills. So I wouldn't worry about it too much if I were to have been treated, if I had NTRK fusion and I were to be treated with something else previously.
Yeah, so I can speak to BRAF, I guess. So the question that has come in is, do these agents, presumably kind of BRAF inhibitors and NTRK inhibitors or targeted therapies, have any role in the locally advanced or earlier stage? Or are they limited to the advanced setting? So BRAF MEK combinations in melanoma are actually approved for locally advanced disease, so stage 3. In non-small cell lung cancer, that is not the case. But this question probably speaks to the recent approvals of EGFR targeted therapies in the early stage setting and the ongoing studies that are really exploring, we have great benefit from these therapies in advanced disease. If we move them up, can we kind of make more people achieve cure? Can we suppress the disease more? I would say that in the context of BRAF mutant lung cancer, we don't know. But there are ongoing studies that are kind of exploring both adjuvant. So after someone has had the cancer removed, given somewhere between 2 to 3 years of these targeted therapies, versus neoadjuvant, before you remove the tumor, giving a few months of the therapy, removing the tumor, and then either giving outback treatment with the targeted therapy or chemotherapy. Another question that's here. Seeing a few pop up now.
Sorry, where do you go for questions?
I guess I'm seeing them in the chat and attendee questions, but I think that we've hit a few of them. Okay. I guess one question for you: does your institution, are you doing RNA based or DNA based?
Yeah. So we are, as a reflex mechanism, we're doing DNA-based studies. But if you don't identify a genomic driver, let's say there's no EGFR or Braf, and then there's a high suspicion, either based on histology or other reasons, then we do a second step, which is RNA-based NGS testing. And I think that's, many other institutions have adapted the same pathways.
Yeah, I think that that's important. And you highlighted some key points about RNA-based. I think one cool thing that that has been highlighted and emphasized as well is the immunohistochemistry, right? And I think that that type of strategy, I think that one keynote you made is that that type of strategy makes sense for something that's enriched for it, right? If you're working with a big population of infantile fibrosarcomas or mammary secretory analog carcinomas, but do you think IHC is a practical thing for non-small cell lung cancer?
No, definitely. That's why I wanted to show. I mean, again, it shows it's very clear when it's positive, but it can stay in normal tissues, and it doesn't really give us much information. So when it's not enriched, meaning when the frequency is very low, doing an immunohistochemistry is not so useful.
So we invite any questions you might have.
This is Maria. I'm not seeing any more questions come in, but I wanted to thank everyone for joining this session and remind everyone that we will be reconvening at 2 to talk with our patient advocacy specialist, who will be discussing how to find your people in the community. And I wanted to give a special thank you to both of the doctors who joined us today, Dr. Dagogojak and Dr. Sitharamu. Thank you so much for your knowledge and for being here with us today.
You're welcome. Everyone have a great afternoon.
Thank you so much.
Okay. Good morning, good afternoon, and good evening, depending on where you are in the world. My name is Alejandro Calvo. I'm a medical oncologist. I work at Kettering Cancer Center in Dayton, Ohio, which is in Southwest Ohio, just north of Cincinnati. And before I start, I want to thank Dr. Jack West and the GRACE organization for all the efforts they do on behalf of our patients. I was asked to give a presentation on ROS1 rearrangement in non-small cell lung cancer. And the first slide shows a picture of the beautiful cancer center where I practice. And I want to make a comment that the treatments of lung cancer are evolving like technology, and I'm using the example of cell phones. When I was in my third year fellowship, I went to ASCO, and this was the most awaited presentation, ECOG 1594. At the time, the standard of care for lung cancer was a platinum doublet, but we didn't know which one was better. Was it paclitaxel? Was it gemcitabine? Was it docetaxel? So this was actually compared head-to-head, which is unusual in oncology, and was presented in ASCO. And just to give you a reference on the timeline, comparing with cell phones, that was a fancy cell phone. At the time, if you had that flip phone in your hand, you were rolling high. I didn't have it. Mine was a brick. So when the study results came out and they were presented, the results showed that all the platinum doublets were exactly the same. There was no significant differences. The survival was 8 months. Response rate, 19%. The time the tumor took to start growing again after response, a little bit below 4 months. And the 1 year survival, 33%. And the reason I'm bringing this here is because if you didn't go through these times, you sometimes take for granted all the benefits we're enjoying now. So I want you to remember the response rates I'm showing you with chemotherapy and the time the tumor takes to progress again. Remember, it's below 4 months. So back then, we were in this part of the curve where we had lung cancer with two flavors, small cell and non-small cell. Really, if you just had non-small cell, that's all you needed to put treatment, platinum doublet. And later we started learning that the histology makes a difference. So a patient with squamous histology has different characteristics than non-squamous. And most importantly, there are some drugs that can have untoward side effects on patients with squamous cells. So we started making that differentiation. Then we moved to recognizing that there are different molecular pathology subsets, and some of them were able to be targeted. And since the cancer cells were addicted to those pathways, which is what you've been hearing throughout the morning today, that had a significant impact on the response that those patients had. And most recently, we have been using immunotherapy, and we use an imperfect biomarker called PD-L1 to make our decision in that treatment. So if you do molecular testing in your non-squamous cell lung cancers, about 50% or more are going to be found to have a mutation that can be targetable. And I think that's very, very important compared to what we were doing at the beginning of the molecular area. So in 2022, this is the complex treatment paradigm that we use regarding molecular biomarker positive advanced non-small cell lung cancer. You see here 8 potential targets. If you add HER2, which is what my colleague, Dr. Thompson, is going to talk in the next segment, you have 9 targets that you can use with different treatment options, either in first line or second line. So it's very important to identify those patients and do the test. Now, once you have the molecular testing results and there is no targetable alteration, that's when you start paying attention to the PD-L1 expression. And for the caregivers in the audience, I want to make sure that this is an important sequence that you have to remember. What is ROS1? We're going to dive deeper into ROS1 now. ROS1 gene is located in the chromosome 6, and it encodes a receptor tyrosine kinase that is part of the insulin receptor family, and it goes in the cell surface. It's very similar to the ALK receptor. The sequence of amino acids, it's equal in more than 50%. So that's the explanation why some of the drugs that work for ALK work also very well for ROS1. Now, ROS1 fusions are oncogenic. They were first identified in human glioblastoma cells several years ago, and the first partner that was identified attached to ROS was FIG, or fix in glioblastoma. The second tumor reported to have a ROS rearrangement was non-small cell lung cancer, and since then it has been reported in other tumors, including cholangiocarcinoma, ovarian cancer, gastric cancer, colorectal cancer, and angiosarcoma. So when you look at these fusions, the particular part on ROS1 is that there are at least 14 partners available for fusion that we know of. And this is different, for example, with ALK, where you have only one partner, EMLA4. Out of these 14 partners, the most common one that we see in lung cancer is CD74, or cluster of differentiation 74. So you have ROS1, CD74 together. In the other percentage, so different partners play a role. And at this point, whether you have a CD74 or non-CD74 partner does not seem to be important yet. But some of the newer publications are looking at the fact that CD74, when a partner for the fusion, may have more aggressive behavior towards the CNS and therefore worse prognosis. So stay tuned on that. So these ROS1 fusions are oncogenic, and they lead to a ROS1 kinase unregulated activation. The example I give to the patients is the light switch is always on. It's not on demand. If it's dark, you turn it on. If it's light, you don't. Here, it's always on, and it's activating intracellular pathways like JAK-STAT, PIK3, and MAPK, which are the ones that lead to the behavior, malignant behavior of those cells. So I'm going backwards. These fusions are usually seen in adenocarcinoma histology, very rarely in other histologies like large cell or squamous. The incidence of ROS1 rearrangement is 1 to 2% of non-small cell lung cancer. If you do the math based on the numbers we saw in 2021, for example, we should be seeing anywhere between 2,000 and 4,000 new cases of ROS1 fusion non-small cell lung cancer every year in the United States. The clinical features of ROS1 malignancy is very similar to ALK, affect patients that are younger. Usually we see that in non or light smokers, and it has a higher tendency to affect the central nervous system with brain metastasis. On average, about 36% of patients have brain mets. And to put it into context, on a non-small cell lung cancer that doesn't have any molecular abnormality, the rate is usually 10 to 20%. And if you look at ALK, which I'm sure you already heard before, the incidence is closer to 50%. So it's more common in women, and when present is mutually exclusive with other alterations. ROS1 positive tumors should be treated with targeted therapy. That's an important concept. Now, to do that, you need to identify them. And how do we make the diagnosis? We need to do testing on the tumor. And you can do immunohistochemistry, you can do fluorescence in situ hybridization, what used to be the standard for ALK and ROS at the beginning. You can do PCR, but most recently we're doing next generation sequencing. And when you look at the differences, there are advantages and disadvantages related to price. Turnaround time, for example, if you use IHC, you're gonna get your results very quickly compared to NGS. But at least in the United States, we're using NGS because it does simultaneous testing. You have several tests running on the potential targets you can use, and it has a little bit of longer turnaround time. You have to pay attention now whether the panel you're using is DNA-based or RNA-based because the sensitivity may be different. All of the ROS1 targeted drugs are multi-kinase inhibitors. And at this point, we have 2 FDA drugs that are approved, crizotinib approved in 2016 and entrectinib approved in 2019. There are other tyrosine kinase inhibitors that are available, but they are not approved. They include ceritinib, brigatinib, lorlatinib, repotrectinib, and most recently, taletrectinib. And you have heard these names in prior presentations today. So the crizotinib, this is a potent oral TKI that targets not only ROS1, but also ALK and MET. It's given at a dosage of 250 milligrams twice daily. Most of the adverse effects are grade 1-2. That means they are minor. They include vision disorders. Usually patients report light trails on the peripheral vision, some edema, diarrhea, liver enzyme elevation, sometimes constipation. So this is the study that led to the approval of crizotinib by the FDA. This is the Profile 1001 study that was published by Dr. Shaw and her team in 2014. And this is an expanded cohort of 53 patients with ROS1 positive non-small cell lung cancer. The response rate was 72%. Disease control rate, which means any type of response or stable disease, 90%. And a progression-free survival, that means how long did it take for the tumor to start growing again? 19 months. And I want to remind you, the slide I showed at the beginning with chemotherapy, response rate with chemotherapy, 19%, time that takes for the tumor to grow back, less than 4 months. So big improvements. In this study, the most common partner was CD74 for the fusion. And because of this, crizotinib made it to the NCCN guidelines back in 2013, and it was approved by the FDA in March 2016, and almost at the same time by the European equivalent of FDA, the EMA. Now, like it happens in most of the molecular treatments we do nowadays, we run into resistance of subtoin. And for crizotinib, there are 2 options. The most common one is a mutation in the ROS1 kinase domain. That happens in 60% of cases. The most common resistant mutations, G2032R and D2033N. The second type of mechanism is off-target resistant. That means a resistant mechanisms away from ROS1, and there have been descriptions of KRAS G12C or upregulation of EGFR signaling. And I know that we have an alphabet soup of letters and numbers that we are always trying to remember. So it's interesting, when I was working on these slides, I was changing the battery of one of my electronic devices, and I ran into this, 2032. So if that helps you remember, use it. What do we do after crizotinib fails? There are several options, TKIs, either ceritinib, brigatinib, lorlatinib, entrectinib, there are reports on cabozantinib and repotrectinib. And you can see that the response rates in first line are very high compared to crizotinib. There are responses with second line. But the part I want you to pay attention is which drugs have efficacy against the solvent mutations in ROS1. If you see the most common one, G2032R, most of the drugs on the left side of the chart do not work for that, including entrectinib. There are only 2 medications that targets G2032R, and they are cabozantinib and repotrectinib. So that gives you an idea how important is what some of the previous presenters have mentioned today, that we need to biopsy at the time of progression to see what we're dealing with. Let's talk about entrectinib. This is a multi-kinase blocker of ROS1, NTRK, and ALK. It can cross the blood-brain barrier, so has a good CNS activity. It's more potent than crizotinib, and FDA approved its use in ROS1 fusion-positive tumors in 2019 at 600 milligrams once daily. This was approved following the pooled analysis of 3 early phase studies, the Star Trek 1, 2, and the ALCA 372. There was an efficacy population of ROS1 positive non-small cell lung cancer that were treatment naive, 53 of them. And there was a safety population that was larger with prior treatments. If you see in this study, the median age was 53, which is young for patients with lung cancer on average. They were mostly, the majority were female. The majority were either never smokers or light smokers. And CNS disease at baseline, 43%. And again, we're seeing this pattern that ROS1, ALK, some of these molecular abnormalities do go with higher incidence of CNS metastasis. The response rate was high in the 70 to 80% range. And there was a difference whether CNS disease was present at baseline or not. And if you look at the bottom of the slide, the median duration was about 2 years in patients who didn't have brain metastasis at presentation versus just a little bit above 1 year, 12.6 months in patients who had CNS disease at baseline. The intracranial responses, patients who came into the trial with stable, either treated or asymptomatic brain metastasis, the response was 55%. And the duration of response was respectable at 12.9 months. Safety-wise, most of the adverse effects were grade 1 or 2. They were reversible. You've heard these side effects with other TKIs, like lack of taste or dysgeusia was very common, fatigue, and a lot of GI side effects, as well as some liver enzyme elevation. If you look at the right side on the safety slide, grade 3, 4, those are the more severe side effects. The ones that really stand out are fatigue, 2.8%, weight gain, probably related to edema, 5.1%, and anemia. Only 3.9% of patients had to discontinue the medication because of side effects, which speaks of a good tolerance to the drug. So entrectinib is an active ROS1 inhibitor with durable responses in patients with ROS1 positive non-small cell lung cancer, either with or without brain metastasis. There is a durable intracranial activity reported in patients with baseline CNS disease, and it's a drug that is tolerated and has a manageable safety profile. We're going to move to another one, lorlatinib. You've heard about this drug again when the ALK presentation was given earlier today. It's a third-generation ALK and ROS1 inhibitor. On a phase 2 trial in ROS1 positive non-small cell lung cancer, 57% of patients had baseline asymptomatic brain metastasis. The overall response rate was 41%, but if you look at the subset of TKI naive, so untreated patients with molecular, the response rate was 62%, 10% was complete response. The response rate in crizotinib treated patients a little bit lower at 35%. Progression-free survival, 21 months, which is longer than what we are used to seeing. And there was an intracranial response rate of 64%. So very active drug, especially CNS. Side effects, the prior speaker talked about edema, peripheral neuropathy, some cognitive effects, and an unusual side effect of elevation of cholesterol and triglycerides that sometimes leads to therapy need. So the clinical activity of lorlatinib is similar to other available TKIs. It has an excellent CNS control with a response rate in that trial of 64%, has efficacy against crizotinib-treated patients, except if they have the G2032R mutation. So remember, that's a key factor. So it's an attractive second-line option, and it's not FDA approved at this time. Repotrectinib, if you read the literature from a few months or years ago, the name is TPX005. It's a second-generation ROS1, ALK, and TRK inhibitor. It inhibits ROS1 with a greater than 90-fold potency compared to crizotinib, so very potent. Common side effects, again, you've heard this from the previous presentation: dizziness, taste disturbances, some numbness and tingling, and constipation. On the TKI naive group, in this case, 22 patients, you can see that the response rate was in the 90% range, 91%, with a duration of response that almost 2 years. And you can see the side effect profile on the right side, similar to what we just discussed. There was a cohort of patients, I'm gonna get your attention to the third line, ROS1 positive, TKI pretreated, so they were exposed to crizotinib or another TKI, but no exposure to platinum-based chemotherapy. Response rate 67%. That led to the FDA 2 months ago granting a breakthrough therapy designation to repotrectinib for the treatment for patients with ROS1 positive metastatic non-small cell lung cancer, previously treated with 1 line of ROS1 TKI, but not received platinum-based therapy. So basically, second line. One word about chemotherapy. It remains an acceptable treatment for ROS1-driven NC or non-small cell lung cancer, either second line or first line if the TKI is not available, whether because of finances or excessive toxicity. The response rates are very high in this population of patients because ROS1 cancer cells tend to have a low level of the enzyme that clears chemotherapy. So there are reports of response rates in the 60 to 70% range. For pemetrexed, single agent is lower at 27%, progression-free survival 7.5%. So if you see better response rates and better progression-free survival than the original chemotherapy trials, but not as good as TKI therapy. In the case of ROS1, we don't have the trials that compare chemotherapy to TKI like we do for EGFR and ALK, but there was a retrospective comparison between chemo and tyrosine kinase inhibitors, and as expected, the response rate with TKI was 86%, with chemotherapy lower at 44%. Immunotherapy. Everybody wants to receive immunotherapy. We have patients watching TV ads for drug A or B, and they want it. So a retrospective study of 551 patients with drivable mutations was done with immunotherapy. A small subset, 7 of them had ROS1 rearrangement. Interesting, the PD-L1 expression, 90%, but the response rates were lousy, 14%. So the key problem here is that if these patients don't have molecular testing, they only run PD-L1, or they only get PD-L1 first, and they don't wait for molecular studies, they are gonna get the wrong treatment. So similar to other oncogenic-driven non-small cell lung cancer cases, there is no evidence to support the use of immunotherapy in the initial stages of treatment in lung cancer patients. In conclusion, crizotinib and entrectinib are effective first-line treatments for ROS1 rearranged non-small cell lung cancer tumors. Entrectinib is preferred in patients with brain metastasis due to the CNS activity it showed. You may want to obtain tissue at the time of progression to identify what type of mutation is driving the progression, or if there is a secondary mechanism that could guide your treatment. Lorlatinib is a reasonable second-line treatment as long as G2032R is not present. Repotrectinib is a promising new agent that overcomes the most common mutations or resistant mutations and has a significant CNS activity. So it has the best of both worlds. So stay tuned. We're going to be hearing more about Repo in the near future. So I want to give you a message to take home today. Please make sure, if you're a caregiver, test for molecular alteration, whether you do tissue, whether you do CT, DNA, or liquid biopsy, before you make your treatment decisions in patients with advanced non-small cell lung cancer. If you're a patient or caregiver, and if you're still on time, please demand to have molecular tests done and available when reviewing your treatment options. And please, using the cell phone analogy, don't be like this guy who's stuck in the past. Thank you.
Well, great presentation, Dr. Calvo. I really like the "don't be stuck in the past" and cell phone analogy. So my name is Dr. Jeffrey Thompson. I'm an assistant professor of medicine at the University of Pennsylvania. Full disclosure, I'm a pulmonologist with expertise in biomarker testing in non-small cell lung cancer. And today I'm going to talk to you about HER2 mutated non-small cell lung cancer. So I'm sure all of you may know that the treatment landscape from non-small cell lung cancer has really evolved quite dramatically over the last 2 decades, as Dr. Calvo's picture really so eloquently pointed out. But I think this has been in large part due to understanding of lung cancer genetics. And really over the years, we've been able to increasingly identify these genetic alterations, which are oncogenic drivers in non-small cell lung cancer. And this has really enabled the development of therapies that target these specific oncogenic driver mutations. And I really like this schematic from the Lung Cancer Research Foundation that just demonstrates, by decade, the number of therapies that are available for our patients. And you can see in the kind of blue pill cartoon here, the kind of rapid expansion that we're seeing in the number of targeted therapies that are available for our patients. This is just another schematic that was published in Nature Reviews Clinical Oncology last year, just highlighting the number of FDA-approved therapies for non-small cell lung cancer that have occurred just in the last decade. And you can see in the blue boxes represents the targeted therapies that have been approved. And you can see in the early 2000s, these FDA approvals were rather sparse, and that these have really accelerated quite rapidly in the last decade or so, with now multiple different targeted therapies for a number of oncogenic drivers available for our patients. And this pace has really continued over the last several years. And I think targeting these oncogenic driver mutations is really driving a lot of the survival gains that we're seeing in non-small cell lung cancer patients. So I just highlight here that this is a Kaplan-Meier curve showing survival probability here in the y-axis and months in the x-axis. And this blue line represents patients that had a specific oncogenic driver mutation detected that were then treated with the appropriate targeted therapy. And it was identified that those patients had improved overall survival compared to these patients in the orange line who had a specific oncogenic driver mutation detected but did not receive the effective targeted therapy. And so it's not only important to test patients for specific biomarkers and oncogenic driver mutations, but that they receive the appropriate therapies. And unfortunately, we still have some work to do to ensure that our patients are receiving comprehensive biomarker testing for all of the various oncogenic driver mutations for which there are targeted therapies available at diagnosis. This was some data that was presented at last year's ASCO meeting that evaluated over 3,000 patients with non-small cell lung cancer and looked at whether they had guideline recommended comprehensive biomarker testing at diagnosis. And unfortunately, only 37% of these patients received comprehensive biomarker testing prior to receiving a first-line therapy. And so, just as Dr. Calvo mentioned, I empower you to be knowledgeable about appropriate biomarker testing know your biomarker, and really encourage others to know their own biomarker testing at diagnosis, because this is such a critically important thing to ensure that our patients are receiving the most effective therapies. And as Dr. Calvo mentioned, don't be stuck in the past with an old cell phone. So these are the current biomarker recommendations put forth by the National Comprehensive Care Network. So in non-squamous histologies, current recommendations are that patients receive PD-L1 immunohistochemistry and genetic mutation testing for mutations in EGFR, ALK, ROS1, BRAF, KRAS, MET, NTRK, and RET. And in squamous histologies, patients should have PD-L1 immunohistochemistry, and then they should be considered for broad molecular testing in the similar way that you do testing in non-squamous histologies. And they also highlight emerging biomarkers, which include HER2 mutated non-small cell lung cancer and MET amplifications. And I'm going to spend the rest of my time really focusing on HER2 mutated non-small cell lung cancer. As highlighted here, there's been very recent data showing efficacy of a number of targeted therapies for HER2 mutated non-small cell lung cancer. And I think it's really become a specific genetic alteration within non-small cell lung cancer that really should be incorporated into routine testing in our clinical practice. So you might see HER2 is often in the literature referred to as ERBB2, so we typically use these synonymously. It's detected in approximately 2 to 3% of patients with non-small cell lung cancer. Here in this pie chart is some data from a multi-institutional cohort of over 700 non-small cell lung cancer patients that underwent genetic sequencing. And you can see here that the ERBB2 or HER2 mutation rate was 2.7% in this population. When you look at a larger population, this is the American Association for Cancer Research Project GENIE, which is an international cancer registry that contains genomic information from a number of different cancer types. In non-small cell lung cancer, this involves over 10,000 patients with genetic sequencing. And then here at the top, you can see that ERBB2 mutations are present in about 3.1% of this population. In preparation for this talk, I had the opportunity to pull our own genetic sequencing data in our lung cancer cases. And in our Penn lung cancer genomics data, where we've sequenced over 4,000 lung cancer cases, the HER2 mutation rate was approximately 2.8%. So this 2 to 3% in non-small cell lung cancer has been pretty consistent across a variety of different cohorts. This specific mutation appears to be mutually exclusive with other oncogenic driver mutations. So if one is identified to have a HER2 mutation, you're unlikely to have an additional oncogenic driver mutation in EGFR or ALK or ROS1, for instance. The majority of these mutations occur in exon 20 as either an insertion of amino acids or a duplication of exon 20. And then similar to other oncogenic driver mutations, HER2 mutations tend to be more common in female and patients who are never or light smokers and that have an adenocarcinoma histology. HER2 mutant non-small cell lung cancer patients have a high incidence of brain metastasis during the course of therapy. So this was a study looking at brain metastases in patients with HER2 mutations compared to other subtypes of non-small cell lung cancer. And you can just highlight in this pie chart the kind of red section here, which are patients who develop brain metastases on treatment. And you can see that the patients with HER2 mutant non-small cell lung cancer tend to develop brain metastases on treatment at a higher rate than some of the other molecular subtypes. So this is just something to keep in mind when thinking about novel targets for HER2 mutations and whether they have CNS penetration, and for designing clinical endpoints of clinical trials and monitoring these patients on therapy. The current first-line standard of care for patients with HER2 mutant non-small cell lung cancer still remains to receive chemotherapy plus immunotherapy combination. We do have some data to suggest that patients with HER2 mutated non-small cell lung cancer have similar outcomes and response rates to chemotherapy, immunotherapy regimens compared to an unselected population of non-small cell lung cancer patients. However, a big question in the field is really, can we do better and improve outcomes in these patients by specifically targeting the HER2 signaling pathway? And so just a little bit about the HER2 signaling pathway in general. So you can see HER2 in the little blue receptor here. It is part of a HER receptor family, and that family includes HER1 or EGFR. And typically what happens is that a certain stimulus binds to one of these receptors, and then these receptors come together. And that activates a downstream signaling pathway that then tells the cell to grow in an unregulated fashion or develop resistance to cell death and enable it to metastasize. And when the HER2 receptor acquires a mutation in it, this no longer requires a specific stimulus. This activation pathway is always on, telling the cell to constantly grow, develop, and be resistant to cell death. And so really the major goal in developing specific drugs to target this pathway is to really stop this activation pathway and inhibit this downstream signaling and induce cell death in these HER2 mutated tumor cells. And so over the last 2 decades, there has been a tremendous amount of work and progress made in targeting the HER2 signaling pathway. And I've just highlighted the main drugs that have been developed to date. These involve both non-selective and selective tyrosine kinase inhibitors. And these tyrosine kinase inhibitors bind the intracellular domain of the HER2 receptor, kind of blocking this downstream signaling, causing cell death. There are also HER2 monoclonal antibodies such as trastuzumab that bind the extracellular domain here. And then more recently has been the development of anti-HER2 antibody drug conjugates. So these are monoclonal antibodies directed towards the HER2 receptor that attached to these are chemotherapeutic agents. And so what happens is these monoclonal antibodies bind the receptor. That receptor is then internalized, thus releasing the chemotherapeutic agent into the cell, inducing cell death. So HER2 targeted therapy has been very effective in other tumor types. And now there are a number of HER2 directed therapies approved in both breast cancer and gastric cancer. So really a major question in the field has been, can we apply these same therapies in HER2 mutated non-small cell lung cancer? And so over the last decade, there have been a number of clinical trials evaluating a number of different therapies that have demonstrated some promising results for patients with HER2 mutated non-small cell lung cancer. And this was a recent editorial that was published in the New England Journal that just highlights some of the most pertinent trials that to date in HER2 positive non-small cell lung cancer. And these initially started with these non-selective tyrosine kinase inhibitors, which showed very modest objective response rates with very limited disease control rates. And then that progressed to trials involving selective HER2 tyrosine kinase inhibitors, which demonstrated improved objective response rates anywhere from 20 to 44% in our patients. But the duration was rather limited, with median progression-free survivals of 5 to 6 months. And these drugs were associated with a number of toxicities. The monoclonal antibodies directed towards HER2 and non-small cell lung cancer have also demonstrated modest anti-tumor activity in HER2 positive patients. But we've recently received some really exciting results in HER2 mutated non-small cell lung cancer patients by utilizing these antibody drug conjugates, which I'm going to talk about in a little more detail. So just going back to our little schematic, here again highlighting these anti-HER2 antibody drug conjugates. So what this is a monoclonal antibody directed towards HER2 that has a chemotherapeutic agent attached to it. And when it binds to the HER2 receptor, that receptor gets internalized and then releases that chemotherapeutic agent into the cell, and subsequently it induces cell death. And just earlier this year, we received results from a multi-center international phase 2 study looking at trastuzumab deruxtecan in HER2 mutated non-small cell lung cancer. And this evaluated a total of 91 patients with HER2 mutated non-small cell lung cancer that have progressed on a number of previous therapies. And in this trial, we saw objective response rate of 55%. The median duration of response was 9.3 months, with a progression-free survival of 8.2 months and an overall survival of 17.8 months. So these were very exciting results, and I'll just go through the trial just in a little bit more detail. So when we look at the patient characteristics, it's very similar to what we see in HER2 mutated non-small cell lung cancer patients. There was a total of 91 subjects in this trial. The median age was 60. There was a female predominance, and the vast majority of patients either were never or light smokers. The vast majority of patients had received several lines of previous therapy, with a median number of 2 lines of previous therapies. The vast majority of patients, 66, had received previous immunotherapeutic regimen, and 14% here had received a previous tyrosine kinase inhibitor directed towards HER2 signaling. And just highlighting again, the response rates were 55% with a duration of response of 9.3 months. Median progression-free survival was 8.2 months and overall survival of 17.8 months. And then here is the waterfall plot from the trial, with a waterfall plot in the y-axis is the percent change of tumor from baseline. So patients that have shrinkage of their tumor, these bars go down. And you can see the overwhelming majority of patients in this trial, the bars go down, showing that most patients had a reduction in the tumor size while on therapy. So very exciting results. And it's important to mention that grade 3 or higher drug-related adverse events did occur in 46% of patients. These were mostly GI or hematologic adverse events. However, one adverse event that's important to note with these therapies is that potentially serious interstitial lung disease did develop in 26% of these patients. Now, the vast majority of these were grade 1 and grade 2, but 2 patients did die in this trial from interstitial lung disease. So moving forward, I think it will be important to understand why this specific drug is associated with this toxicity, and that patients on these therapies need to be monitored closely for this toxicity. So I think with these results, trastuzumab deruxtecan has really established itself within the treatment paradigm of HER2 mutated non-small cell lung cancer patients. And I think we just need further data about where does this really fit, within that paradigm. And fortunately, there's already an ongoing trial looking at this therapy in the frontline setting. So this is the trial schematic of the Destiny Lung 04 study. That's enrolling locally advanced or metastatic non-small cell lung cancer patients with HER2 mutations. These patients are naive to systemic therapy, and they have no known other oncogenic mutations. And the patients are being randomized 1-to-1, with one arm receiving trastuzumab deruxtecan, and the second arm receiving standard of care chemotherapy immunotherapy combination, with the primary endpoint being progression-free survival. So really exciting. This trial is ongoing, which may incorporate this therapy into the frontline setting. So in conclusion, as the number of targeted therapies continues to expand, having broad molecular testing to identify potential oncogenic driver mutations is really critically important, as Dr. Calvo mentioned. HER2 mutations occur in approximately 2 to 3% of non-small cell lung cancer patients. And great progress is being made in the development of novel therapies targeting HER2 signaling, with multiple targeted agents showing promising results with trastuzumab deruxtecan being the best to date. And that further research is really needed and / ongoing to develop biomarkers to predict efficacy, understanding these mechanisms of resistance, to develop novel combination strategies, and defining optimal sequential treatment strategies. So with that, I really want to thank you for your attention, and I think we'll move on to the Q&A session. Thank you.
I'm going to start, Jeff. I see the attendee questions. There are two questions there. The first one is, how often do patients with ROS1 abnormalities end up with a second mutation? And this is an interesting question because the traditional thinking, as I mentioned in my presentation, is that these mutations are mutually exclusive. So if you have EGFR, you can put money and bet that you're not going to have any of the other mutations. But we are testing more patients and we're using more sensitive panels. So we're starting to get reports on double mutations or double trouble, if you want to call it. There are some reports of two different EGFR mutations. For example, del19 exon 21, that's considered a double mutation, or del19 and T790M mutation. And those are fairly simple to tackle because you're going to use the same treatment for either. The problem comes, what if you get a combination of EGFR and ALK? And there are case reports of that. The question is, which one should you target? Which one is the driver of the cancer? And, you know, it may be due to tumor heterogeneity, that different parts of the tumor have different drivers. But unfortunately, those patients, in all reports that have been published to date, have a lower response rate and a worse outcome. So it's not a good thing. I did see, to be more specific with your question, ROS1 and ALK mutation. There is a case report published in 2017. And of course, that's, again, an easy answer because the drugs you're going to use are going to cover both. The problem is, what if you get EGFR and ROS1? And I think, you know, the drugs don't cross cover, so that would be a problem. Some of the reports, again, do show that you treat for EGFR first, but those patients are not going to respond that well. And I'm not aware of data on covering both at the same time, if that's what the question was going to. I hope that answers the question.
Dr. Calvo, maybe you can answer, get your input on this too, from this question. Since there isn't an FDA-approved treatment for HER2 mutated lung cancer yet, where should targeted therapy fit into the sequence for when to give it?
Yeah, this is a very interesting question. And if we look back, we've been asking that for most of the new drugs. You know, they do show activity in early studies, usually heavily pretreated patients. And the question is, where does it fit? I can tell you there is a publication in New England from January this year about 91 cases of HER2 mutated cancers that were pre-treated with chemotherapy and had no standard treatments left. And when they were treated with trastuzumab deruxtecan, the response rate was very robust at 55%. So if I have a patient with HER2 mutation that runs into that situation, I think the answer is clear. You want to use it for second, third, fourth line. But the biggest question is, can it be a more effective drug if you use it in earlier phases, similar to what you do with EGFR? And I think that's the trial Jeff, you mentioned earlier in your presentation, studying the effects of that medication in first-line therapy of these patients.
Yeah, I agree. I think we need to wait that trial, and we just don't have evidence to date yet treating patients up front with specific HER2 targeted therapies.
If history repeats, if you have a 55% response rate in second, third, fourth line, I can almost guarantee you those patients are going to behave like the EGFR patients or ALK patients with very high response rate. The question is the toxicity going to be a problem? And, we don't want to assume, we want to actually try it and do it.
Yeah, exactly.
And I think those are the only two questions we have in our panel at this time.
Right. I think that if we have no more questions, then we can end a little early if there are no more questions.
Well, thank you, everybody. Thank you, Grace. And Jeff, pleasure seeing you.
Yeah, Dr. Kelma, great seeing you, and I want to thank Grace and all the organizers and all the patients in attending. It was a wonderful event, and thanks for the opportunity to present.
Thank you both very much. This was great. Oh, we have one more question or a comment. Actually, we have a couple more comments coming in.
I think I'm gonna. Okay, so the one question is, are there any upcoming trials and medications to look forward to? And the answer is yes. There are trials with a new NTRK inhibitor. I'm not gonna dare to remember the name, but it's, I believe, has an L in the, so stay tuned for that one. Because we're seeing all these ROS1 inhibitors that have greater CNS effect and also higher response rates in the second line in patients that were treated with TKIs before. So I think that's what is showing improvements. And the second question is, I believe, related to adjuvant treatment. It says, what do you think to give in early stage ROS1 positive lung cancer? Should we use crizotinib? So I'm going to assume it's asking about adjuvant treatment. What do you do if you have a resected stage 2 non-small cell lung cancer that happens to have ROS1 rearrangement present? And the answer is, at this point, we don't know. There is not information. If you think that the same history with EGFR is going to repeat, and we're going to go back to the ADORA trial that was mentioned earlier in this presentation, maybe that's going to be the way to go. But because of the implications of cost, commitment to a treatment for 2 or 3 years, and potential toxicities, I think we have to wait for formal clinical trials before we make a formal recommendation. But it looks a very attractive idea to do that.
Great. Well, if we don't have any more questions, let's give it a second here to see if anyone pops any questions in at the last minute.
Dr. Calvo, just you had highlighted about the importance of biomarker testing. How do you have reflex testing at your institution? How do you ensure that all your patients have
that's the million-dollar
first-line therapy?
$1 million question, Jeff. We just had a tumor board. We have a tumor board with other hospitals participate. And there was a patient who had advanced disease, was on cycle number 4 of chemo. And when I asked what was the molecular information, it was in process. So we came up with a lecture that this is really unacceptable in 2022. You have the option for liquid biopsy. And normally the turnaround time in the worst case scenario is 3 weeks, which is, in my opinion, too long. And that brings the question, should we do reflex testing? And I think in the ideal world, the answer is yes. If I'm a patient that is diagnosed with non-squamous, non-small cell lung cancer, at the time I go see the medical oncologist, I would want them to see all the histologic, all the immunohistochemistry, and the molecular studies, just like our breast cancer patients do when they come see me. We don't need to initiate that, at that time, because that's another 2 or 3 weeks. But I think the main obstacle has been always financial and logistics. But I think we're coming to that point. At least in my hospital, I work in a community hospital. It's a teaching hospital, but it's community. We're going to try to do molecular testing in-house. And I don't know if that's going to facilitate the process. But I think that's very important, because you're really missing out as a patient if you don't do targeted therapy, especially at the beginning of your treatment. If you get on chemotherapy, especially if you're EGFR and you go on chemoimmunotherapy, that's, in my opinion, a disservice to the patient. So,
absolutely. And as you pointed out, people are so quick to, that ROS1 having high PD-L1 status, to focus on the PD-L1 while the genomic information is pending.
And the confusing part is that even though when you read the literature, some of these targetable mutations are associated with a low PD-L1 expression, actually, I see a lot of high expression in some tumors. I've seen actually 100% PD-L1 and EGFR mutation. And sometimes the physician is saying, should I do this or immunotherapy? And if you know the data, there is no question. You don't treat with immunotherapy. Those patients don't respond well to immunotherapy. So yeah, I think correct testing is key in these cases.
There's one other question, saying there are some papers suggesting that hormonal therapy can reduce response to treatment. What are your views?
I guess I'm going to tackle that one, Jeff. I'm not familiar with the papers, but we do know that some lung cancer cells, adenocarcinoma, do express estrogen receptors. So it makes sense that if you do hormonal therapy, you could have actually the opposite of what you're trying to do. But I don't think has been looked at formally in clinical trials. So the answer is I don't know. But I would be careful if you're taking hormone replacement therapy, for example, and your tumor is not responding. We normally don't test for ER expression. But if you talk to a pathologist, there are lung cancer tumors that will express ER. And if that has in some way a role in tumor growth or a cancer pathway, that could be a problem. So wishy-washy answer, but not very clear.
Yeah, I was going to say I'm also not familiar with that literature, but certainly could make sense depending on the expression patterns of the patient-specific tumor.
Yes. Fortunately, in clinical practice, we don't like to do hormonal therapy when somebody has cancer because thrombogenic tendency is a problem. So that's a rare, but I think it's a good question. And the attendee just clarified that they were talking about hormone replacement therapy. So I think our answer does cover that. There could be a potential of deleterious effect. So if HRT is not that important and you're dealing with advanced lung cancer, probably you don't want to take it.
Okay.
All right.
Well,
We finally have exhausted all the questions from the group.
so if there's no more questions, we can give it just a second again. And if there's no more questions, we can go ahead and wrap up the session. Looks like there's no more questions. Thank you both so much.
Thank you.
Thanks, everyone.
Have a good day.
Bye-bye.
Good afternoon. My name is Dr. Angel Chin. I'm a medical oncologist at the University of Michigan, and it is my pleasure today to talk to you about EGFR mutant non-small cell lung cancer. Here are my disclosures. So we know now in 2022 that non-small cell lung cancer is made up of different drivers. When I say drivers, I mean that there are changes in the DNA of the cancer itself. And when these changes happen, these mutations, it changes how the way the cell functions. And the way I like to describe it to my patients is that it turns on a signal. It's an on switch for the cells to continue to grow without really being under the body's control. Luckily for us, now in 2022, we have all these different identified mutations. I have those in the green boxes. And we also have drugs that act then in my, the way I describe as an off switch. And the one today that we're going to focus on is on the far left, and these are the EGFR sensitizing mutations, for which you can see that there's 5 different drugs that are already approved in this setting. So what is EGFR really? So EGFR stands for epidermal growth factor receptor. And there's actually a family of 4 of them in the ERBB family, and EGFR just happens to be ERBB1. And you see that there's 3 others. When we talk about receptors, what we mean is you'll see that there's that green Y. That's a simple way to depict how these proteins work. So what happens is that there's a signal that comes to this receptor, and when the signal is received, the downstream effects will occur, and I can illustrate that here. So there's a signal from outside the cell, goes in the receptor, and that leads to different signals. In the case of EGFR, those signals lead to cell growth. What happens when you have an EGFR mutation is that now you don't really need this external signal, that blue dot, that this downstream pathway is always on. So irrespective of whether or not the cell is receiving a signal, cell growth is always happening. And that kind of, in a very simple way, defines what cancer is. It's just cell growth that is not being controlled by the body. EGFR is actually a normal part of your body. It's found in the skin, your GI tract, aligning different parts of your body. But when it becomes mutated, as it can in lung cancer, that's when the problem arises. So in non-small cell lung cancer, we think it accounts for about 10 to 15% of all the non-small cell lung cancers that we see in the United States. We most commonly find it in a specific type of non-small cell lung cancer called an adenocarcinoma. We also find it more frequently in patients who are female and patients who have light or never smoking histories. However, I really want to emphasize that it is always important to check for this. So even if a patient is male, even if someone has a smoking history, it does not mean that they for sure do not have one of these mutations in EGFR. And therefore, it is always important to check, especially when we're talking about metastatic disease. And it is considered a standard of care and is recommended by multiple national guidelines to check. So EGFR TKIs, and TKI here stands for tyrosine kinase inhibitors, and it just describes how certain medications work. And it's really changed how we treat these cancers. And on your right, you'll see that I've listed 5 currently approved EGFR TKIs for the treatment of metastatic EGFR non-small cell lung cancer in the United States. So as you remember, I mentioned that the EGFR mutation in this instance acts as an on switch. What happens with these drugs is that they come here and they block that EGFR mutation. And so whether or not you have a signal, it does not matter. That signal to continue to grow is turned off. And that's how these drugs can help us treat these cancers by turning off their signal and therefore resulting in cancer cell death. One question I most commonly encounter is, well, doctor, you told me you have 5 different drugs that are approved. How do you know which one is the best one? I would say that at least in the United States, the standard of care is really with a drug called osimertinib, and its trade name is Tagrisso. And it's really become the standard of care, in my opinion, for metastatic EGFR non-small cell lung cancer based on this clinical trial. This is called the FLORA study. The blue line shows how patients did with osimertinib. The red line shows patients who received other EGFR TKIs. And you can see here that the blue line is doing better than the red line. And in this situation, we saw that the use of osimertinib led to a longer overall survival compared to the other EGFR TKIs. We think the reason that osimertinib works better is that it's more specific to that EGFR mutation. So it doesn't affect the normal EGFR as much, so it's more tolerated. Osimertinib also seems to do a better job at getting to cancer that may try to go to the brain, because we know that unfortunately lung cancer is one of those cancers that do like to go to the brain, but osimertinib can help penetrate the blood-brain barrier and help treat cancer that may go to the brain. When we talk about drugs, though, of course, we know that there are side effects to really any drugs that we give. And the side effects of EGFR TKIs are pretty simple to understand once you've realized when I mentioned that EGFR can be normal, and it's in fact found in parts of your body, such as the skin and the gut, and in different parts of lining. So we think about the side effects, the skin side effects. Think about an acne-like rash. We can see nail changes. We can see some skin peeling or dry skin. In the gut, we can see mouth sores develop sometimes. We can see that patients can experience diarrhea. These drugs can cause fatigue or feeling like no energy. And then on blood tests, we can see that these drugs can cause elevated liver enzymes, a decrease in platelet count, and decrease in kidney function. So what can we do? We know that these drugs work really well. We also want to make sure that these drugs are tolerated, because one of the most important things we want to do is make sure that patients have a great quality of life, and that's our goal. So when I talk to patients, some of the things I recommend are, for the skin change, we talk a lot about moisturization. We talk about using antibiotic creams or even oral antibiotics, especially for that acne-like rash. For the mouth sores and diarrhea, we talk about salt and soda mouth rinses and anti-diarrhea medications. I think some of the most common side effects of any anti-cancer treatment are fatigue and loss of energy. And in this situation, we can actually talk about decreasing the dose of the osimertinib. And we see that we can safely decrease the dose of this drug without significantly impacting its efficacy, which is a very positive thing that we can do. And for these elevated or change in blood function and blood tests, what we typically do is we get frequent monitoring. So for me, I always check a patient's blood counts, kidney function, liver function, and we can adjust the dose as needed to help make sure that these tests stay relatively normal. So the question happens, the next most common question I think I get is what happens when osimertinib stops working? And that, unfortunately, is something that we see. And the reason this happens is, the cancer cells find a way to get around the drug. Cancer cells are smart, and they're smart because they're a part of you. And the way they get around this drug is they can develop a different mutation, so that now the on signal is turned on through a different pathway than EGFR. So turning off the EGFR pathway doesn't seem to matter anymore. Sometimes cancer cells become a different type of cancer entirely. So instead of non-small cell, rarely it becomes something called a small cell or even a squamous cell cancer. But you'll see in the pie graph on the right, unfortunately, about 40 to 50% of the time, despite our best efforts, we still don't really quite understand what is happening that makes the osimertinib stop working. So what are our next treatment options after osimertinib? I think it's always important to consider getting a new biopsy, and this can be done in tissue if it's an area that's safe to biopsy and easily accessible, or through the blood, because we now have technologies where we can draw a patient's blood and they're sent to special laboratories around the country, and they're able to look at the tumor cells in the blood and run tests on that. And for me, I want to see, one, if the EGFR mutation is still there, because that means maybe there's a role for us to continue the osimertinib. And two, if another mutation has developed, meaning has a different on signal occurred in the meantime. We know now that if we see on the scans that if only 1 or 2 spots are growing, or the growth is not very significant, we can actually consider radiation or surgery to try to get rid of those tricky spots. So it's kind of like you see a weed in your otherwise nice lawn, you pluck out that weed and your lawn still looks great. And you can continue the osimertinib because it's keeping everything else in check. However, if on the scans, the doctor feels that the number of spots that are growing are just too many, or now you're having new spots, then at that point we would consider switching to chemotherapy. And if the EGFR mutation is still there, I would sometimes continue the osimertinib. Or, as always, I always encourage participation in a clinical trial if that's available, because we're always looking for a better solution. I know that there's a lot of commercials on television for immunotherapy. So these are drugs like pembrolizumab, which is Keytruda, nivolumab, which is Opdivo, durvalumab, which is Imfinzi. And certainly these drugs have changed how we treat non-small cell lung cancer. But we see that for patients with EGFR mutated non-small cell lung cancer, immunotherapy really doesn't seem to be beneficial, even if we add chemotherapy to it. So as a normal standard of care, I wouldn't go to immunotherapy right after osimertinib stops working. Now I kind of want to switch gears and talk about what I think are some exciting things coming down the pipe, so to speak, and some exciting research that is ongoing. So the first study I want to talk about is a study that we just heard more about at our annual oncology meeting in June. And this study is called the Chrysalis 2, and it looks at the combination of two drugs called amivantamab and lazertinib in patients with EGFR mutant non-small cell lung cancer after they've progressed on the osimertinib and platinum-based chemotherapy. So what lazertinib is a drug very similar to osimertinib. Lazertinib is also an EGFR TKI. It's very active against cancer that can go in the brain, and it seems to be very well tolerated in terms of its toxicities. What they did is also add another drug called amivantamab, and that is kind of shown on the right. So what happens is amivantamab binds to two different proteins, EGFR on the left and the green, and something called MET, which is in purple on the right. What we know is that MET is a way that cancer cells can become resistant to EGFR. And so now MET in this instance is acting like the on signal and kind of taking over what the EGFR was previously doing. So what amivantamab is it binds to both of these proteins together, and that allows your body's immune system to recognize these cells as a problem and to eliminate them. Amivantamab is actually already approved in the United States for use in patients with a different type of EGFR mutation called an exon 20 insertion, for which osimertinib and some of these other drugs we've been talking about are not shown to be effective. So what the researchers did is they took patients who have EGFR non-small cell lung cancer. All of these patients had to have received osimertinib and had to have received platinum-based chemotherapy. And in some cases, other patients have received multiple different other drugs, other EGFR TKIs, and maybe even other chemotherapies. And everybody in this study received a combination of those two drugs, the amivantamab and the lazertinib. What they found here are what I think are the interesting results. So when we look at the top line, we look at ORR, that means overall response rate. That showed 33%. And what that means is that about 33% of patients had a significant tumor shrinkage. I think the other really important piece of information for me is if you go down a little bit, there's an area that says stable disease. That means that for patients that their tumors maybe didn't shrink significantly or a lot, but it certainly didn't grow too much either. So it still means that the cancer is being controlled. And we see that another good proportion of patients had stable disease. So this drug combination seemed to do an excellent job of either controlling or shrinking the cancer. I think that here what they looked at was patients that had different prior treatments, and if maybe what their prior treatments, if that affected at all their response to the combination. And I really want to have you focus here on the dark gray bars. And these are patients who had received both osimertinib, chemotherapy, and multiple other lines of treatment. And you'll see that even in that situation, they were included in the population of patients who had a good response. So that is below that dotted line that says -30. Those are the patients who would have considered to have an excellent response, meaning this combination was effective whether or not you had only a little bit of treatment before, or even if you had a lot of treatment before. Of course, it's always important to think about side effects, and side effects here highlighted in red are those that are related to the EGFR drug, the lazertinib. So like we talked about already, rash, skin changes, diarrhea. There are side effects related to if you're targeting that MET protein. So that would be low protein levels, in your blood, and lower extremity swelling. And then I really want to highlight the side effect in green called infusion-related reactions. So this is a reaction to the drug Amivantinab. It's quite common, and patients commonly describe it as a sense of flushing. Some patients may feel warm, a little short of breath. They can feel their heart is racing. It's not considered a true allergy. This happens quite a bit with this specific class of drugs. And the great thing is that patients who then received either steroids or some other medications were able to then continue to go on to the drug, and the reaction did not recur. So as you remember from the beginning, we talked about how EGFR is a part of a larger family of these ERBB receptors. And now I'm going to focus on ERBB3, which is called HER3. And what we know about HER3 is that it's actually also frequently seen in non-small cell lung cancer. In fact, it's seen a little bit more frequently, more commonly in EGFR mutant non-small cell lung cancers. And this is the other, I think, exciting drugs that we are seeing. So this is a publication that came out this year from Dr. Yanni and his colleagues. And it looks at the safety and efficacy of a drug called patritumab deruxtecan. And again, it's in patients with EGFR non-small cell lung cancer. So what is patritumab deruxtecan? So on the left, you see our EGFR receptor, which is actually HER1. And then here on the right, you'll see HER3, which, as I've said, is actually commonly found in non-small cell lung cancers, and especially in EGFR non-small cell lung cancers. So what the drug does is it comes in, it binds to the HER3, and this drug is actually linked to a potent chemotherapy. So what this drug does is it directs the chemo only to the cells that have this HER3. And in this situation, we think that the HER3 is more found on patients with EGFR non-small cell lung cancer. I know this is a really busy table, but all I really want to demonstrate is what is on the bottom. These are the 81 patients that were on this study. And you'll see on the bottom talks about prior cancer regimens. So again, a lot of these patients had prior osimertinib, prior chemotherapy. Some of them even receive immunotherapy. So again, these are patients who receive a lot of different treatments. And you'll see right at the top says number of prior lines. It talks about some patients had even 9 lines of treatment before this. And again, here we want to highlight what the overall response rate was, is about 39%. So again, that meant 39% of patients had a really good shrinkage of their cancer. And again, you'll see that another subset of patients also had stable disease, which means that this, again, this drug seems to be pretty effective in patients who've had progressed on their treatment. Of course, we'll see that there are side effects to all of these drugs, and that's when we look at the bottom. This is grade 3 or higher. That means these are more serious side effects. We see a lot of these side effects are related to blood count changes, which are monitored very closely while in this treatment. The most important side effect is what I've highlighted below in red. It talks about ILD, which is interstitial lung disease. Unfortunately, with this class of drugs, we see very rarely that sometimes patients can develop inflammation in their lung, and that can cause them to be short of breath, and that could be long-lasting. We are learning and trying to understand the mechanisms behind it and ways to prevent it. And as I've said, it's fortunately a very low likelihood, but it is something to be aware of. So my takeaway points from all of this, it is, again, if we've covered nothing else, I think for me, it is important to remember that we always should check for the presence of EGFR and other driver mutations in metastatic non-small cell lung cancer. And again, that is considered a standard of care. Medications that target EGFR, the TKIs, have completely changed the longevity and I think the quality of life for our patients with EGFR mutant non-small cell lung cancer. We do need more directed therapies after progression on osimertinib. I think we do have some suggestions that perhaps there may be a benefit to continuing the osimertinib if the EGFR mutation is still there. We would always like to encourage participation on a clinical trial that is feasible and available. And again, outside of a clinical trial, I really don't see that there's too much benefit to immunotherapy, but that is an active area of ongoing investigation. And with that, I would like to thank you.
Hi, everyone. My name is Millie Doss. I'm a clinical associate professor at Stanford and also chief of oncology at the VA in Palo Alto, and I'm going to be providing an overview of ALK-positive non-small cell lung cancer. My disclosures are listed here. So to start, I just wanted to provide some background of ALK in non-small cell lung cancer. We know that ALK alterations are seen in 3 to 7% of patients with non-small cell lung cancer. These alterations are more frequent in adenocarcinoma histology, in patients of younger age, and in patients who are never or light smokers. When we think about ALK alterations, we're really specifically talking about EML4 ALK gene rearrangements, also known as translocations. We know that there have been at least 15 variants that have been described in non-small cell lung cancer. And these rearrangements, translocations, were first identified back in 2007 in lung cancer patients. And when we look for these alterations, we typically look for them through FISH, immunohistochemistry, or next generation sequencing. So more commonly these days, we're sending biopsy tissue blocks for next generation sequencing, and we can pick up these translocations on those results. As far as treatment goes, we have a number of different FDA-approved options for our patients with ALK-positive non-small cell lung cancer. Frontline treatment options are shown here. So we have Alectinib, which was first approved back in November 2017, Brigatinib, approved in May of 2020, and then most recently we have Lorlatinib, which was approved in March of 2021. And I'm going to go through a little bit of the data that led to the approvals shortly. There are some other ALK inhibitors. So it really started with crizotinib and also then ceritinib. And so I'll again be sharing data with you now that we have these other options available. I think the role of crizotinib and ceritinib is less clear. This is a summary of the phase 3 trials of first-line treatment with ALK inhibitors in ALK-rearranged non-small cell lung cancer. So as I mentioned, it started with the Profile 101 study with the use of crizotinib, which was really the first ALK inhibitor. In this study, it was compared against chemotherapy. So it was platinum pemetrexed compared to crizotinib. And we saw a significantly higher response rate in those patients receiving crizotinib, which led to it being now approved as a frontline option for our patients with ALK rearrangements. Next came ceritinib, and this was studied in the ASCEND-4 study. Again, in this trial, ceritinib was compared against chemotherapy, showed a significant improvement in overall response rate and progression-free survival. And then the later generation ALK tyrosine kinase inhibitors are shown here, alectinib, brigatinib, and lorlatinib. In these studies, the later generation TKI was compared against crizotinib, which had really become the standard. And what we're seeing is that there was a significant improvement in, again, overall response rate and progression-free survival with these later generation ALK inhibitors compared to crizotinib. So I wanted to just start with the Profile 101 study. So this was, again, a study that compared crizotinib to chemotherapy. And what you can see here is that progression-free survival strongly favored those patients receiving crizotinib compared to chemotherapy. No significant difference in overall survival was seen, and this is because crossover was allowed, meaning that those patients who were randomized to receive chemotherapy at the time of disease progression, they were allowed to go on to receive crizotinib. And so if that crossover effect is allowed, it can make it quite difficult to be able to tease out survival differences in the end. But based upon this data, the FDA did approve crizotinib as a frontline treatment option for our patients with ALK rearrangements in August 2011. As we started using crizotinib, we did find that acquired resistance to this drug was quite common. So the median progression-free survival on crizotinib was on the order of 7.7 to 10.9 months. So around less than a year, most patients would develop resistance to crizotinib. And so we knew we had to try to do better. So the ALEX trial looked at alectinib, which is a second-generation ALK inhibitor, and compared it against crizotinib. And again, it was compared in the frontline setting in our patients with ALK-positive lung cancer. And this is the 5-year data that was recently published, showing a continued significant survival benefit for those patients receiving alectinib compared to crizotinib. And so this has now really established alectinib as a frontline option for our patients with ALK rearrangements. And this is really the preferred option for many of us in clinical practice. When we look at the safety with alectinib, overall, it seemed that alectinib was better tolerated compared to crizotinib. And so this drug was approved in November 2017. It's important to point out that in addition to the overall survival benefit, that alectinib demonstrated an improvement in progression-free survival as well as in brain penetration. So I think that's an important point. So we know that patients who have ALK rearrangements are more prone to developing brain metastases. So it's always great when we have these newer drugs that can get into the brain better. And so, as I mentioned, alectinib is now a preferred frontline option. Next came the ALTA first-line trial, and this is looking at another second-generation ALK inhibitor, brigatinib, again comparing it against crizotinib in ALK-rearranged non-small cell lung cancer patients. Again, we're seeing here clear progression-free survival benefit in those patients receiving brigatinib compared to crizotinib. No significant difference in overall survival. Again, this is due to the crossover effect. So once patients progressed on crizotinib, they were allowed to go on to receive brigatinib, which really makes it difficult to be able to tease out survival differences in the end. When we look at the safety, it's just important to keep in mind that brigatinib does have certain adverse events that we just need to look out for. Increased blood creatinine kinase levels were seen more frequently in those patients receiving brigatinib. Cough and hypertension were also noted more frequently. So just things to be aware of. And again, based upon this encouraging data, in May of 2020, the FDA did approve brigatinib as a frontline option for our patients with ALK-positive non-small cell lung cancer. And then finally, we have the CROWN study. So this is looking at the third-generation ALK inhibitor, lorlatinib, again, comparing it against crizotinib as first-line therapy for ALK-positive patients. significant improvement in progression-free survival seen in those patients receiving lorlatinib. Again, we're seeing a significant improvement with regard to time to intracranial progression, as well as cumulative incidence of CNS progression as the first event. So improvements there in those patients receiving lorlatinib compared to crizotinib. So based upon this encouraging data, in March of 2021, so just last year, the FDA did approve lorlatinib as a frontline option for ALK-rearranged non-small cell lung cancer patients. Again, looking at safety, lorlatinib overall did seem to have sort of, again, kind of unique side effects that need to be considered. So hypercholesterolemia and hypertriglyceridemia were seen quite commonly in patients treated with lorlatinib. And so this is just something that we are now monitoring for when we start patients on this drug. Edema was also seen more commonly, and then associated increased weight. Peripheral neuropathy and cognitive effects were also seen. So just, again, to be aware of these side effects and to really try to manage them as best we can. We have some strategies that we can use to try to overcome some of these adverse events. Just to talk a little bit about the adverse events that are more commonly seen with these ALK inhibitors as a class, just wanted to mention that we do more commonly see GI toxicities, which include nausea, vomiting, and diarrhea with ALK inhibitors in general, as well as liver function abnormalities. These were more commonly seen with the earlier generation ALK tyrosine kinase inhibitors, the crizotinib and the ceritinib, compared to the later generation ALK inhibitors, but just important to keep these toxicities in mind. Anemia and myalgias are also seen in patients treated with ALK inhibitors, more common with the alectinib compared to some of the other ALK inhibitors. And then, of course, visual impairment is also an adverse event that we think about with these ALK inhibitors. This was more commonly seen with crizotinib. Thankfully, this was usually transient, and it's less common with the later generation ALK inhibitors. But just to be aware of these more common adverse events with the ALK inhibitors. So as I mentioned, although we're really excited about the efficacy of these drugs for our patients with ALK rearrangements, despite the efficacy, we know that acquired resistance, unfortunately, is considered to be inevitable. So these drugs will stop working at some point. And when they stop working, we oftentimes see both on-target and off-target pathways that seem to develop at the time of resistance. So on-target really refers to alterations within the target kinase, and off-target alterations include kind of new bypass pathways that are formed or histologic transformation. I'll mention that for ALK, histologic transformation is not as common as in EGFR, for example, but it is something that we do see from time to time. The most common ALK resistance mutations in patients who are treated frontline with alectinib are the G1202R resistance mutation, which is seen in 25 to 30% of cases, and then the I1171X alteration seen in 10 to 15%. So these are on-target alterations that can form in patients who are treated with alectinib frontline. The good news is that when we see these resistance alterations, we know that lorlatinib can actually target these alterations. So when we have patients who progress on frontline alectinib, we do a repeat biopsy, we see one of these ALK resistance mutations, we can then go ahead and treat with another ALK inhibitor, usually lorlatinib, to try to overcome this resistance. We know that when we're treating patients with the third generation ALK inhibitor lorlatinib frontline, that we can see these more complex resistance mechanisms. And so sometimes we'll see compound ALK mutations, more of these bypass and downstream signaling pathways. So that's just important to keep in mind. So many of us are still using alectinib frontline, but we do now have approvals for both brigatinib and lorlatinib frontline. And so if those are used, it's just it's just important to point out that we are seeing, sort of other kinds of resistance mechanisms that are popping up. We know that the ALK specific ALK fusion variant may influence the development of on-target resistance. So I think it's really interesting work that has recently discovered that maybe the specific variant will be able to predict what the resistance mechanism will be that develops. And then I just finally wanted to state that repeat tissue biopsy at the time of disease resistance is commonly recommended. And it's really to be able to figure out what is happening at the time that the ALK inhibitors has stopped working. Is this something that we can target with another ALK inhibitor? Is this something that we can target with some other drug? And so I think it is important to try whenever possible to perform a repeat tissue biopsy at the time of disease resistance. And then finally, emerging therapies in ALK-positive non-small cell lung cancer. I think there's a lot of excitement in some of the ongoing clinical trials that are currently underway at different sites throughout the US, where we're trying to improve upon our current outcomes for our patients. We have the ALK Master Protocol, whereby patients who've progressed on frontline ALK inhibitor therapy are then told to undergo a repeat biopsy, a repeat tissue biopsy, to look specifically at the ALK resistance mutation. And then they are basically told to go ahead and get a certain therapy based upon the results of that tissue biopsy. And so this is really kind of an individualized protocol where patients go on to receive therapy based upon the results of the repeat biopsy at the time of disease progression. So I think it's a really interesting protocol, and we're hopefully going to get more data from that in the upcoming years. There are a number of other ALK tyrosine kinase inhibitors that are in clinical development to try to overcome some of these ALK resistance mutations that we're seeing. And then there's ongoing clinical trials looking at combination therapies upfront to try to delay the development of resistance. Again, with the overall goal of trying to give our patients longer time on these therapies and, basically at the end of the day, improve survival for our patients. So I think there's a lot of excitement in this field moving forward. Thanks very much. So I think we're going to go ahead and take some questions if there are any. And so Angel, I think I'm just looking in the attendee questions.
Yeah, let's see. So first question. So in regards to, I think this is referring to EGFR TKI, so osimertinib. In regards to the dose, does increasing the dose increase the efficacy of the drug? Are there any fourth generation EGFR TKIs in the works? And is amivantinab and lazertinib available if the platinum chemotherapy is not effective? So I will try to address all of them one by one. So that first question, does increasing the dose increase the efficacy? That's actually quite a tricky question. So the way that drugs are actually approved when we're doing these clinical trials is that drugs are approved at the maximally tolerated dose, which is not necessarily the maximally effective dose, meaning that we basically take the dose that is best tolerated by patients with respect to side effects, but that does give us wiggle room to decrease the dose, like we've talked about, to help improve its tolerance. I will say that in some instances, we have seen that if we increase the dose, we may get some better control of certain areas. And really in this situation, it's in patients who maybe have brain metastases that can be growing, but it's not necessary that a higher dose means that it's more effective. And so I really do try to counsel patients that it's okay to have a lower dose if that means it's more tolerable. As far as I know, I'm not aware of any fourth generation EGFR TKIs that are in clinical trials. I know that there's a lot of work in this space, but I don't know specifically of any clinical trials. Where the combination of lazertinib and amivantinab as we speak today is not yet currently FDA approved. And so the only way a patient would be able to get on the combination that I'm aware of is actually through participation on the clinical trial. Let's see, the next question. About just in general about how to treat mouth sores if you're on osimertinib and if there's any nutritional supplements that can help. Maybe Dr. Das too, you can speak to this. I am not aware of any nutritional supplements per se. What has really helped my patients the most is really like the salt and baking soda rinses. It helps to heal the sores. And really, if the sores become too bothersome, we have had to dose reduce in those situations and the sores essentially resolve. But I don't know if Dr. Das, if you've heard of any nutritional supplements that may be helpful.
No, I agree with you, Angela. I think our first line is generally the baking soda rinses, and they do usually take care of the mouth sores. And yeah, I'm not aware of like ginseng or fish oil being helpful in the situation, but you know, I imagine there may be some nutritional supplements that may be marketed towards helping that. And so I think it's always important, if you do come up with something, to, you know, bring it in to your appointment, show it to your oncologist. You know, in general, I'm pretty open to patients using you know, supplements. As you know, they're just not regulated by the FDA, so we don't always have all the sort of information, but I think it's useful to you know, look it over with your treating provider, and then, you know, as long as it looks otherwise safe, I think it's okay to go ahead and use as a kind of an adjunctive option.
Yeah, I agree. The next question, boy, I think this is the $1 million question. So checking for mutations is a standard of care, but insurance companies are still refusing to cover. Any suggestions? You know, this is a great question. Unfortunately, I still do encounter this. Not as frequently as earlier in the days, but it still happens. I would say we really just have to be persistent. And I have, you know, had to do peer-to-peers with multiple insurance companies explaining what we mean. We order the testing. I think sometimes there's a confusion on the billing code that it looks like we're trying to do genetic testing, which is a slightly different testing. This genetic testing, to the mind of insurance companies, is looking at, are there any cancers that are inheritable? But when we look at the mutations, for our purposes, we're really checking it in the cancer itself. And I found that sometimes that is just a misunderstanding, but we just have to be persistent. I mean, it's in the national guidelines. We really publicize it quite a bit, I think, as an oncology community. But I don't really know that I have any great solutions to solve this problem.
Thankfully, I think it's happening a little bit less frequently than before, especially as we now are using more liquid biopsies and tissue biopsies at the time of resistance. And so I do think that it does still come up, but less frequently. And then we certainly, you know, I know that all of our care teams are advocating for our patients and you know, taking the extra steps to really talk to the insurance companies to make sure that they understand. And by far and large, it does end up getting approved, sometimes just through some extra steps, but most of the time it really does get approved.
Yeah. Next question, what do you recommend for patients with uncommon EGFR mutations, such as G719X? Seems like perhaps afatinib is the first line, maybe even debatable among specialists. And do these patients also have the same options to participate on clinical trials? So my typical, when approaching an uncommon EGFR mutation, I actually try to go directly to the source and looking for what may already been published about a certain mutation. Some are more common uncommon EGFR mutations, so we know a little bit more about the response rates with different drugs like afatinib. But some are truly kind of case reports. And I think we just kind of do the best that we can in terms of looking what's available. Afatinib for me has been kind of my go-to with some of the uncommon mutations, just because it does have the most data published. With clinical trials, so that's where the tricky part comes in. A lot of these clinical trials with EGFR mutations, because of how complicated things have gotten, the clinical trials can be very specific that the patient must only have had the common EGFR mutation. They're not necessarily taking any EGFR mutation. But I do think that this is an area too of active clinical interest. So it might just take a little bit more digging to find the correct clinical trial. Let's see. I think this one is for you, Millie. Is there evidence that other ALK inhibitors work after a patient's cancer has progressed on lorlatinib?
Yeah, that's a great question. I think we're still trying to get more data here. And so, sometimes we have patients that we're treating with alectinib frontline. They develop disease progression on alectinib, and then we switch them to lorlatinib. And then they may have a response, and then at some point, the lorlatinib stops working. And so then do we go to brigatinib, for example, or chemotherapy? I think we're still trying to understand. Again, I think the goal is to try to do a repeat biopsy at the time of disease progression or resistance on whatever line of ALK inhibitor therapy you're on. I will sometimes try another ALK inhibitor. In clinical practice, has it really worked? I think it's sort of anecdotal. And so I do think it's there's a lot of ongoing trials to look specifically at some of these newer generation ALK inhibitors to see if they can overcome some of these resistance patterns that we're seeing on lorlatinib. But as I mentioned in my talk, when we're using lorlatinib, the resistance patterns become a little bit more complicated. And so honestly, I think the safest approach is probably to go to chemotherapy at that point. We know that chemotherapy is very effective in patients with EGFR and ALK. And so, yes, we always want to try to use a targeted therapy whenever available. But I think you can never really go wrong with chemotherapy. And so that's I think at the time of disease progression on lorlatinib, I think I would probably more seriously think about chemotherapy. I think if there is a clinical trial, and there are clinical trials looking at novel ALK inhibitors in this specific setting, of course, that would be an option. But chemotherapy remains a great option as well.
So let's see, where should proactive patients who develop side effects like pneumonitis or resistance look for available clinical trials to discuss with their doctors? So I think that that's a great question. The best source, and I use it often, is a website called clinicaltrials.gov, .gov, and it really is a list of all clinical trials sorted out by different status. So some clinical trials are open but not yet accruing patients. Some trials are active and accruing. It tells you all the different sites that are accruing. It can be a little overwhelming because depending on what search function you use, you can come up with like 6 to 10 pages of different clinical trials. So that can be a little bit daunting. I think if a clinical trial if a patient is interested in clinical trials in general, I think it's great to always bring that up early with their doctor, so the doctor, can be maybe on the lookout for what may be available at their own cancer center, or maybe other trials are opening up nearby. I think that's probably a really good way to go about it.
Yeah, I'll just add to that. I think talking to your provider kind of at the time that you're thinking about changing therapies, talking about what is available at that institution. I know in the Bay Area, we have a pretty good pulse on what trials are opening and closing. It's a very dynamic process, and the eligibility criteria are always also very kind of specific to the studies. And so it's not uncommon when I see a patient and we have to decide on next line of therapy, I'll go ahead and shoot an email to my colleagues at UC Davis or UCSF. I'm at Stanford, trying to just make sure that I know what trials are available there and to consider those options. And yeah, as Angel mentioned, I think clinicaltrials.gov is great. But as she said, also it can be a little bit overwhelming, and then you're seeing kind of trials throughout the country, which may not be really practical or feasible. So really thinking about in the geographic region that you're in, kind of asking your provider to look into sort of the options, and then it's, I would say it's fairly common for us to be sending patients back and forth to various institutions. Usually if a trials is not open at our institution, it'll be open at one of our nearby institutions.
Let's see this patient. So for me, so for patients who were on erlotinib and had stable disease progression, but noticed disease, okay, so for patients who are on erlotinib and had disease progression, but noticed disease progression, one switch to osimertinib, is it efficacious and viable to switch back to erlotinib? I would say I would not recommend going back on erlotinib unless, again, this is in the context of a clinical trial in which they may be adding something else to the erlotinib. What we know about the evolution of EGFR non-small cell lung cancer is that, when patients start on erlotinib, they usually develop certain mutations that make it resistant to erlotinib, for which osimertinib is effective. But we don't see that once a patient has progressed on osimertinib, that they can still go back on the erlotinib, just because, again, those mutations are already present and make them resistant to usually both drugs. So that is not something I would recommend. Let's see here. As a general principle, could it perhaps be more valuable to return to a targeted therapy after someone has been on chemo for a while since the last targeted therapy? Millie, I'm going to let you take a crack at that one first.
So this is from Jack West. So I think this is a great point. And I certainly do this in clinical practice. So, when we do have patients who've been off of targeted therapy for a while and have been on chemotherapy, I do think it's worth considering going back to a targeted therapy option. And so that, again, in the context of ALK, where I was talking about sort of thinking about chemotherapy after someone's progressed on lorlatinib, I think going back to perhaps a different ALK inhibitor after they've been on chemotherapy for a while, I think is a reasonable option. And so that is something that we're doing in patients with driver mutations in general, thinking about chemotherapy, giving patients time on chemotherapy, and then if we have to think about kind of a next line in therapy after a year or longer on chemotherapy, I think that's the time to consider going back. And I have seen responses to these targeted therapies again after they've been off therapy for some time. So yeah, I think that's a great point, and it's sort of a great general principle that many of us sort of put into clinical practice.
Yeah, so I can add to that as well. So I think that's a great question. It certainly would be, if a patient was on chemotherapy before I put them back on a targeted therapy, I would probably do a biopsy, whether that's tissue or blood, just making sure, we would like to see that there's hints that perhaps a targeted therapy would be effective. So they have an EGFR still or an ALK still. I will say that more recently, I have seen some of my colleagues continue a patient on their targeted therapy and adding a platinum-based chemo to it. And I've done that in a few instances where I find that patients still have the EGFR mutation, but they're clearly progressing on the osimertinib. And we put them on osimertinib and the platinum doublet chemotherapy. And the rationale there for me is that the chemo is going after the more osimertinib resistant population of cancer, and the osimertinib is keeping in check those that are still what we think sensitive to the osimertinib. And then I think for me, I like to keep the the drug only because it has perhaps a better efficacy against brain metastases than what we traditionally think about with chemotherapy. I can't tell you that this is, you know, I have great data to back all of this up. I've just seen it in practice a little bit more commonly, and at least anecdotally of a few of my patients of mine have actually been doing pretty well on that kind of a treatment plan.
And I think as a follow-up, yes, I agree that, you know, there's a follow-up comment here about thinking about adding a different therapy against the same target, not the old one, unless there are no options. Agreed. Especially in the setting of ALK, where we have a number of different ALK inhibitors that we can think about, you know, going to a different drug after, you know, patients have been on chemotherapy for some time is generally what I would do. In EGFR, I will say, you know, there are patients that maybe had progressed on osimertinib. They've had multiple lines of chemotherapy. You know, sometimes I would think about going back to the osimertinib. You know, I generally wouldn't go back to one of the earlier generation TKIs. But, you know, again, trying to think about, you know, re-challenging with osimertinib. That's generally in the setting of, you know, kind of patients who progress on multiple lines of chemotherapy where we don't have, you know, other great options. In the case of ALK, it's a little bit different because we do have a number of other second and now third generation ALK TKIs that are FDA approved that we can use. For EGFR, it's a little bit different. The only third generation EGFR TKI that we have is osimertinib. So, but I think the field is evolving, and I think we're going to have more options moving forward.
Absolutely, I agree. Let's see, if the patient is willing, do you think traveling outside the immediate area for a trial is a good or more risky option? Ooh, that's a good question. So I think that I think so part of that depends on you know, if we know that a trial is available, because certainly we wouldn't want a patient just to travel to you know, a different institution outside where they live, to a different state, for example, only to find out that this trial is not available, or, you know, not even enrolling anymore. So any kind of homework or communication with another cancer center that can be made to kind of get a sense of that, I think will be really helpful. You know, as a person who does clinical trials, who's really interested in clinical trials, obviously I think my opinion here is a little bit maybe more biased. I do think that clinical trials are something I would recommend if I feel that it's appropriate for a patient. But that comes with a lot of caveats with, you know, is it financially feasible? Is it safe to do so? So, you know, we certainly wouldn't want to take any patient who maybe needs more urgent therapy to go on a clinical trial, because we all know that it takes time to enroll a patient, to get all the scans that it requires, to check off all the labs. You know, clinical trials usually come with quite stringent enrollment criteria. So I think if a patient is sick from their cancer, I wouldn't say let's go travel out of the state to get on a clinical trial. I think the other,
Angel, is, you know, I think it really depends on the trial, right?
Yeah.
You know, and so if it's a trial that looks really promising, you know, for a particular patient, I think really connecting with that institution and figuring out what are the requirements of the study. Is it practical or feasible for someone to be traveling from another geographic area? So it really depends on the patient circumstances, on the you know, kind of the more kind of details of the study, what's required of the study. I think in the era of COVID, there have been more studies that have been sort of, you know, where we're trying to develop studies that will allow us to have patients participate, you know, not who don't live in the immediate vicinity. You know, I don't think we're quite there yet for a lot of our trials, but allowing for, you know, for consents to take place, you know, virtually, for trying to get particular study-related activities done at a different institution, and transferring that data over. So there is a lot of interest in trying to do this, and I'm hoping that as we move forward that we will be able to allow more of this, because it is tricky, and logistically it's not practical for patients to just uproot their lives and move somewhere and live there for months at a time. And so hopefully we will be able to offer kind of more broad clinical trial participation and make some of these eligibility criteria and some of the study requirements a little bit more feasible for patients who are not maybe living in that immediate vicinity.
Okay, I think those were all the questions. I didn't know if there was any other last minute questions.
Looks like not. Great.
All right. Well, I want to thank everyone for joining us today, and it was really a pleasure.
Yeah, thank you all for tuning in. Really, really great to share this morning with you.
Hello and welcome back, everyone. I'm sure you've had a lot of discussions in the breakout groups, and so now it is time for us to begin our session number 2. We have really some great topics, and very excited to host some of the very well-established speakers here during the session 2. We're going to be talking about finding your cancer community. We're also going to be talking about management of KRAS mutated and RET mutated non-small cell lung cancer, so stay tuned. To kick off proceedings for session number 2, I am going to start by welcoming Terry Conneran. She is the founder of KRAS Kickers. She's a speaker, advocate, and a lung cancer survivor. I am very, very excited to hear from Terry. And as most of us know, as a physician, as a researcher, we all want to hear from our patients, and we are all patient advocates. So really excited to welcome Terry here from KRAS Kickers. Thank you so much for joining us, Terry.
Hi, thank you all, and thank you so much for having me today. You know, it's really important to be able to find people that I can connect with. Let me tell you just a little bit about me and how I ended up even being here. So about 5.5 years ago, I was diagnosed with stage 3 lung cancer like anybody else. That wasn't my plan for the year. We were working on vacations, and my youngest was about to graduate from college. It didn't work out that way. She did graduate from college, but I ended up dealing with chemo and a lobectomy, went through a treatment, and it kind of, and as you kind of like try and process everything that's going on, you know, if you're a cancer patient, any sort of a cancer patient, you just want to see something on the other side. You want to talk to somebody who's really walked the walk and talks the talk and knows how you really feel. So I went looking for that and couldn't find it. After I went through the surgery, I was able to kind of find a lung cancer support group in my hometown of Charlotte. And I connected with those people there in person and started hearing all the commonalities that we had and the same fears and the same hopes and same kind of like issues that we had, things that our patients understand only on another patient level. And I started hearing about these other things, these mutations, these biomarkers, and you know, how they're living through the different side effects. And I was hearing like real life experiences, you know, the real practical part of, oh, maybe I need to go see a physical therapist, what have you. And as I started hearing about these biomarkers, it's like, well, I went back to my doctor and I said, well, hey, what's my biomarker? She says, well, you don't have one. And to kind of speed up that part of the story is it took 3 years and 2 recurrences and a second opinion for me to learn that I had a KRAS biomarker. The KRAS, as I've since found out, is the most common of all of the biomarkers in the lung community. So when I heard that I had KRAS, I thought there must be other people that had this as well. I went looking for another group of people that I could connect with, because we want to have that sense of commonality. We want to be able to have the same devil, be fighting the same enemy, and have the same name for it and that same source. And I couldn't find another organization that was doing it. So ended up happening that I started the KRAS Kickers. This was just as COVID was starting to happen. So we went online and we connected as a Facebook group and we started a website. And by we, I mean me and the other people that have KRAS, because I'm not alone in this. We're all within it. And as that just kind of branched out, I've learned what KRAS is, what KRAS means, what it does, and not just from a molecular level, which is important, but also understand enough to know what my next treatment might need to be. I've subsequently had a couple of different recurrences. I've been through radiation, but most importantly, it's not just what it is I'm going through. It's being able to connect with the other people that have this as well and being able to stay on top, knowing what my biomarker is, okay? And if mine hasn't changed, they can change, but mine hasn't changed. I'm the KRAS G12D, so even though there's many people that have a G12C targeted therapy, I'm unable to benefit from that myself. And so we're still on the cutting edge. We're still looking for what's next. We're looking for the clinical trials. We're looking for it. So we're finding within our community, this is becoming the real life place. This is kind of the watering hole, okay? And the KRAS Kickers is become the watering hole for the patients. We're going there to get a sip of water. Sometimes it's a virtual hug. Sometimes it's, they're just having somebody listen to you and know how you're feeling. Other times it's a matter of, I really want to know, what is the research? How is somebody else doing? I'm talking to patients one-on-one within, the community. It might just be a DM. It might be on Facebook. It might be a phone call. We've been emailing back and forth. We might be able to pull up and have that, because each person needs to know and needs to connect with somebody else that has that same thing. I have the benefit of being out 5 years now. And so my treatment process would have completely changed over the last 5 years than it would have if I was diagnosed today. That's really good news. But that's also inspiring and hopeful for other patients that haven't gone through it. And they can talk to me and they say, oh, okay, so you did live through chemo. No, I didn't lose my hair. Yes, I managed to get through it. And my hearing did mostly come back and my taste did recover. And at the same time, also what's going on with the family and how horrifying it is to get a recurrence, what it's like, and have another person to kind of hear that out. Because for me as a patient, it's actually when I have an issue that I want to be able to talk to somebody else about. My family's supportive, my connections, my friends are very supportive, my Bible study ladies are all very supportive, but they don't get what I'm going through. They don't get what I'm going through on a real level. And so if you're looking for somebody to be able to connect with other people that have the same sort of thing as you, first of all, figure out what that is. Your journey is going to be a little bit different than mine. How do I know that? Because everybody's journey is unique. That's the whole beauty of targeted therapy and precision medicine, is that we need to know what that is and what that is for me. I love doing having a phone buddy. I've been a phone buddy. I continue to remain a phone buddy. And so you can connect with somebody else that has something that's going through the same thing. How that looks is if you have KRAS, you can join the KRAS Kickers and we can help you find that. If you have another type of mutation, whether it's RET or ALK or whatever, they do the same thing as well. Those are the same sorts of people you want to be able to talk to, because you want to know what that real life experience is and how to connect with it. These Facebook groups, each one has its own benefits and its own downside. It's the same as any other neighborhood. I've always had great neighbors, but when my neighbors change, the neighborhood doesn't change, but my neighbors do. And so it has a different sense and a different relationship. So if you have Facebook and you join a community, you don't have to jump in both feet and just put it all out there. You can just kind of dip a toe a little bit and see what the mood is. See if you feel comfortable. Some of them are very spiritually oriented. Some of them are not. Some of them won't let you post a link. Some of them won't let you post even just an emoticon. So you have to kind of find that space that you're comfortable with that works for you. And when I say you, that means the patient, but it also means the care partner. We have an awful lot of people that are care partners. And I know from going through the treatments myself, when I'm going through treatment, my mind is like oatmeal. I can't think straight. I can't process things. I'm not really sure exactly what it is and what I need. And I lean into those partners that I've got around me. My kids are all adults. And they kind of go and help in some ways. My husband helps in another way. There's the practical parts of the food and that sort of stuff. And then there's the other parts as far as the research and connecting out. That's why these sorts of groups, like what we're doing here with Cancer Craze, is so fantastic. We can get that information and that share. as a patient and within the care partner, and a little bit more extended, because it's not just that partner that's doing it, it's the rest of the family member outside of it. It might be a cousin or somebody who's not really on the day-to-day level, but they want to be able to help. So there's those folks as well. And they can benefit from, whether it's the Facebook groups, it's also like the different websites and the different connections. I really encourage people, if you like talking on the phone, there are phone buddies. These phone mentoring programs are fantastic. We work in conjunction with other ones that help cross-match you. In fact, I've joked so much that I wish my kids would use them to find them a marriage partner, because that doesn't seem to be going real well on Tinder. They do a really good job. And if it doesn't work out, it's okay. It's a pretty small loss. That's it. You just don't talk again. I've done a whole lot of phone buddy sort of things in DM messaging that they just might have a simple question. I answer the question. They never talk to me again. That's okay. My feelings aren't hurt. They got the information they needed, and that was just the peace of mind. I also have patients, not patients, these are friends. It's just we had the same commonality. We had the same demon that we were fighting, and now we have that ongoing relationship. But it's a different sort of a relationship. The same way that, like, if you had met somebody the same time you had a child, okay, and you kind of grew up together, your kids grew up about the same time, you're about the same place at the same time, that same sort of a relationship. Those sorts of things are available for the patient. They're also available for the care partner. And don't discount, when I say partner, that doesn't necessarily mean one and done. It takes a village. It takes a circle of care around you as the patient, and that's okay. And it takes a circle of care around the care partners as well. Like I said, my kids look at it differently than my husband. I was, I guess, technically a care partner as well. My mom was diagnosed with breast cancer when I was 18 years old. And so I know what it's like to be on that side of it as the child helping an adult go through it as an adult parent. And my kids see it, the benefit from it as well. But I also can relate to them a little bit more. So I'm more inclined to push them in a direction of go talk to them, other people. So other adult children that have the same sort of thing with their parents, because it's a special sort of situation. It is different. It is difficult as the adult child helping the parent. And I can tell you, as the parent now, not the adult child, that's on the other side of the coin, I got to tell you, it's actually a little harder on this side of it, because my kids want to come in and they know stuff. And they sometimes actually know the better choice than I know, because they're out there and they're able to siphon through the knowledge and the information and the resources. And when I say those resources, that can be things like financial resources. It can be emotional support resources. It can be a one-on-one resource. It also can just be like that research information and being able to talk it through. We have a mentoring program that it allows people, okay? So it's not always the patient, it allows people to have somebody that just kind of sit there and listen through. A lot of times we have a patient that's like, okay, my doctor's presented me with these 3 different clinical trials, and I'm not sure what I want to do. I am not giving them advice. I'm listening to them talk. But I'm listening to them talk, and I'm asking them other questions from a patient's point of view. What does that mean? Are you going to be able to really stand living away from home for 6 weeks? Is that really practical? And that may be perfectly, in fact, that may be a really good idea for them, but it may not. And it may not be practical at all. And at the same time, it's just hearing it from another patient. It's like, okay, I've got it, and I can talk through it. And then there's the reality part of it. You know, like I said, talking to my kids. Now my kids are adults. But again, as when my mom was the patient and I had to listen to it, I didn't want to hear it. When my kids were listening to me talk about it, sometimes they didn't. One kid wants to process it in one way. The other kid wants to process it in another way. My son's an engineer. He wanted to go through and he wanted to analyze everything that there was under the sun and basically like interrogate the doctor. He wanted to interrogate every single thing, question all the research, wanted each piece of knowledge. I was too sick to care. I was like, just give me whatever it needed to make me feel better. My one daughter was so concerned about making sure that I ate enough, that I ate too much. The other one just wanted to make sure that there was like always somebody there, that I had that phone call, that I had that sense of touch, and that was important as well. And those are different parts of the puzzle. And each part looks different on each person. So when I have had recurrences, and I've had a number of them, and that's never easy. It's never easy as a patient. It's something that we live in fear of, but it's something that happens. We face it every single time we go in for another scan. I personally advocate they shouldn't be calling them tests because I can't study for it. And if I don't pass it, I feel like I'm the failure, as opposed to as a diagnostic. It's just a peek into what's going on in there. And I have to walk myself through telling myself that day in and day out, the closer a scan gets. I still get scanned every 3 months. I still turn into an anxious witch for about a week at a time. And everybody in my circle knows what's going on. But when I can talk to another patient and they're hearing it, they're like, hey, I get you. It's not that they get it from a different level. They understand it and empathize with it in a way that nobody else can. And they can kind of say, you know what, you're going to be okay. And even if I'm not okay, meaning I've got a recurrence, it's back again, and I've got to deal with that, I know I've got somebody I can call and I can process and walk through. How am I going to tell the kid? How am I going to tell my husband? What am I going to say? And a lot of times you don't even have to say anything. Just hearing somebody on the other end of that phone call, knowing somebody's on the other part of that Facebook group, just being able to put it out there and get that sort of, it's support, the hug, the sense that I'm not alone. And it's not just that I'm not alone, but you're with me. And you're with me in this. And we've got that sense of community and that connection that just kind of goes to a different level. That's kind of, I mean, people are there. People want to help. You need to be willing to ask. I'm hopeful that there's going to be like a questions out there that I'm not just going to sit here and listen to myself chatter on. But so if you would be so kind as to toss a question out into the inbox, I would really appreciate it, because it makes me feel like you're actually listening and that I'm not just like talking out here to myself, because if I was going to do that, I'd be on Twitter. Okay. I'm not seeing anybody jump into the question box. So I'm just going to like, okay, so I'll just keep talking. That's okay with me.
Well, thank you so much, Terry. I think that was amazing. And honestly, as someone who discusses, scans with patients, I love the idea of how you mentioned, it's a diagnostic and not a test. I'm definitely going to remember that. So we do have a question and answer session that we're going to be doing after the three presentations. So, and I did see Dr. Luo's here. So if we are all set up, I think we can move on to our next presentation, and then and we are already getting a lot of questions in the chat. So definitely there are people listening to you and have questions for you for sure.
Okay, thank you. All right, we'll be back at the panel then. Thank you.
Absolutely. So next, I'm just going to introduce Dr. Luo. Dr. Luo will now be presenting about the management of KRAS-mutated non-small cell lung cancer. Dr. Luo is a thoracic oncologist at Dana-Farber Cancer Institute and is an instructor in medicine at Harvard Medical School. Thank you so much, Dr. Luo, for joining us, and the floor is yours.
Okay, great. Can everyone hear me? You want to just give a... All right,
yes.
Thank you, Terry. All right, so thank you so much. I think I'm waiting a minute for Maria to share the slides. That's great. All right, well, thank you all so much for having me. I'm really excited to talk about management of KRAS mutated lung cancer after Terry's wonderful introduction to it. If you want to just go to the next slide. So these are my disclosures. I won't be I don't have any disclosures pertaining to the subject of this talk. And I will not be discussing off-label use of any FDA-approved treatments. And then these are my disclosures. Next slide. Okay, so the couple things that I hope to cover in this introductory presentation are an overview of KRAS lung cancer, and then how we think about diagnosing this type of lung cancer, and then treatments that a doctor might suggest to an individual. And then I'm happy to take additional questions in the Q&A session afterward. Next slide. So a little bit about KRAS lung cancer, of which I think a lot of it is re-emphasizing things that Terry already talked about. KRAS mutated lung cancer is actually the most common oncogene-driven subtype of non-small cell lung cancer. So in the United States alone, over 50,000 individuals are affected every single year. And these are new people who are diagnosed. And it accounts for about a quarter of people who have non-small cell lung cancer, which is the most common subtype of lung cancer. And what I've illustrated on the right is, even though we classify this group all as KRAS-driven lung cancer, it actually has multiple subtypes that are dependent on the actual specific mutation. And so it's important not to know just that someone has KRAS lung cancer, but what specific mutation someone has. And that's the reason that's important is the medicines that are available for it are different. And so what I've tried to illustrate in these three pie graphs are the most common subtypes of KRAS lung cancer. And so the vast majority of individuals have KRAS G12 something, and there I've listed the kind of wedges of the pie of which ones are the most common. Other individuals have G13 or Q61, and those tend to be the most common types of KRAS-driven lung cancer. So next slide. So what exactly is KRAS? So illustrated here on the left-hand side are proteins that are outside and inside a human cell. And the more common subtype of lung cancer people may have heard about is something called EGFR lung cancer, which was discussed earlier. And that is what's labeled as RTK. So that's a protein that gets mutated on the surface of a cancer cell. And KRAS is actually a protein that's right after it. And this entire pathway of proteins all linked together tell a normal cell to divide and persist. So KRAS is actually a normal protein in all human cells. And once KRAS protein is turned on, so that's what I've illustrated here is the KRAS is in purple, and you can see that I put some arrows in. There's an off state of KRAS, which is KRAS, it's called KRAS GDP. So that's when the signaling is off. And then it can shift to KRAS turning on, which is KRAS GTP. And when KRAS protein is more in the on state, that's when it tells the rest of the cell to grow and persist. What I've illustrated on the right-hand side is an actual picture depicting KRAS protein. And the three colors indicate where the 12th amino acid is, the 13th, and the 61. And so this is a schematic just showing what areas of the protein itself can be mutated in KRAS lung cancer. And then when one of these sites is mutated, the entire pathway is on when it's not supposed to be on. So cells are now growing and dividing and persisting when they're not supposed to. And that's when a normal cell becomes a cancerous cell. So the next slide. So it turns out KRAS actually is one of the first cancer proteins that was discovered. So this was first identified back in the 1960s on the far left-hand side, where scientists realized that there was a virus in rats that led to sarcoma, and this led to the development of what's called the oncogene theory. So it's saying that a gene, just a single protein mutation, can turn a normal cell into a tumor cell, and then KRAS was one of the first oncogenes that was cloned. So we learned more about the sequence of KRAS. And it wasn't until 2013 that we actually were able to develop a drug that can actually turn off the mutant form of KRAS protein. And since then, there's been a acceleration of new discoveries in the field. With just last year, the US FDA approved the first KRAS-directed medicine against KRAS G12C, specifically in lung cancer. And since then, there have been multiple other medicines that are being tested in the clinic, not just for KRAS G12C, but other subtypes of KRAS cancers as well. So next slide. So to talk a little bit more about this discovery, here I've illustrated what the actual medicine does to the KRAS protein. So shown in the blue circle is the binding site of the GDP, which is a molecule that is bound to the on-off form of KRAS. And what happens is these scientists were able to find a separate pocket, which is illustrated in the yellow box, that had previously been unknown. And they were also able to develop a medicine called sotorasib that can actually covalently bind, so just lock the entire KRAS protein itself in this off state so that it's no longer turning on. And sotorasib specifically binds to the KRAS G12C mutant form of the protein, turning the entire protein off and preventing the cells from growing and dividing. And so this was a huge breakthrough in 2013 when we were finally able to develop medicines for KRAS. And since then, borrowing upon these principles, we are now developing new medicines for other KRAS drugs. And we're also, or other forms of KRAS lung cancer. And we're also developing not just these small molecules, but other new ways of binding to and shutting off KRAS. And so it's been very exciting to have this new discovery in 2013, and it's only accelerated research and discovery in the field. Next slide. So a little bit about the way that KRAS is diagnosed. So in order to diagnose someone with KRAS lung cancer, shown here on the far left, is an individual's sort of timeline when they present to a medical oncologist clinic. So the first thing we are trying to do is collect a lot of information, and that includes not just the history and physical exam, but an actual biopsy, so an actual sample of the cancer itself. And I've illustrated in the blue box that most people with KRAS lung cancer have non-small cell lung cancer as the subtype. And in order to determine, is it KRAS? Is it KRAS, first of all, and is it G12C? Is it G12D? Is it something else? There's another test called DNA sequencing, and that can be either done off of a traditional biopsy or via a blood sample. And so when that is finally determined, which it takes a period of time, it actually takes not just the medical oncologist, but also a proceduralist like a surgeon or an interventional radiologist, or you have to have a blood test sent to a lab. And then that requires both a pathologist, so someone who looks at the cells under a microscope, but also a molecular pathologist, so an individual who specializes in reading DNA mutations. It takes all of those individuals to make a diagnosis of KRAS lung cancer. And that's why we often tell our patients that it takes several weeks before we're able to definitively say what subtype of KRAS lung cancer someone might have. And if it's possible to wait that long, sometimes it's worth waiting to know exactly what it is, because it helps us more personalize the treatment recommendation. So after that, the patient would come back in and you would start treatment. And what I've illustrated in the blue circle is there'd be multiple clinic visits where you would get the treatment, and we would use either the physical exam or scans in combination and laboratory tests to make sure that the cancer is shrinking or stabilizing. Next slide. And then oftentimes in lung cancer, we do see that the cancer grows at some point, and that's known as acquired resistance. And so when that happens, we kind of go through the cycle again, where we think about, would this person benefit from another biopsy? But generally, we have to think about changing the treatment strategy. Okay, next slide. Just a little bit about the two types of biopsies that we can detect KRAS lung cancer in. The top, I've illustrated the traditional, what everyone thinks a biopsy is, which is called a tumor biopsy. And what that is it's usually a day procedure. There's usually some anesthesia involved in order to get the sample. And this, where at my institution, it's called OncoPanel, but many other institutions or commercial labs also have their own panel, but it's essentially to look for the DNA mutations themselves. And you can also identify the cancer subtypes, such as, is this lung adenocarcinoma, for example, off of a tumor biopsy. And I just illustrated 3 situations on the right-hand side of when someone might ask for a tumor biopsy. First, to detect the cancer, there are research studies where sometimes we're trying to understand what is happening when the cancer is small or non-existent, and sometimes at the time of resistance to determine the next treatment strategy. By contrast, the other type of test where you can detect KRAS lung cancer is called liquid biopsy. And so here, this is a simple blood draw, and depending on where that sample is sent to, some places will just test for KRAS, and then other commercial laboratories will test more genes that are associated with cancer. And you can also get this test at various times during an individual's disease course. All right, next slide. And a little more about this, this blood test, because not everyone may be familiar with this. So what it is it's testing for something called circulating tumor DNA, which is essentially all the cells in someone's body is turning over, including cancer cells. And when cancer cells turn over within the body, the DNA contents actually are shed into the bloodstream. So if you want to go to the next slide. And so the dying cancer cells will release the DNA contents. And then we now have this really cool technology that's able to detect small amounts of mutations just associated with the cancer in the bloodstream, essentially based on a normal blood draw where you would check for your number of white blood cells or your electrolytes. And so this is a test that we now have to detect KRAS lung cancer. Next slide. Just a little bit about the differences between the traditional biopsy and this other biopsy called a liquid biopsy. The traditional tumor biopsy along the top, it's generally a day procedure, and it's pretty good at detecting the subtype of lung cancer. What I've illustrated here is of 100 people who have cancer present, 99 of them are going to have a positive test result. So basically, it's the gold standard. Along the bottom is the liquid biopsy, which is not a procedure other than a blood test, but it's not perfect. So you can see here, out of 100 people, there's about 20 people who have KRAS lung cancer, but that test is not going to be able to pick up the KRAS mutation or other mutations in the bloodstream. And so there's what's called a false negative rate. There's about 20 people. It's probably because those individuals don't have as much shedding of this DNA in the bloodstream, even though they have KRAS lung cancer. Next slide. So that's a basic summary about KRAS lung cancer. It's the most common subtype of non-small cell lung cancer. We now have an FDA-approved medicine specifically targeting KRAS, the mutant form of the protein, keeping it in the off state, called sotorasib, for individuals who have KRAS G12C lung cancer. And there's many more medicines targeted at different KRAS mutations entering clinical trials. And then the other thing to know is that this is detected via a biopsy, and it can be the traditional biopsy or a ctDNA test called liquid biopsy. All right, next slide. So I'm going to talk a little bit about the treatment strategies for KRAS lung cancer as a general overview, and I'm happy to discuss more details at the Q&A. So when I think about lung cancer treatment, I think of it in two different categories. So along the top, along the top are medicines that are called systemic therapies. So they're medicines that go everywhere in the body. And these are classified as traditional chemotherapies, which are medicines that target all dividing cells. Targeted therapy, which is similar to sotorasib, a medicine that just goes off against the mutated cells that have the mutated form of the protein. And immunotherapy, which essentially boosts your immune system to go after the cancer cells. There's also localized treatments along the bottom, which include surgery and radiation being the most common types. And then the other thing to not forget about is symptom-directed therapy. So if someone were to have a cough or constipation, there's medicines directed at that. Next slide. And to speak a little bit about treatments, systemic treatments for KRAS lung cancer, I've listed the most common treatments that someone might encounter in each of these categories. So there's several forms of IV chemotherapy that might be given either by itself or combined with one of the other chemotherapies listed on this column. And those are usually given once on like a weekly, and every other week, and every 3 week, or every 4 week schedule. So those are medicines that are able to shrink KRAS-driven lung cancer. The middle section, the targeted therapy, which now we have sotorasib, our first KRAS G12C targeted pill. We also have these two other IV medicines that target blood vessel growth that sometimes are given in KRAS lung cancer. And finally, KRAS lung cancer does respond to immunotherapy. And so there's several immunotherapies that might also be given for KRAS lung cancer. And then on the far right, there are actually many clinical trials out there. This is probably one of the hottest fields in lung cancer right now. And so clinical trials are an option for individuals who are interested in trying something new or different, something that hasn't been tried and true, but has very promising evidence in the laboratory that it'll be helpful for people. And so there's various clinical trials that are available for KRAS lung cancer as well. Next slide. And finally, I want to emphasize that it's not just about shrinking the tumor, but also there's a lot of, it's important to not forget about both mental health, which significantly affects physical health. So I talk to all of my patients about trying to exercise regularly, developing a support network, knowing who your support network is, and then trying to maintain a routine if possible during this period of time. I think this is very important, and I see Terry is smiling and nodding. So I always want to emphasize this point. All right, last slide. So this slide just gives you a glimpse of all these. There's many KRAS G12C drugs that are also being investigated both by themselves and in combination. But I just want to give a preview of what's coming on board. And this was just a list that I I came up with of all the new medicines that are about to get started in clinical trials of KRAS non-G12C lung cancers. And you can see KRAS G12D, 13CV. There's all these KRAS multi or pan-RAS inhibitors, so medicines that target other subtypes of KRAS lung cancer. And I've just color-coded them based on the many different ways that we're thinking about targeting KRAS lung cancer. So not just a sotorasib-like approach, but other completely different medicines that include those that induce new protein-protein interactions, activate the immune system. And so this is a very exciting and bright field, and we're very excited for the next years to come of developing new effective medicines for KRAS lung cancer. So final slide. So I just want to summarize, there are many, many potential treatment options for people with KRAS lung cancer that medical oncologists will speak to you about, and this includes several categories of systemic treatments, including our first targeted therapy in KRAS G12C lung cancer. There are locally directed treatments, and then to remind you at the very end that there's many new treatments that are being developed in clinical trials for individuals with KRAS lung cancer. All right, next slide. So I thank you very much for your attention, and I'm happy to take any questions at the end and during the Q&A.
I think we can probably head into Dr. Khalil's presentation.
Sure, thank you, and I will start by sharing my screen. I hope you guys can all see it.
Thank you so much, Dr. Khalil. Yes, we're able to see it. I would just like to introduce Dr. Khalil to the audience here. So Dr. Khalil is a thoracic oncologist at the University of Alabama in Birmingham, and she focuses on thoracic malignancies, and we're very excited for her to join us here today to talk about RET-mutated non-small cell lung cancer. Thank you.
Thank you, Dr. Desai, and thanks for the organizing committee to invite me to talk to you about this exciting topic. I would also like to thank everybody who has held on until the last talk. Your commitment and your attention span is not unnoticed. These are my disclosures, and I will start by mentioning to you a case presentation of one of my patients who I encountered in clinic. She's a 57-year-old woman who presented to her primary care physician with non-resolving cough of few weeks duration and back pain. She had a chest scan that revealed a large 6-centimeter mass in her left lung with multiple smaller nodules involving both of her lungs. She went on to have a whole body scan, also known as a PET scan, that revealed lesions in both of her lungs, lymph nodes in her chest, and multiple spine and pelvic bone lesions. And also she had a brain MRI that revealed one small brain lesion, about 6 millimeters, consistent also with a metastatic area. And when we talk about metastasis, it's just a fancy word that we physicians and healthcare workers like to use to describe spreading of a cancer from one part of the body to another. She went on to have a biopsy of one of her peripheral lung nodules, and that revealed that she had a non-small cell lung cancer, with her subtype being adenocarcinoma. Of note, she had never had smoked in her life, and she worked as a teacher, and so she had no known environmental exposures that she could recall. She had next-generation sequencing of the biopsy tissue, and we'll talk a bit more about what next-generation sequencing means in the coming slides, and that revealed a RET fusion with a partner called KIF5B. And she was seeing me for the first time about a year ago for discussing treatment options for her. And just to give a bit of a background about what genetic alterations are to people who have not joined us since the morning. When physicians examine the tumor tissue under the microscope, they can determine the type of cancer that a patient has. but also the changes in the DNA of the tumor cells can be examined. Often these changes can drive its growth. And these changes are what we call mutations or errors or alterations or biomarkers. And there are other words that we like to use to describe these also in the medical field. The DNA is something that you can think of as a blueprint for the behavior of a cell. And so if there's a deviation or an alteration from the normal DNA, it can drive the uncontrolled growth of a cell, leading ultimately to a cancer. And one of the many types of these alterations is what we call a rearrangement or a fusion, where one gene on one chromosome or even a part of a gene can be attached to another one, leading ultimately to what we call a fusion gene, translating into a molecule that drives the division. Most of the times it's uncontrolled division of a cell, leading to a malignancy, leading to a cancer. The two main types of red gene alterations are point mutations, which we don't usually see as commonly in non-small cell lung cancer. We see it more commonly in thyroid cancers. And there are the red rearrangements or fusions that we see more commonly in non-small cell lung cancer. These occur in about 1 to 2% of non-small cell lung cancer patients. Usually the person who presents with these rearrangements is somebody who is on the younger end of the spectrum. There are patients who have no history of smoking. And the most common subtype of non-small cell lung cancer that we see these rearrangements in is adenocarcinoma. These appear to be associated with a higher risk of metastasis of the brain. And this correlates with a lot of other subtypes of mutation-driven lung cancers. We see that across the spectrum of this group of non-small cell lung cancers. The fusion partners, the ones that we usually see are the KIF5B. This is the most commonly seen partner to RET, and it occurs in about 70 to 90% of tumors. And then the other less commonly seen is the CCD6 RET fusion, and it's seen at about 10 to 25% of tumors. There are other partners that we see, but to a much lesser extent as a partner for RET. How do we look for these rearrangements? One of the older ways of looking at them is fluorescence in situ hybridization. You can also hear your physicians and healthcare team talk about something called FISH. What this really means is that we are technically staining different genes and looking at them under the microscope. This is a picture demonstrating how this looks under the microscope in a different fusion gene that we see in leukemias, but it's a helpful illustration. So on the left side, on the normal cell, you would see two different copies of two genes. I'm going to call them the red gene and the yellow gene. And then in the cancer cell, which is on the right side, you can see that you have two copies where the red and the yellow genes are fused to each other. This is what we call a fusion. That was the older way of looking at fusions, and usually we still use it in situations where we have limited tissue, for example. The more advanced and the more widely used way to look at rearrangements is what we call next generation sequencing. That usually uses the patient's tissue. We use a machine in order to do this sequencing of the DNA in the tumor cells, and that gives us information on multiple mutations or biomarkers at the same time. Often we use this to look at large panels of genes, and sometimes we can even look at the whole DNA inside that tumor cell. Another way that was very eloquently illustrated by Dr. Luo is the liquid biopsy or the blood-based testing that looks at the alterations in what we call the circulating tumor DNA, where we isolate that DNA from the circulation that's being shed by cancer cells, and we look at them and sequence that in order to identify the fusions. Now, how do we treat patients who have non-small cell lung cancer with RET rearrangements? There are multi-kinase inhibitors that had traditionally been used back in the days when we didn't have the more advanced medications that we have right now. These are called multi-kinase inhibitors because they have multiple targets, not just the RET fusion molecule. Some examples are cabozantinib, vendatinib, alectinib, lenvatinib, and sunitinib. They were approved by the FDA, and they are approved by the FDA for other indications and other subtypes of lung cancers and even other cancers, such as thyroid cancers. They're significantly less potent than the newer RET inhibitors that we have. However, they did have good responses back in the days where we didn't have the more targeted and specific drugs that we have right now. I'm going to cite an example with cabozantinib. When we used to use this drug for patients who had RET rearrangements, there were studies that showed that people had responses in about 28% of the time, and about 36% of people had stabilization of their disease. The more advanced and more recently studied and approved drugs in the setting are what we call selective RET inhibitors. Some examples are selpercatinib and pralsetinib. They were studied in large trials, and when I say large trials, there are relatively large trials to other drugs, but that's because this RET rearrangement occurs in just about 1 to 2% of non-small cell lung cancer. The studies were Libretto and Arrow, respectively, and they showed that in people who have RET rearranged non-small cell lung cancer that have been exposed to prior treatments, the response rates were as high as 60 to 65%. And in patients who had no prior treatment, what we call treatment naive patients, the response rates were all the way up to 70 to 80% of patients. They also demonstrated that these drugs do penetrate to the brain, and they can even treat brain metastasis. And I'm going to show you a couple slides from the studies that were done on this. This is what we call the waterfall plot from the study that was done, from the trial that was done on pralsetinib. And just to give you an idea of what we're looking at, every bar on this graph is a patient, and the length of every bar basically illustrates the change in their disease burden. And so you will see that on the far left of this graph, there are a few people who have a slight increase in their disease burden, but the vast majority of people have decrease in their disease burden. We have a threshold where we call people that have responses to treatment, and we have to see about 30% reduction in their disease burden in order to call them responsive to treatment. And so there is a large amount of patients, about I would say 60 to 70% of patients who had actual responses to the treatment. And then on the far right end of this graph, you do see a number of patients that had all the way up to 100% of response, which is what we call complete response. These are the waterfall plots from the selpercatinib trial, also demonstrating the same thing, where you have a few people who had progression or increase in the size of their cancer burden, but then the vast majority of patients do respond to the treatment. And you also have a few patients who have complete response of their therapy. On the right side graph, I just wanted to highlight in here that these were the patients who had intracranial metastasis, meaning spreading of the cancer to their brain. And they had, for the most part, also deep responses to these medications inside their brain lesions, which is very important and very reassuring to patients who have brain metastasis. I wanted to also highlight some treatment side effects to the older drugs and the newer drugs. The multi-kinase inhibitors that we used to do, because they had multiple targets, they also had multiple side effects, including rashes, diarrhea, hypertension, often leading to treatment interruption and dose modifications of these medications. With the newer selective RET inhibitors, they have a narrow target, and so they have less toxicities overall. The vast majority of what we see is either hypersensitivity, some hypertension, but not as common as we used to see with the older drugs. And then we also see some low counts in some cases. In the vast majority of patients, those rarely lead to interruption of their medications or the need to dose modify them. And so the take-home points here are that RET alterations are present in patients with non-small cell lung cancer. They are seen in about 1 to 2% of these patients. We do have very good targeted therapy options that are well tolerated, and they have good response rates and durable responses, and importantly, intracranial responses with effect in the brain, which sometimes cannot be affected by traditional drugs. And I would also say that checking for these alterations is the standard of care for all patients who have metastatic non-small cell lung cancer. We do hope that these drugs will be studied in the earlier setting, non-small cell lung cancer patients, and hopefully that would be the standard also to test for this in earlier stages. And finally, I'll put a plug in for connecting with other patients who have RET mutated non-small cell lung cancer. I would highlight the RET positive group, which is a patient advocacy group out there that can provide you with education on these cancers. It definitely is very helpful to provide patients and their caretakers with a sense of community. They could even tell you some patient stories that just illustrate how good the drugs that we have are and how their quality of life is on these medications. And then also importantly, at the time that people experience progression of their disease, where the cancer really outsmarts our drugs, they can also connect you with trials and other studies looking at side effects and resistance mechanisms and other parts of dealing and treating these non-small cell lung cancers that are not inherently studied on traditional trials. And the best way to connect with these groups is really social media, and that is their Twitter handle. And I will thank you for your attention, and I'm happy to answer any questions that you may have.
Thank you so much for that excellent overview. And I really like that last slide that you have in there in regards to support opportunities for patients, because as we know, this is definitely an overwhelming diagnosis, and the more resources we have, the better. So I really appreciate you putting that plug in there. We are going to open the floor for question answers, and I see some questions that have that are just starting to kind of come into the chat here. But I think I will, oh, here we go. This is actually a question for Dr. Luo. So I know right now we have patients that have a KRAS G12C alteration get targeted with sotorasib, but what do you do for your patients that have other KRAS alterations at this time? And are there any clinical trials that you are that you're referring to?
Great question. Can you guys hear me, by the way?
Yes.
I'll make sure, because I turned my camera and video just on. Thank you so much, Dr. Prechigal and Dr. Desai, for organizing this. So that's a great question. There are actually several clinical trials that are about to open or are opening in individuals with KRAS non-G12C lung cancers. I listed them on my slide, but you can also search for them on the website clinicaltrials.gov. And so one example is I know of a KRAS G12D medicine that's just about to start in clinical trials for lung cancer. And if you look it up, you can actually get a sense of what cancer centers might be offering it. There's another KRAS, it's called KRAS multi. So people who don't just have G12C, but also G12D and several other KRAS subtypes, that is also opening up. And so I think the best way to think about this is look at the website clinicaltrials.gov, and then I would engage with your medical oncologist about when is a good time to consider participating in a clinical trial. The pros are for sure trying a medicine that's targeted specific to your type of lung cancer, but the negative is sometimes you have to travel to another center and could be on this medicine for an extended period of time. And there might be certain scenarios where it is appropriate to participate in one of these clinical trials. It's a good time to do so. And then there's other times where it's actually more efficacious to take a medicine that's been tried and true and approved by the FDA. And so I think the best person to talk to about that is your personal medical oncologist about what to think about clinical trials. But they're definitely either opened or opening, and there's multiple other ones that are about to open as well.
And thank you for that. I think that clinicaltrials.gov is a great resource, and I refer my patients there as well. We actually have a question for Dr. Khalil. So in regards to the RET space that you so eloquently spoke on, what are your thoughts about selpercatinib versus pralsetinib?
It's a good question. We get that very often from our patients. I tend to think about them as interchangeable. They have equivalent efficacies. They have very similar side effect profiles. And they have basically equal tolerance among patients. And so the only difference that I see is just in the schedule of giving the medication. And so I think that either or are perfectly fine to use in patients who have RET mutated non-small cell lung cancer.
Thank you. Yes, I agree. Any thoughts about CNS penetration or in that same space, just kind of piggybacking off the same question?
So I think there is intracranial activity for both medications. I think the selpercatinib trial did demonstrate very effectively that in a group of patients who even had multiple lines of prior therapies and had targeted measurable disease in their brain, they were able to show really deep and long responses. So for patients who have brain metastasis that is not symptomatic, meaning that is not causing seizures or weakness or focal neurologic deficits, I tend to even avoid radiation for these patients and use these medications, oral inhibitors, to control their intracranial disease. And I'll just also put a plug for patients who have no brain metastasis at the time of their baseline diagnosis who are on treatment with RET mutated non-small cell lung cancer to be screened periodically with brain MRIs, because that is one of the ways where cancer can kind of sneak up on you, and you would want to know about these resistance mechanisms before they actually cause problems.
Yes, thank you so much, Dr. Khalil. I have a question which I really actually want to know, Terry's perspective, but also Dr. Khalil and Dr. Luo's perspective, because it's a really good question. The question is about the best advice you have for newly diagnosed patients and what should their first steps be.
Do you want me to go for it first?
Yes, please.
Okay, because usually that's where it starts, is like, okay, in fact, at one point we put out a poll, what day of the week were you diagnosed? Because I was pretty convinced it was going to be the latter part of the week, and it was. We had a considerable amount of people were diagnosed on a Friday, which means now I know I have lung cancer. What am I going to do? And that leaves me all weekend to think. And although Dr. Google is one of the most dangerous places that you can go, you do need to connect out with the other patients that are going through it, because that's where you're going to find that amazing four-letter word, hope. You're going to hear from other people that have walked the walk and know what the walk. But the best information I have is the thing that is the absolute hardest things to do. And that's, you need to take the 2-week wait to find out what your biomarkers are to get the best treatment that you can possibly do. And in that 2 weeks, it is the most hellacious type of limbo for a patient, but that is also the biggest gift of time that you have. That's when you can reach out, you can wait, get that information, get that second opinion, start getting the things together that you need to feel that's going to give you a sense of control over what that looks like in your life, whatever that looks like. and really reach out to the other people that you need to hear it from, which I really think is the sense of community and that sense of hope, because it is not, we're not out here to scare you. We're out here to tell you what's really going on.
Okay, I'm gonna go next if that's okay. Thank you, Terry, so much. I think it's very, very important to, during that period that we call the limbo period, while you're waiting for, you know, more information about your cancer, the stage, the drivers, all those other things. This is one of the hardest things that people have to go through. And I think I would just say, find your rock, whatever it is, whoever it is. Whatever you enjoy to do in order to try to process and not just get your mind off of the diagnosis, but just process what you've been told. Find a person who you like to talk to. Find a community that might give you just some information about what you're going through and what to expect. And find something that you like to do in order to stay as active as possible during that period of time and as present as possible in trying to process that information. I find that some of my patients just pick up either walking out in nature or some other form of way to help them through that waiting period that is imperative, unfortunately, in our field. Before we learn more about their cancer in order to get them the what we call right treatment, because every single patient is different. Even if you have the same mutation, your disease burden is different, your symptoms are different, the whole journey that you're going to go through is different. And just find your rock.
All right, I completely agree with both what Terry and Dr. Khalil mentioned. I think it's super important to focus on, you know, who is your support network? Can I continue to try to maintain the same routine that you're that existed pre-diagnosis, whether that be trying to, you know, eat breakfast at the same time, go to work, because I think that really can help tackle the waiting time. And one other piece of advice that I think is helpful, especially for those who do seek a second opinion, is trying to you know, identify a spokesperson, either would it be a family member or a friend, to help you stay organized in terms of your medical records. Because I would love that, you know, all the medical records talk to each other, but they don't always. And so I generally recommend people almost create their own, like, it's almost like a binder, like a CV, but for your lung cancer, and try to collect CDs of the actual pictures of the scans, try to get a copy of the scan reports, try to get a copy of the pathology reports, because those pieces of information are very important for other doctors when they're trying to better understand your type of lung cancer. And I think the other thing to do is for your first appointment, if possible, try to come up with a list of questions that you have, because I think that really keeps the appointment organized and maximizes your chances of getting your most pressing questions addressed by the doctor. So I usually really like it when my patients come with a list of questions. I can look at it quickly and say, like, here are my answers to these questions, or these questions will be addressed. And I think that makes seems like it makes the first few appointments the most productive when patients themselves are prepared and they come with a family member or a spokesperson, because I think that everyone picks up a different aspect of those initial conversations, and then you can go home and regroup and share what you understood and regroup and come back with a second set of questions. And so I encourage all of my patients to do that.
Can I throw one more thing in that suggestion as well? The other thing I would say is give yourself, as the patient, a little bit of grace. Okay, and it's kind of appropriate here too. Give yourself some grace. It doesn't matter how you got it, what you got, you're going to do something about it right now. It's been there for a while. You've got 24, 48 hours. It's okay. Give yourself a little bit of space to breathe with that. And even if you don't get all the information, even if you're going to write down every single question and you're not going to exactly understand it the first time through. That's okay. Ask the doctor again next time. Don't think you're going to get all the answers in one and done, because it is a little bit of a moving target and they understand that.
That is very, very insightful, Terry. And I usually tell my patients, especially that first visit, you are really drinking from the fire hose. You are just getting information from all around, many different information about the diagnosis, the treatment options, all the other things. And it is something that we all realize on the healthcare side of things, that if somebody walks out of our clinic room and they have retained 10 to 20% of what we said, that's a win. And just, you can come back and you can ask questions. And if you have questions, you can just jot them down. And in that second visit, you can come back after you've kind of digested a lot of what was given to you, to come back with questions in more details if you want about things that you didn't ask the first time. So totally agree.
I think that you all beautifully and eloquently answered that question, and I had so many little mini takeaways. I think that, this is a very nice segue to, finding your comfort and finding your, getting back in the saddle and understanding your disease. But then all of a sudden you're up for your first scan, or you're up for your 50th scan, and you have that scanxiety, which is a common term that we hear. And there's a very important question here in regards to how do you deal with scanxiety? How do you educate your patients? How do you support your patients? And Terry, tell us also your experience as well. I'm just curious, do you prefer a scan to be done, not over the weekend? Do you delay your scans to, do it after a holiday instead of before? Or tell me about what you do and tell me about some coping mechanisms. This is an area I think I really could use some help.
It's a really good question, because as much as it is at the front end of the diagnosis, you think, okay, I got diagnosis, I'm doing treatment, it's all good now. No, this is not going away. You're going to be going back and forth for scans. You're in this for a marathon. I'm still at a 3-month scan process, and I know that about myself now, that I'm going to get anxious, that I have to be intentional about doing things like getting enough sleep, getting enough exercise. If I'm starting to let my mind wander onto things that shouldn't be, I need to wear myself out more than usual. Okay, whatever that looks like for me, whether it's playing video games or exercising or indulging myself in a bowl of ice cream. Whatever that thing is, I've got to give myself a little bit of space around it, because it is real. And talk to someone else who gets it. And as much as the people who love you around you think they get it, they do not get it. And that's why I'm such a proponent of the community. My husband, my kids have been here every step of the way, but I need to have a safe space that I can go and I can talk it out with somebody else and tell them that interfere, because I know how hard it is. And like I said, I use the example of the test. I failed tests. I failed my diagnostic tests. And where I feel the failure the most is when I have to go home and I have to look in my family's eyes and tell them that. And it's okay, they're still gonna love me. But if you frame it out in your own mind that I'm not feeling the test, my body's not feeling the test, it's just we're seeing what's there. We're getting to peek at what's there so that we can stay in front of it. And so as those anxiety starts building up, we've got a better chance of staying in front of it. If you're ahead in the football game or whatever the game is, you've got a better chance of winning. And that's really a lot of it.
Well, thank you so much, Terry. And I think, there are so many pearls of wisdom here. I actually have another question just off of that, which is becoming even more relevant now because, as you know, there are a lot of institutions have an EMR and have a patient portal where the scan results, the scan is performed on Friday, the results are revealed, and the patients obviously look at them on the portal, and then, maybe I'm meeting with them on Monday or Tuesday. And, by the time they're in the room, they're obviously, have a lot of anxiety over the last 3 to 4 days. And there have been a couple of instances where I've been like, okay, well, yeah, the scan does say progression, but it's only, mild. I think we are okay. We can continue the treatment. And, they feel so relieved. But I feel like, how do we cope with this? And are there any particular things as physicians that we should be looking into to kind of, mitigate these kind of situations for our patients?
Well, and that tells me what a great doctor that you guys all are, is that you care about that. Because we do care as the patient and we want to know. And each person, I've talked to patients that could fall on any different side of the equation. Some people want to do it before the holiday, some people want to do it after the holiday. But once you've done it, now I want to know. Because I'm completely, the minute I finish that scan, I'm completely convinced. Okay, for example, I had to take a COVID test at one point. Okay, in the 15 minutes while I was taking that COVID test, I was completely convinced I was dying from COVID. Oh my gosh, yeah, I have had a tickle. Maybe I have been tired. Okay, until the whole thing came back was negative. That's kind of what's going on in our mind and our heart, that we've already got it. So to me, there's no such thing as a little progression. Okay, it is, what am I going to do? I'm going to be doing something about it. So how can I best mitigate it? That's kind of an individual thing. And I think it would be a great piece of information to have for each physician, that they put it on their chart. Does this patient want to know right away? I learned the hard way, don't get a test. Don't get a CT scan when my doctor's on vacation, because I had to wait a week. My family was about ready to lock me in a room, okay? Because I had to wait, because there was nobody backing her up so I could get the results, right? And so, those little pieces of information are crucial to us. And so if we know that going in, and what it is we're looking for, right? Because it is on a personal basis.
Yeah, all the points that you guys are making are very important. And we've all, on the healthcare side of things, we've been through these conversations and these discussions where patients actually get a preview to their scans on the portal, for example, before we have the chance to talk to them. And the way I have learned, and we all are learning, right, throughout life in general, the way I've learned to do it is when I know that there's a scan coming up for one of my patients, I first ask them, do you want to have it done before your birthday, after that event? When is the timing going to happen? And then we schedule it that way. And then I usually try to schedule the scan and the visit with me on the same day, where they have a visit after the scan happens. And then if that is not possible, I try my best, to the best of our ability with the limited time that we have, to actually call them with the results ahead of that weekend or before whatever event is happening. And then at the back end of things, if I forget, we are all humans. If I'm away, if whoever is covering doesn't have the time to call my patients, I always ask them, not just call us. Send a portal message, just ask us, what are my results? How do I interpret my results? What are the things that I should look out for? And even if the scans are stable, or even if the scans have good results and things are actually improving, there's a lot of medical jargon there that patients don't necessarily understand and don't have to understand, and that is an enough stressor. So for all the points that were made already, and our own experiences, this is how I go about it, and based on basically patient interactions.
Yeah, I really like the answers that have been discussed thus far, both about scanxiety and use of the portal to look at reports. I guess there's a couple other things that I consider as well. I liked Terry's point about thinking about it as a football game and planning in advance. And I think that even though I understand from the patient's perspective, that's the one piece of data you do not have, which is, what does my scan look like? by contrast, on the doctor or the provider's perspective, we actually, in a lot of circumstances, care more about what is the physical exam, what are the symptoms that you're having, and what are the laboratory results, rather than the scan. And the scan gives us a little bit of information, but I would say symptoms and what's been going on the past couple weeks, that actually is more important to us when we actually make a decision. And so even though the scan on the patient side feels like that missing piece of information, since you've lived with your symptoms for the past couple of weeks, the actual contribution of data that that scan provides is usually quite small in a visit. The other thing that I would once again encourage people to try to do is to try to, if possible, bring an extra person to that visit, or see if there's a family member or a friend who would be available via speakerphone, because I think those scan visits, sometimes after discussing the results of the scan, it's hard to be in a good state to hear what else the doctor is recommending. And I speak from personal experience of getting scans myself for medical conditions as well. And so I think having that second set of ears is very important. And then in terms of advice on looking at the report, I know it's hard to resist looking at the report before speaking to your doctor, but I actually highly recommend that to people, because I think for sure there's a lot of medical terms on there that just mean this is fine, or this is a nodule, or this is a scar, or this is a normal organ that's shaped a little bit differently, but the terminology itself can look very scary, or mean something different in normal plain English than it does in a text report by a radiologist. And the other thing to think about, most of us practice at an academic institution, is generally, you may have heard of the July effect. And so in July, there's a lot of new people coming on, like trainees, new doctors, new people in a new role. So I have seen that in July, we do see the terminology being used in scans to be a little bit different. And so I think for all those reasons, I think looking at the scan report text before talking to your doctor who's seen you for many more visits is maybe not as useful as you might think. And so I'm okay with my patients looking at their scan reports after talking to me about the results, but I think it's probably best, if possible, to resist looking at the text report before you talk to your doctor.
Dr. Desai, I think you're muted.
I was going to say, I totally disagree with that. I'm sorry. Because I think what happens is it depends on where you are as a patient, where you are in your kind of like knowledge space. The more informed and the farther you are into it, the more you've learned how to read this. And so I am 100% of the patients that I care about. And so now 5 years in, I can read, I know my report. I know my inside and out, right? And I know, okay, well, maybe they're going to consider this, this is good or this is bad or whatever. If you're brand new at it, totally new game. Definitely you need to resist that urge. But I think that it once you become educated about it, and I love being able to, I think that it does foster an opportunity for us as patients to learn how to learn with our doctors, right? And so, okay, in KRAS kickers, the KRAS is more than a biomarker, it's an acronym. KRAS knowledge, research, advocacy, and survivorship. And part of all of those things, you, my doctor, are the knowledge part, right? You're doing the research and let me advocate for my survivorship. And I think as we work together to do that, that's really when the beauty of it all comes together for us in fighting our lung cancer.
Yeah, and I totally hear and agree with your perspective. I guess I was thinking more from like an individual who is not as knowledgeable as you are, or informed, or takes this sort of initiative. I feel like in general, that's my general advice. But I definitely encourage my patients to engage and participate. And I love it when people have questions and thoughts and ideas, and speak up with what they're interested in or what their opinion is, because I think that definitely helps me decide and work with patients on crafting the best treatment for them. So definitely advocate for that.
And thank you for that discussion. I think, Terry, what you're bringing to the table is that every patient is different and has different wishes and different desires and different experiences. And there are some patients that, will not read a scan because they don't know how to interpret it. It causes anxiety, or they don't want to know, or they just don't want to think about it till they walk into the door. And there are some patients that, like know every detail and know what, an increase in SUV is, or that we're following an adrenal nodule, and they get it. And I appreciate all those different types of patients. And I think you just need to know your patient and know what, and know what they expect and what they want, and try to find a middle ground somewhere so that they're not sitting, with anxiety without having questions answered, but they're feeling like they're part of the team. So thank you for that discussion. There's actually some questions coming in the chat. One is specifically actually for sotorasib, for Dr. Luo. So this patient is talking about timing. They've been on sotorasib for almost a year, 11 months actually, and unfortunately is having progression. But clinical trials are limited, especially for patients with kidney disease. So she or he is just curious about any advocacies or any programs that are getting compassionate access. And this kind of piggybacks on a question that we have in regards to adagrasib, which I know was just presented at ASCO by Dr. Sabari, and also some work that was just published in New England Journal and came about 2 days ago about adagrasib for patients with KRAS G12C. And what are your thoughts about sequencing them, and would this patient be a candidate for that? I'm just curious if you could kind of answer some of that.
Yeah, no, thank you. And I think it really depends, once again, on engaging with your doctor about exactly why someone's kidney function might not be completely normal, because there's a variety of reasons someone might have kidney dysfunction, including simply being dehydrated. And so I think definitely talking to one's doctor about it. I think the other thing is, in terms of these pills, and not just sotorasib, but also, like when we think about EGFR lung cancer or ALK lung cancer, all of these pill medicines, the dosing can be adjusted or held, and you really, and people still do quite well on lower doses of medicine. And so I think engaging with the doctor about what is the right dose of sotorasib for me in the context of the other medical conditions I have, whether it be kidney issues or other side effects that you might have, or other concurrent medical conditions. In terms of what other treatment options are available, I think, as I presented in the slide, the good thing about KRAS lung cancer is there's a lot of different treatment options available. And so it might be time to pause that KRAS medicine and try a chemotherapy or an immunotherapy or a combination. It really depends on your form of KRAS G12C lung cancer, whether those strategies are the right strategy for you. And sometimes locally directed treatment, not being on a systemic medicine, is the best choice. So I encourage someone to engage with their doctor about that. The second thing to talk about is this upcoming other G12C medicine called adagrasib. And so this is a similar medicine to sotorasib, and the data that was presented last month on this medication suggests that it has similar outcomes, and that there were individuals who had slightly more GI-based side effects, but sometimes those side effects are related to the dosing of the medicine, but I think generally the community agrees that these medicines are similar. In terms of whether someone would consider one or the other, I think they're very similar medications, and so I would engage with your medical oncologist once that medicine is FDA approved, which one they would want you to take. And there's actually a variety of other KRAS G12C directed medicines that are being investigated in the clinical trial setting. One thing that was presented at ASCO that I forgot to mention, and Dr. Prishigul mentioned, this was discussed by Dr. Sabari, is that there was some data presented that the adagrasib medication can lead to responses in the brain. So KRAS G12C cancer that's spread to the brain, leading to shrinkage there. So I think it would be good to know what sorts of data is out there for sotorasib as well. But as new KRAS G12C inhibitors get developed, I think it's good to talk to your doctor about what the next step is right for you. And it might not be a clinical trial quite yet. So.
Well, thank you, Dr. Lo. I think, like you mentioned in your talk, I think pretty exciting times for KRAS mutated subset of non-small cell lung cancer with so many therapies and options in the pipeline. There's another question, and I will direct this to Dr. Khalil. More of a general question, I would say. It says, assuming someone has done well on a targeted therapy and has minimal side effects, at what point is progression enough to consider changing treatments? And then after Dr. Khalil, maybe Dr. Luo, you can also mention what your thoughts are. Thank you.
That's a good question. I think we have to individualize. Like, there are patients who do great on targeted therapy and at some point start having one lesion increasing in size and progressing, and the rest of their disease being stable. This is what we often label as oligoprogression, which Dr. Florence Duma addressed earlier today. In those situations, it might be best to do targeted approach treatments to that progressing nodule or lesion, things like ablation or radiation or local therapy like a surgery might be enough to take care of that particular progressing area while continuing to be on the targeted therapy to suppress all the other areas and keep them under control, particularly if the patient is tolerating the drug well. In other situations where you have multiple sites of disease increasing in size and clearly progressing, in that situation, I think the best thing to do is to interrogate those progressing areas better. And when I say interrogate, either if it's safe to do a biopsy of one of these areas, try to figure out why we are having progression and what are some of the ways that the cancer is resisting the drug that's already on board. The best way to do that is with a biopsy of the tissue. But if that's not possible, or if you don't have the luxury of time to do it, and the patient is symptomatic, you can even do a liquid biopsy and try to capture some of the clues that we can get as to what is causing or driving the multifocal progression that a patient may have, and then addressing or adjusting the treatment accordingly.
Yeah, I thought that was a wonderful answer by Dr. Khalil. I think a lot of it, just like she said, is we're trying to decide, is this just a few sites that are growing, or is it all the sites that are growing? And I think if it's a few sites and there can be locally directed treatments, we might prefer to do that rather than switching therapies altogether. So thank you.
Yes, thank you for that. I know that we actually have a question here that I think should be answered by everybody, but we can start with Terry. Terry, I know you had mentioned that you have kids and your family has been very involved in your diagnosis and in your treatment course all the way through supporting you. But how do you talk to your kids about this? How do you involve them? maybe you can give some insight about your experience, and then I'd love to hear how Dr. Luo and Dr. Khalil, if they how they talk to patients' family members and involve them.
You know, that's a big question. It really is a really big question, because the same as every patient's different, every family member is different, and so is like the dynamic within it. And you know, and so with my kids, and like I said, my kids are adults, and it's a completely different thing than if I was dealing with a 10-year-old or a 6-year-old. And sadly, that's an awful lot of the cases that people are having those situations. And I can't speak to that because I haven't had any personal experience with it. But it does boil down to the way they understand it and giving them enough information the way that they can process it. My son wanted to drink from the fire hose. He's an engineer. He wanted all the information. Then he wanted to go online and just bury himself in and come up with the solution. Okay, like all of a sudden he's going to become Batman or something. And there was really, the solution was online and he was going to find it. He needed that for his way of being able to find the peace. But my daughters needed it in a totally different way. And so I really think it does boil down to sitting down and having that time. And the same as you're not going to get all the information from your doctor, or even if you get the information from your doctor all in one sitting, you can't grasp it all. You need to kind of like be able to marinate on it, and you need to give them the space to do that as well. And a lot of times they're going to ask you the question that's the hardest. And they're like, what are you going to do? And I don't know what I'm going to do. I'm trying to figure it out with the doctor. And this is always during that 2-week limbo time. And so as much as I can't recall who said, you know, kind of find find a normal, there is no sense of normal over those 2 weeks, and just kind of accept the fact that it's not there, but enjoy that piece, because right now that is where you are, and be here in the moment and recognize that your family may get mad. They're mad at the cancer. They're not mad at you. And if your family members realize that the patient is mad and frustrated with the cancer, they're not mad with you. And so there's kind of that parts of it, but it still boils down to just the person within the personalized medicine and who's going through the whole treatment.
Totally agree, Terry. I think my approach to how to talk to the family is, first of all, just ask the patient, who do they want to involve from their family, from their patient, from their friend group, from their support group. And you know, with COVID during the pandemic, we had policies that allowed only one family member in the room, and sometimes we're even more strict than that. During that period of time, I think I and many other physicians, we had a lot of family members on like the phone, speakerphone, sometimes multi people conferences on the phone in that visit, and just ask the patient, who do you need to be around you during those visits, especially the first few, where we're trying to kind of get all the information and try to process it. And then who do you want me to reach to if you are not in a situation where you can get all the information, or if you are not in a situation where you can make all the decisions for yourselves, and ask those questions. These are hard questions to ask when you meet a patient and you haven't had that like long-term relationship with them, but it's okay to ask. And they may not have an answer, they might not have a point person, but that's okay. And that just gives them the opportunity to think about these questions and then come back and identify those point people that they want in their circle to be involved with their care and with decision making in case they are not able to do that. And just to have those conversations early on where, okay, what do I do if you know, I'm not able to make those decisions, and what are my goals besides just treating the cancer? What am I shooting for? Do I care more about quality of life than quantity of life? Have those discussions. What are the things that I have to prepare my family and myself and my other life situation to adapt to this new normal? That it's not normal. It's just the new reality of things.
I absolutely agree with, and I really appreciated Terry sharing her perspective and Dr. Khalil's perspective on getting a sense from the patient, which family members and how to engage with them. Two other thoughts I had were a lot of the times going to speak with a social worker can be quite helpful. I think the social workers generally have resources, especially on how to deliver the news to children, and might give patients additional ideas or suggestions. I think it really depends on the age and the maturity of a patient's kids, but I've found that oftentimes, when appropriate, bringing a teenager to an appointment, actually, if possible, given the COVID restrictions, to one of the appointments actually can be helpful, because when they're physically in clinic and they see their parent talking to the medical oncologist, they see what happens during treatment. I think it just physically being at an appointment has helped a lot of kids of patients that I've had. So that's something to consider.
Absolutely. Yeah. Thank you so much, Dr. Luo and Terry and Dr. Khalil. Just kind of on the topic of, bringing caregivers with you and just kind of involving them in your care. There is also a question, and I think I'm also very curious to know about, maybe Terry, you could perhaps answer these. Are there resources for caregivers, and how do I find them? And then also kind of, if you can speak a little more broadly about other patient-specific resources on different type of groups for different type of lung cancers, as well as how someone can find a specific group. Thank you.
For sure. Okay. Well, almost all the biomarker groups, almost all the biomarkers have a group. Okay. So with KRAS, we've got the KRAS kickers. There's the RET group, the EGFR resistors, ROS1. I mean, they're all there. I'll be happy to put a link in there so you can pull them all up. But they're very out there. And a lot of us, like at KRAS, we do more than just lung, but you also run into other patients that are in there. And those aren't just for the patients. Those are for the patients and the care partners. And there is, boots on the ground information there. Okay. As far as, whether it's you can't deal with the mouth sores in, a Saturday night, and this is an emergency room visit, and your doctor's off for the weekend. Okay. And being able to talk to somebody else, and it's and then you just hear something like, oh, they use baking soda and water. That sounds pretty lame. I can try that too. Those sorts of pieces of information are the real life part of living with the cancer, because it's not just about the diagnosis, it's about living with it. And so for those care partners and for that circle of care, yes, those resources are there. There are Go-To Foundation, the KRAS kickers, EGFR resistors, the ALK positive groups, all these different groups, we have that, and we help with each other in those sources. And if you're going to start there, that would be the fantastic place to start. As far as phone mentors and that sort of thing, I think the Go-To Foundation does an excellent job, and we help work with them in those things. They connect you to the other groups. We all work within the same space because really we're about the patients. And that's why if you're patient-centric, that's why I think I look from the patient centricity out, which is from that point of view. Did I answer that question?
Perfectly.
Yes, perfectly. I totally agree. Just another question, and I think this also, we often get asked this question by our patients, and so I think this is a very appropriate one for this forum here. In terms of nutrition, which dietary supplements or types of diet can patients benefit from in improving therapy outcomes? Dr. Khalil and Dr. Luo, if you want to start.
I can take a stab at that first. So what I tell my patients is there is, and most of the time they come already with information about, okay, is sugar okay? There's a lot of literature and studies out there about, you know, carbs and sugar and cutting down and all that. We live in the US. There's no way that you're going to eliminate sugar from your diet, but you can cut down. You can decrease the portions of a processed sugar. You can decrease the portions of carbs. I always encourage my patients to increase their intake of proteins, whether that is meat-based proteins, chicken and fish and other stuff, or even plant-based proteins for people who just don't eat meat. I myself, I'm Lebanese originally, so I come from the Mediterranean area, and I'm very biased towards Mediterranean diet. It's very heavy on proteins and kind of vegetables and fruits and other stuff. So coming with that background, I think helps to kind of understand that nutrition is a very important part of the day-to-day things and decisions that patients have to make. And the other thing that I also advise is, if you have some decreased appetite, share that with your physician. We do have medications that can help with improving the appetite while we wait for the drugs to work on the cancer to help with that as well. If you have certain side effects, or if you're having some sort of intolerance to just regular diet, you can alter your diet. You can do pureed or soft diet. You can supplement that with multiple types and brands of supplements that are high in proteins and low in sugar. And the information is out there. If you can't get that information from your medical oncologist or your provider, you can reach out to a dietitian. You can reach out to your community of other people who are dealing with the same thing, with the patient advocacy group. The information is out there, and I think it's important to look at that.
Yeah, I absolutely agree with what Dr. Khalil mentioned, both about looking for resources, and I'm so glad that Terry spoke about, you know, the different groups of resources out there. The other thing that I would add to that is, I think it is important, now that we have good treatments for lung cancer, to consider your other medical conditions. A lot of our patients with lung cancer have diabetes or heart disease, and oftentimes it is important to maintain a diet that can help with those other medical conditions. For example, if there is uncontrolled heart disease, it becomes much harder for us to give you medicines for your lung cancer. And so being aware that not to forget about the other medical conditions, especially heart disease and diabetes in individuals who also have those medical conditions, is important when considering nutrition, if possible.
Can I just throw, I mean, I'm not a doctor, I'm just a patient, but let me, boots on the ground point of view on this is, if you've always hated fish, getting diagnosed with lung cancer, you're not going to start loving it. And so don't beat yourself up about it. So try and eat more healthy and make more right decisions than wrong decisions. But the important thing is you must eat, because if you don't eat, you're really going to be in trouble. Would that be a fair enough assessment? And stay hydrated.
That's perfect. And I just want to tell you, you are not just a patient. You are an important panelist here, and you are teaching us and the rest of the, you know, the listeners on this line. So please, you never say that again. You are so important, and we are learning so much from you. So thank you. And I totally agree. Like, the hydration thing is really important. Just eat. You know, I try not to, you know, now's not the time for a crash diet, liquid diet, NutriBullet. No, don't change your habits. Just eat a normal food. Eat food. That's just the most important thing. Don't lose weight, and eat, and just do your best. And, you know, I think we'll support you along the way. But I love that fish aspect.
Well, and at the same time, many of us gain weight. I thought, great, I've got lung cancer. Now I'm going to go to treatment. I'm going to lose that couple of pounds I always wanted to lose. No, I gained weight because of all the steroids. And I didn't do lung cancer wrong. I just didn't understand that that's what was going to happen. And I think if we don't prepare ourselves for that, I watched a friend of mine, another advocate on TikTok, and she's like, and if you gain weight, it's okay to go buy a new pair of yoga pants. It's okay. And don't stress about it and worry about it, but do eat.
Yes, absolutely, Terry. Thank you. I was just gonna say, I think that, like, I completely agree with Dr. Prishigol's comment. I think we're not on Zoom and we don't have these emoticons where you could see my hands clapping, but I really love all the pointers you're giving us. I think this is so much important for us. Sorry, Dr. Khalil, didn't mean to interrupt you.
Oh no, that's okay. I was just gonna say I tell a lot of my patients that we're humans and we tend to eat for pleasure, but sometimes cancer makes you lose that appetite and lose that pleasure that you derive from food. And sometimes it helps, sometimes it doesn't, but you can start thinking about your food differently. It is nutrition. It is kind of another medication that you need in order to keep going and to continue with your day-to-day activities while keeping that cancer under control or getting to keep it under control. And so sometimes that helps. And if you're not able to do it on your own, we do have medications to help, and we do have other ways to help. There is, we call it in our institution at UAB, we call it supportive care. It's a group of doctors and nurses that are also called palliative care in other institutions. And they are a very valuable resource for our patients. And I do acknowledge that as medical oncologists, we have a bias or a tendency to not involve them as early as possible. I try to think of involving them as early as possible in the care of our patients, but they are also a very valuable resource to our patients for questions about diet, for questions about how to cope with my diagnosis, and a lot of other things that come up while dealing with the medical aspect of cancer.
Thank you for that. Yes, you brought up supportive care, which is a huge resource that we should be bringing in as early as possible. The data has shown that they really improve quality of life and enhance survival as well if we bring them in early. So thank you for that. In the interest of time, I realize that we're actually over. And while I could speak with all of you forever, it is Saturday, it's a weekend. We want to enjoy our time, focus on quality of life, and enjoy this weekend with our families and our friends. So I don't know, if any of you have any closing remarks before we bid adieu, and we will absolutely make sure that all questions that are put in this chat, please put your email. We will address them. Maria and the rest of the RACE team will get to them. And after you all have your closing remarks, I'll give our closing remarks, and then we will say goodbye. Anything from any of you on the panel? Last words?
I will say a last word, because this is really what it's all about, is being willing to hear other people and connect with other people. So the patients that are listening in and the care partners, thank you for being here, because you want to become informed in order to advocate, and this knowledge is incredible power. So take this back and understand it and process it. So thank you guys for all being here, because this is where the hope comes from, is by getting this knowledge and sharing it with each other, and then a sense of community. So thank you all for having me, and thank you all for being here.
I would just add that it was my pleasure to be part of this panel. This was one of the special panels I've been part of. And thank you for inviting me. And I would echo what Terry said. We are all advocates for our patients, but I think just getting out there and trying to get into those communities that can provide you with support from, the perspective of whoever is going through the journey similar to you, I think that is just an invaluable resource.
Yeah, I completely agree with both Terry and Dr. Khalil. Thank you so much for having me on this panel. I've learned a lot, and it was great to share this time with you all. And I totally agree with more knowledge is power. So thank you.
Great. Well, I will wrap things up, and thanks to all of our incredible panelists. We have learned so much from all of you. So if you're still on here, hello and thank you. We could not have done this without you. Special thanks to Dr. Desai, my co-host, who helped me organize this, and also thank you to the Grace team for hosting us and having us and helping us organize this tour de force event. But most importantly, thank you to all of those that are on the line listening, that joined us, that took time away from your families on a weekend to learn a little bit more about lung cancer and share your thoughts and questions. We have learned so much. So stay tuned for our next meeting, and I hope you all have a wonderful weekend. Okay, take care. Bye.